solutions and way forward, bringing more than 500 experts from the entire ecosystems of IVF to discuss the critical issues and find comprehensive solutions. The 6th edition will focus on in-depth information on the complete ART procedure, precautions and awareness, infrastructure and insurance challenges, building awareness on the entire process of IVF to bring new hope and resilience for all the couples. Welcome to the 6th IVF Summit and Award.
Today, ladies and gentlemen, we aim to share clinical, policy and entrepreneurial insights, spotlight Tier 2 India and bring new IVF voices to the table, discuss climate-smart reproductive care, reflect on gaps, legal, male fertility and gender that need urgent redressal, and finally, celebrate excellence through the India IVF Awards 2025. As we reflect on the scale and significance of today's gathering, the 6th edition of India's premier IVF Summit, it is only fitting that we take a moment to honor the visionary institutions who have made this possible. This summit is not just a platform, it's a movement driven by science, policy and compassion, and powered by those who believe in building a more inclusive, accessible and patient-centric future for fertility care in India, and would not be possible without the commitment and partnership of our sponsors and supporters who believe in advancing quality and equity in IVF care. We are proud to host this event in association with ISAR, the Indian Society for Assisted Reproduction, an organization that has continuously advanced standards, ethics, and education in reproductive medicine. Their support brings unmatched credibility and depth to our dialogue. Our special segment, the Sustainability Hour, is brought to you in association with the Indian Fertility Society, a body committed to long-term systemic impact in fertility care and reproductive health. We thank them for their thought leadership and guidance. We are also delighted to be joined by two esteemed session partners, Gufic Life Sciences and JB Pharma, whose pioneering work in fertility-focused pharma and innovation continues to elevate clinical practice across the country. A heartfelt thank you to SafeTree, our fertility insurance partner, for integrating reproductive health into financial and insurance frameworks, a conversation we deeply believe must be mainstreamed. We also welcome FIBE, our healthcare finance partner, whose commitment to enabling affordable and timely access to fertility treatments reflects the very theme of this summit, care without compromise. Our sincere gratitude to Trust Legal, our legal partner, whose expertise in ART law and patient rights has helped shape critical dialogue around ethics, surrogacy, and regulatory compliance in the ART ecosystem. And finally, a big thank you to our communications partner, Teamworks, whose efforts in amplifying today's voices across media and digital ensure that this summit's impact resonates well beyond these walls. To each of these partners, thank you for your belief in this vision. Your support enables more than just an event. It empowers a national conversation. Can we have a huge round of applause for all our partners? We begin today with the powerful keynote foray by Mr. Kamill Narayan, CEO of the Integrated Health and Wellbeing Council. He is one of the country's most influential leaders in health communication, patient advocacy, and sustainability in healthcare. With a distinguished career that spans over 15 years, Kamill stands at the confluence of media, public policy, and systems transformation. He began as a health journalist, but quickly emerged as a nationally respected voice who not only reported on health issues, but began changing the way India responds to them. At the helm of the IHW Council, he has built one of India's largest health advocacy platforms, convened over 150 multi-stakeholder summits and campaigns, and led groundbreaking dialogues on fertility access, reproductive justice, mental health, rare diseases, digital health equity, and the critical climate health intersection. He is the driving force behind impactful initiatives like the India Health and Wellness Summit, Sustainability Hour, and of course, the India IVF Summit, which today enters its 6th edition under his visionary leadership. As a columnist and public commentator, his writings have appeared across leading national publications where he consistently advocates for equitable, inclusive, and preventive healthcare systems. His thought leadership brings urgency to neglected issues, challenges silos in medicine, and champions the health rights of communities often left unheard. Kamill believes and reminds us all that health is not a privilege, it is a fundamental human right, and that true change only happens when communication is not only credible but also courageous and compassionate. Please join me in warmly welcoming to the stage a change architect, a bridge builder, and the heartbeat of today's summit, Mr. Kamill Narayan.
Thank you. It was rather very long introduction. So, good morning, everyone. The leaders of our country's IVF sector. I refrain from using the word industry because when you call it industry, it becomes more of a trade-oriented practice or something which is only driven towards generating revenues or providing services. So, the leaders of IVF sector of our country who have gathered today and will be joining us over the course of the day. First and foremost, to all of you, a very happy World IVF Day. This is the day which reminds all of us that this practice, this one of the most, I think, amazing and most innovative, something which has shown the power of science, that something which was only to be intervened by the God, now our doctors can help people to get the bliss of parenthood. This was something which maybe for generations people would have gone to the temples to the various religious, spirituals, gurus to get this blessing, something which science can make available, science can help all of us. IVF Summit, when we began in 2020, that was the year of COVID's first wave, or for so to say that the time when the biggest preoccupation for all of us was COVID and the COVID generated existential threat which we had. And at that time, not only about IVF, but so many other critical disease areas or patients found them stranded, whether they were for cardiovascular issues, for management of many NCDs, or for cancer care. The continuum of care really got disrupted at that time. And so was the situation for something called IVF. It might have been, and it is painful to understand, recognize and accept sometime that this particular area still remain somewhere at the least priority of our healthcare system, and many times those who plan our healthcare system. For them, this may not be something which is as critical, as pressing as many other diseases which create major problems, challenges, or take the toll on our life or our ability to live productively. But IVF, despite that all this neglect which we see sometimes, is still something which bring the most critical ray of hope, the most critical intervention, something for people, for the humans live for, the right to procreate, the right to continue their bloodline, the right to have children, the right to have parenthood, to enjoy the parenthood. This is something which is most ingrained and inherent and natural for all of us. Absence of which can lead to multiple other areas. We are seeing several burden which are an outcome of whether they are social burden, whether this is mental health burden, a lot of other areas and issues which we see in the families, in the society, stem out of this problem called infertility. The whole infertility, we just heard that one of the focus of this summit is going to also look at that the role and then the share of male infertility. By default in our country, infertility is assigned to the women, which lead to multiple other challenges and issues for them in terms of having a respectful, dignified life within the family, within the society. So when we look at IVF Summit and when we work towards the health in ISW Council, the focus for us is not who is providing this. That is important aspect. But the focus for us always is that who is the beneficiary of it. And the beneficiary of every aspect of healthcare has to be people. People like you and me, our children, who need to have the best possible, not only healthcare, but all that which helps us live a healthy life, life where we can realize our true potential. And that's where ISW Council has been advocating for good air, good food, good water, good living, good healthcare for all. Healthcare for us comes at last because we believe that those 4 fundamentals, if we are able to address, we will have lesser burden for healthcare. And then the healthcare will be able to more efficiently address that. The challenge sometimes we face is that our more attention go to the healthcare and we get into the vicious cycle of making more people sick and go to the hospital, and then have a bigger burden for hospitals and not being able to address as much, which leads to the further aggravated situations. Today also we see when it comes to infertility, it is not just infertility is coming because of the choices of our life. Many times those are attributed to the people that it is because the choices which you make, the lifestyle which you live, leads to you to further multiple diseases or conditions like this. This is also because of the environment we are living in, the nutrition which we are not getting. So all that, so when it comes to fertility care, it is not, the solution for us is not only lying in IVF. It is much beyond that. But IVF certainly is one thing where you have been, kind of bereaved of or stripped of other things. IVF can certainly help you get that bliss of parenthood, can give you an opportunity to live with respect, with dignity, with fulfillment within your family, within the society. So that's where this sector, the people, the doctors, the paramedics, the pharmaceutical companies, the patient advocates, and all those who are working to strengthen this are worthy of a salute from us. And we again, once again, wish them a really happy this World IVF Day, and also exhort once again to all of them to look at IVF as something which is the service for the society, which is something which is as critical as bringing a cancer care to a patient, and not look at it just as an industry, limited to the numbers. I feel sometimes bad when I hear the word the mushrooming of the clinics. The word mushrooming somehow has a negative connotation for me. They are not mushrooming. We already are providing lesser than 1% required, care maybe for the nearly 30 million couples who still are looking for parenthood or facing challenge in that. So the mushrooming is not the challenge. Mushrooming is adding access. The challenge is how ethically, how compassionately, and how responsibly they will be providing this intervention. And that's the responsibility of all of us, the leaders, the companies, the large players who have brought this sector as an organized sector. We are seeing the massive valuation which is being generated for many brands in this. They all have a great responsibility to ensure that this, one of the most important, scientific marvel is not defamed or assigned with a lot of those doubts and suspicions and sometime that negativity which we see prevalent in many cases. So thank you so much all of you for joining us. We are looking forward to an insightful day today to understand the various aspects and hopefully drive this message of compassion and empathy for the people who need this care wherever they need and wherever they are. So thank you so much for joining us, and also thanks for all our partners who have extended their generous support to help us bring together and continue this advocacy for time to come. Thank you.
Thank you, Mr. Kamill, for your insights. Before we move to our first panel of the day, we are honored to welcome a valued partner and one of the strongest industry voices in the fertility space, Bharat Serums and Vaccines. BSV has long been a trusted name in reproductive health, supporting not just science and innovation, but also access, education, and equity. Their commitment to fertility care in India spans decades, and their role in enabling clinicians and patients alike is both deep and wide. To share a few thoughts on BSV's vision for India's fertility mission and how the industry can work together to build a more inclusive ecosystem, please join me in welcoming Ms. Bhavna, Vice President, Corporate Communications, BSV. We welcome you, ma'am.
Good morning. Firstly, let me tell you that I'm stepping in for our Managing Director and CEO, Mr. Sanjeev Navangul. Unfortunately, he has a personal exigency and he couldn't make it to this summit. However, he sends his best wishes to Kamill and the team here. Very quickly, I head corporate communications for Bharat Serums and Vaccines. We are a Mankind Pharma Limited group company been in women's health, fertility, emergency care, and critical medicine for almost 5 decades and counting. Bharat Serums and Vaccines has been making pioneering efforts in building the women's health landscape in the country. Before I start, I just wanted to very quickly tell you guys that somewhere 47 years back, in a very small town called Oldham in Greater Manchester, little Louisa Brown was born. And she is the first IVF baby in the world, born today, and therefore we celebrate the World IVF Day. Lots has happened since 1978, and very quickly, the IHW summit, which started in 2020, like how Kamill said, was one of the first platforms which actually began serious discussions on IVF. In 2020, they came to us and we believed in the intent and their vision to start conversations and responsible discussions on IVF, on a voice that not many were hearing, and on a topic that many would frown upon. So from there on, many strides have been taken. Conversations have moved, from a regulatory landscape to policy advocacy, all of that keeping what infertile couples and patients require and need. So I think all these conversations have kept the patient at the center, but they were driven by many factors, and one of the biggest factors that drove these conversations is the scientific and medical advancements that have really touched the entire IVF sector, Kamill. I'm not using industry. So let me very quickly start my presentation. We talk about infertility, and it is a very important discussion to have because infertility affects 1 in 6 people. And while the lifetime prevalence is 17.5%, the periodic prevalence is 12.6%, you may think it's a small number, but look at this, 1 in 6 people in the world are infertile. I think it's high time we had serious conversations about this topic. This graph looks very intimidating. Most of the lines are, most of the curves are downward. Most of the countries are also facing the same challenge. And what is this challenge? The key takeaway of this slide is that fertility rates across continents, across countries have been falling. Also, they've been falling below the replacement rates. What does that mean? It means that the population is not producing enough children. In India, and I read this in an article yesterday, our fertility rate is 1.9. Now the acceptable optimal replacement rate is 2.1. So while it simply means that Indians are not producing enough children, it seems to be an oxymoron for a very populous country like ours that we have a problem like this. But this is the problem, and this needs to be addressed. You can also concur this with the fact that birth rates are also declining. And it's a gender agnostic issue. And I think these conversations and IHW summits have really reiterated this fact. Many people, in Tier 2, Tier 3, even Tier 1 cities, metros, say infertility is a woman's issue. It's a woman's problem. I think this room has to start educating people outside of this room that this is a gender agnostic problem. Male infertility and female infertility have been increasing over the years. Yes, female infertility prevalence is more, but it is still a gender agnostic issue to address. And why does this issue exist? It exists largely because of lifestyle changes that we see, smoking, drinking, obesity. I will not talk about obesity here because it is a very controversial subject. So, but many changes in people's behavior have contributed to infertility rates declining. Also, you find that many non-communicable diseases like diabetes, like hypertension, like cardiovascular disorders, medical conditions like PCOS, they have all contributed to infertility rates being on the decline. And the most obvious, a change in the entire social and demographic milieu of the economy. Most of the young generation is now taking a conscious call to look for financial stability, look for economic stability before they really venture into starting families. So this also, in a way, the delayed parenthood choice that many of the new generation makes has contributed to infertility rates being on the decline. But there is a solution, and that is what the summit has tried to reaffirm and reiterate. In vitro fertilization is one of the preferred options for couples who are infertile, who are seeking fertility treatments. Also because if you look at it from 1985 onwards, the delivery cycle rates have been increasing, and they have been very successful. And alongside, the risks associated with IVF have been on the decline. This makes for IVF treatments to be extremely viable, extremely preferred option that couples could sort to. A very quick slide, and I mean, this is like preaching to the Pope because most of the people in this room are IVF experts. But as an industry, we feel that these are the important drivers of scientific and medical advancement in the IVF sector. Recombinant hormones, I'm sure most of us in this room are aware that recombinant fertility hormones help in providing consistent success and outcomes. Bharat Serums and Vaccines, we are proud manufacturers who indigenously manufacture and market two of the most critical fertility hormones in a recombinant platform, which requires, of course, a lot of complex research, and they are also very hard to replicate, but very consistent in their result and outcome. Another one, AI in embryo selection. We have tools like EmbryoScope today, which help us to identify embryos. Machine learning and algorithms that they throw help in identifying embryos and smoothen the entire implantation process. When you go to genetic testing, we have pre-implantation genetic testing, where they test for chromosomal disorders, where you test for single gene disorders. So all of that helps to ensure that miscarriages are reduced. For example, risks of miscarriage are reduced. Cryopreservation. Here it's very interesting. We also work in the area of women's health and women's sports. So Bharat Serums, we do a lot for women's sports, and interestingly, we have athletes. We have very renowned women athletes who have actually told us that when they experience motherhood, it's an extremely different experience they have, but then coming back to the sport is that much more difficult for them. So for them, egg freezing and cryopreservation is actually a boon, and most of the athletes and women's sports personalities are looking at this as a very viable option for them. It is not only an option for them, it's also an option for the young mothers who young couples who want to delay parenthood. And it is also an option for women who are undergoing therapies like chemotherapy, etc., because you can preserve your eggs and freeze them, and this is an option that they could use. Of course, this room, everybody is aware of CRISPR-Cas9, which helps in bringing about genetic modification at the embryo stage itself, where it has a potential to correct hereditary single gene disorders, and therefore this is one of those genetic marvels that is really helping to identify viable candidates in embryos. Mitochondrial replacement therapy is also hitting news today with the mitochondrial editing that is happening. So paired along with it, it is helping in advancing IVF in the world. While I talk about these advancements, while we have seen the journey of IVF being one that is very productive, pun intended, the idea is to ensure that we as a democracy provide couples informed decision-making power, so that they can make decisions on their reproductive choices. I think that is the most important way forward for the IVF sector, and also the fact that we bring best-in-class, world-class treatments to the country, so that with scientific advancement, we help to increase the infertility to fertility rates, and we ensure that IVF as a sector is a responsible sector, ethically driven sector. There's a lot of work that needs to be done in terms of not only talk about treatments and the medical advancements, but also in terms of awareness, in terms of psychological counseling for the couples going through IVF. And as a responsible corporate, we have been working on all these areas, and we would like to congratulate IHW for their 6th summit, and hope that we are able to really have those responsible discussions today and ensure that we are able to spread the awareness and give IVF its much needed attention. Thank you, everybody.
Thank you, ma'am, for that captivating keynote. May I please request Mr. Kamill to felicitate Ms. Bhavna. Thank you. As we move forward, we shift our lens from metros to Tier 2 India, from institutional hubs to rural and semi-urban landscapes where fertility remains a deeply personal, often stigmatized subject, and access to quality care is still a challenge. Our next session is titled IVF for Bharat, and it asks, how do we truly decentralize fertility care? Can we deliver world-class outcomes outside of metros? What are the infrastructural, cultural, and financial gaps that we must bridge? And how do we ensure that in this expansion, no one is left behind? May I now invite our panelists for this session. I request you to please join me on stage as I call out your introductions. We begin with Dr. Indrani Lode, Director, Urvara IVF, Kolkata. Dr. Lode has been a pioneer in advancing women's health in Eastern India. Her work combines community outreach with clinical excellence, making her a strong voice on regional IVF models rooted in empathy and ethics. Ladies and gentlemen, please bear with us while we quickly set up the stage for the panel to come, and I will continue to introduce our panelists in the meantime. We have Mr. Gaurav Singhai, COO and co-founder, Gunjan IVF World. With multiple centers across Tier 2 cities in North India, Mr. Singhai brings a strategic operations lens to fertility access. He understands the real-world logistics, affordability models, and behavioral shifts required to build trust beyond metros. We have Dr. Sohani Verma, Senior Consultant, Apollo Hospitals, Delhi. A senior figure in reproductive medicine, Dr. Verma has been advocating for accessible fertility services, public awareness, and gender-sensitive care. She brings both legacy, experience, and progressive ideas to this panel. We also have Dr. Keshav Malhotra, Director and Chief Embryologist, Rainbow IVF. One of India's leading embryologists, Dr. Keshav combines lab leadership with a passion for bringing international standards to local IVF centers. His perspective merges science, youth, and system-scale vision. We also have Dr. Sudha Prasad, Director and Senior IVF Specialist, Medical Institute of Reproductive and Sexual Health. Dr. Prasad is a highly respected name in reproductive health, known for her strong academic background and work in building affordable care pathways for underserved populations. To moderate this session, we have Dr. Narendra Malhotra, Managing Director, Rainbow IVF. Dr. Malhotra is not only a veteran in reproductive medicine, but also one of the most credible voices in national ART policy, training, and public education. With centers in multiple Tier 2 cities, his leadership in this session will bridge ground reality with strategic insight. Another couple of moments, ladies and gentlemen, and we will then invite our panelists on stage. May I now please invite our panelists on stage, and apologies for the delay. Can we have a huge round of applause as our panelists join us on stage?
Yeah, I know. So Gaurav, please. Dr. Indrani Lodh, Dr. Sudha Prasad, and Dr. Keshav. I'll sit here. You can go in the second one here. So very good morning to all of you. It's indeed a pleasure to be here in this very, very well organized 6th India IVF Summit and Awards. And we all know that 25th of July, 11:47 p.m., the whole scenario of infertility changed, and probably we conquered a major part of infertility. Can I have the slides? So what we are going to talk today from these experts, we have Gaurav, we have Dr. Sudha Prasad, we have Dr. Keshav, and we have Dr. Indrani Lodh on how to take IVF for Bharat, and how can we have it here also? So they can't see the slides otherwise. So expanding the access to Tier 2 and rural India. So we have these panelists which you've already been introduced to. IVF in rural versus India. Dr. Indrani, what are the biggest barriers to IVF awareness and access in the two-tier and in the rural India? Yeah, the mic is on.
Good morning. Happy World IVF Day to all of you. So I think the biggest challenge is that there aren't enough IVF clinics in the tier 2 cities, leave the rural India.
We just
And
heard
India is
mushrooming, we just heard from somewhere, it's mushrooming and you say they are not enough.
India is 80% rural and 20% urban,
In the rural part,
yeah, and all the growth that is happening right now is happening around the metro cities and the other big cities mostly. But tier 2 and rural India is still far away from what we need and what we have.
Anyone else wants to add, Dr. Siddharth?
Hi, thank you for calling me. So I just want to say first that how much is the education? If you go to the village, if you have really gone to the village, you should know about it. That people do not know there is an infertility treatment. This is the number one thing, because uneducation.
So your first thing is lack of awareness.
Totally awareness is not there. They do not understand that this disease is also treatable. And there are so much of myth about it, stigma, taboos of the society, that they do not understand that this will be declared in the society that I have no child and I have to get treatment about it. So this is very much important. And another thing, when you go to the village, I don't know how many of you have gone to the village. I go to the village and I see there is no electricity. Even this
So
mushrooming
the infrastructure is
the
a
infrastructure comes late. Normally
infrastructure.
electricity is not there. So IVF labs and the OT requires the real electricity and it should be properly supported.
Stabilized and everything.
So it is not there.
Gaurav, what about you? How do you think that are these points, of course, very valid
In
points? but
addition
anything
to
else?
what ma'am has said, awareness, infrastructure, lack of infrastructure, there are 3 A's that are very, very important. The first is the affordability, the second is the availability, and third is the access. Now, affordability. Typical IVF cycle typically costs 1.5 to 2 lakh rupees. Hamara to per capita income is 1,14,000 only. So the poor families are spending 1.5 years of their earning for one IVF cycle. So affordability is a big question.
So cost is the question.
Yeah.
The
Second
first
is
thing-
the availability.
because Dr.
Yeah,
Indrani
yeah.
said it's not available.
Yeah. And then the access.
And then people
Yeah.
don't have access to.
So when people come to our centers from rural places, they face a lot of hardships. It takes time, then accommodation issues and everything. So it's not accessible to them also right now. Even the basic infertility care is also not available. IVF to abhi dur ki baat hai.
And
Dr.
that's where,
Keshav, what do you think about
I think
this?
that's where insurance has to play a very big part in the
There's
near
some
future.
insurance has to be there for rural
Because,
people or for everyone. Yeah.
It has to be there for everyone, because now we just heard the previous speaker speak about how our fertility rates are declining. We're already at 1.9. And unless and until the government makes a policy change and includes IVF in their insurance policies, I think we will further decline. So that's something that we really need to speak about. I think Vikas is also going to touch upon it from Safety. They are launching something. So, yeah.
So anything else in the rural apart from these points which they said? Awareness, cultural stigma, misconceptions, low availability, fertility care, the 3 A's, and of course the cost.
Superstition, I think.
Superstitions, the misconceptions.
Superstition, yeah,
stigmas.
it prevails very much in the rural India. They think
So
infertility
they'll
is a
rather
curse.
go to a fertility doctor who will do all
No, they
the-
think it's a curse and they are being punished for their karma, not in this birth, maybe in the previous birth. You know, all that is there.
I think that's also
And
there.
fertility babas.
That's also there
Yeah.
in tier two cities where
And so the first thing I think we need to tell them that infertility is a disease. It's not a condition. It's not a curse. It's not a superstition.
So thank God WHO
So that's,
has
I think,
recognized infertility as a disease.
and yeah, WHO has
Otherwise,
recognized.
And I just want to add, even the infertility is there in a couple, always the blame goes to the female.
Yes.
And
That's right.
finally, with great difficulty, great counseling,
You are
the
able to-
male partner comes and he is azoospermic. So we do not know exactly.
So
the
Dr.
reason.
Keshav, the next direct question comes to you, is cost the main hurdle, or is it the availability of the trained professionals like you in the non-metro cities? And you would
I
not
think-
like to be in a rural area, people like that
No,
level?
honestly, we have gone to so many smaller cities and established clinics there and worked there. So I do feel that that is somewhat being taken care of, but cost is something which is probably one of the bigger hurdles. UNFPA just came out with their report for 2025, which lists as the real fertility crisis being in India. And what they label in their report is, it's the housing crisis, it's the salaries, it's the inflation. These are all factors that are actually determining whether people can even afford to have a child, let alone go through a process like IVF to have a child. So there are lots of other things that we need to also take care of as a country and not just focus on IVF itself.
Anyone wants to add that? Cost or trained professionals? Or both?
I just want to add here,
Yeah.
when in Maulana Azad Medical College in 2006, I started the IVF in a public sector. So there was lots of hue and cry that why it really required, I have to go so many times to the secretariat to catch the people there, that this is a problem. You sit in the infertility clinic and see how people cry, how women cry there. So sensitivity, I got it. Finally, I got the IVF center, and the government said, ki, okay, we will give the free IVF. When I have given the cost, then they said, my God, all Maulana Azad fund will go to the IVF only because it is so costly. So finally, gonadotropin was is excluded, and everything, all media disposable consumable were given by the government. But there are few numbers in the government sector which can really give the support to
So that's
these
another challenge, to have an IVF center in the government college. It's now compulsory by the NMC, Indian Medical Council, that everything, for every medical college to have a center so they can train students. And finally, the government is planning to have it in the district hospitals also. But the problem is of the media, the disposables and the procurement.
The tenders,
The
it's
tenders and-
really difficult to run an IVF clinic. I think ma'am will agree in a government setup, because an IVF process is time bound and we can't really afford on not having the right media at the right time, not getting injections at the right time, not getting access to embryologists or critical equipment which is not made in India. There is a cap.
25% of the equipment should be made in India.
It is actually very difficult. So till the government strengthens the public sector, IVF is going to be dominated by the private sector, and it's much needed.
So we now have almost 500-600 medical colleges have gone into the rural, and that's where IVF needs to go to provide rural care. So we understand that trained personnel, infrastructure and cost are both critical to it. Dr. Sudha, how can the government schemes, insurance programs, Ayushman Bharat help? See, Maulana Azad, the Delhi government was very big-hearted, and they allowed, they said free IVF.
with great difficulty.
With great difficulty.
Because when I took this
We know,
proposal,
we struggled with you. We went to the
so
government
they said,
with
ki,
you.
my God, you need a बैलगाड़ी और एक हवाई जहाज भी. How this is possible? This was the terminology used for me.
So what do you think the government should do? Bring this into all the government free schemes, health schemes?
See, in government policies are there, but the funds are in Ayushman and Janni Suraksha and all those things. I tried my best to get this, but it is so difficult because infertility is not added in that list. Yeah. This is number one problem, because they think without this, people can survive.
We are already overburdened with children.
Overpopulated
Should we have
area.
more children or not?
Because I remember in 93 when I went to Baylor University, they said India wants the IVF center. Why? They are highly populated.
Or
Western
add
people.
karoge population.
So in India, what they will answer about it? They had this kind of question from me. So this is another problem, because they cannot. So this is Janni Suraksha, number one, we should add the infertility also in that list. Then only we will get the part of the thing. If some government has paid about 65 to 80,000 rupees. Why only the government person will get? Because they have get the reimbursement.
Should be open for everyone.
It should be open for everyone, and all private centers should be recognized for this IVF, and people should get from there that they should sign it. Yes, of course, under the ART law, they should work.
Gaurav, your thoughts on this? Ayushman Bharat, should it cover IVF?
I'll talk. First, I'll talk about the concept of population explosion is an outdated.
Yes.
I am not saying. Sanjeev Sanyal, the principal economic advisor of the Prime Minister, has said, if we take out UP and Bihar population growth, then India's fertility is falling really rapidly. So it is propped up to 1.9 thanks to UP and Bihar. Now, so first change in the policymakers has to be that we are no longer reaping a demographic dividend, because we are already, the peak number of babies have already been born 15 years back. Even Pakistan and Philippines are younger than us now. And in 2050, our demographic dividend is going to stop giving us results.
Like Europe.
So the first change the policymakers have to see is that population is no longer a burden, it's an asset. So everything has to start from there. Things like Ayushman Bharat and all, of course, they should be included so that the poor families can get some support. So government should now
so we have to
support.
understand that when we look at infertility, and on the other hand, you look at cardiac disease, hypertension, renal disease, and diabetes added together, the infertile patients are much more than these diseases. And there's a lot of money being pumped into these diseases and the research and the free treatments rather than into infertility. So that is what someone has to make the government understand. So Gaurav, while there aren't any, the government does not have any advertised government schemes for IVF insurance. We from ISAR have this thing for two cases of where deservable to do free IVF. So the ISAR centers can opt for the ISAR scheme, Dr. Sadhana Desai's scheme, and where can provide. So it's one or two, but it is still there.
No, there are some states also that are working towards it.
Tamil Nadu is one of them.
Goa has a scheme.
Is one of them.
Even Maharashtra, Parsis for the community, they have a scheme.
Subsidized fertility care for the Parsis, free first IVF cycle by ISAR, and that could be the good side. Like in Israel, it is totally free. So Gaurav, now to you, what are the technical challenges and the medical infrastructure for setting up a IVF unit in a rural? I mean, can you have a lab like this in say Achnera or somewhere like that?
If you see the cost of setting up a lab, right now it is anywhere between 2 crore to 3 crore. The cost is high because there is so much of import component in the setup of the lab. So if we are able to produce good quality equipments in India at a lesser rate, then the cost of setting up labs will come down, and in turn the cost of treatment will also come down. So indigenization or Make in India has to come into our sector also.
So Make in India is the answer. Yes. Dr. Keshav, what about labs?
I still feel that access to laboratories is still doable, because we don't need such a big laboratory. Even though this is our lab in Agra, we don't need such a big lab for rural setups. Smaller setups can actually work, and they can produce the same amount of results, or good results for such setups. I feel that people are unable to step into that market because they are unsure whether patients would be able to afford. And unless and until that is solved, people will not enter into the rural market, and the access would still be limited.
But still, for a lab, you'll need backup.
Yes,
you can't
like,
do with one
like ma'am mentioned,
because
you need electricity. There are lots of issues.
Not only the lab will be made in a rural area, in some village, and it will work out. You have to maintain, you have to support it.
So
this is
access
very
to
important.
liquid nitrogen,
yes.
how will
you
be
get
procured?
The liquid nitrogen? How will you get the media? How will you confirm that cold chaining? So many points are there that they should be supported, then only one lab. So what I feel that if we will provide the transportation to the villagers or the rural person, then probably at the better district level, this can be thing. It cannot be cannot go to the villages.
So a new word has come, transportation. When I was the president of Foxy in 2008, I was asked in a press conference, what will you do to reduce the maternal mortality? I said, build roads. They said, pagal hai, build roads, patient mar raha hai, build roads kya hoga? I said, मरे हुए patient को ला पाओगे तभी तो बचा पाएंगे. So that is what it is. If you can bring the patient or take the specialist to the village, then only you will be. So the, or become a fellow Bhiksha Commission Society. So that's the challenges which we have. Indrani, back to you again.
Training.
Yeah, you wanted to add something?
Yeah, I was saying that even training of gynecologists to become an IVF expert, training of embryologists, that also needs to be seen. So like when you're looking at, when you want to provide all these services to tier 2 cities and villages, action has to happen at all levels, starting from the government, the policymakers, the thought process, because I mean, like Indira Gandhi, she thought of sending a satellite to the space in 1975 when we were struggling so much with hunger and garibi and family planning issues. Even as we were graduates, we were so much concerned in PSM about family planning. Hum do, hamare do was the slogan. And now look at it, the fertility rates have come down and we are talking infertility, 30 years.
That needs
so
a
I think
change in the education system as well, because
absolutely
the same books, we are also reading the same books and they are still focusing on family planning where issues have evolved.
Yeah, issues have changed. So, the change has to happen from the top right up to the bottom. And I don't think it's not doable. Of course, it's doable.
It is doable.
The thought process has to change.
What are the social stigmas, the religious beliefs, the family pressures? Do these affect fertility treatment?
Oh my God, this is all about social.
Another big
Infertility
so
is more of a social
which we face,
issue.
Taking these treatments to rural families,
absolutely.
or even all families.
Yes, of
So
course.
what are these?
So these social things are a lot, like I said, it's looked upon as a curse and maybe a result of some bad karma which you have done in some past life or this life, and then the woman is is held responsible for getting a child. I'm not bringing the son-daughter issue in it. Not only a child, but to bear a son. Because the son will take the family's name forward. So that is such a pressure. So even after having 2 girls, couples want to come back. Thankfully, in my part of the country, I am from Kolkata, this is not much. Yeah, definitely there's more happiness on the birth of a son. But having a daughter, I mean, they are not unhappy, as I would say. So these are the issues, and we all know that all these stem from more deeper issues like dowry and, division of the family property, etc.
So it's a whole social circle which is...
So infertility as such is more of a social problem and a medical problem. Yeah, the medical problem has just started to come up and we are viewing it as more of a medical problem. But to change this mindset, I think we'll need another few years and the dialogue has to go on. Public awareness has to increase.
So Dr. Keshav, do you think it's unnatural, what people say unnatural baby bahar banaya hai?
No,
Andar banna chahiye?
they do feel that it is unnatural, and it's not just in rural setups, it's also in cities like Agra, tier 2 cities. We face these patients every single day, and it's so
I hear this in Kolkata also.
It's so
which is a metro.
To tell them that it's going to be your baby. You're going to carry the pregnancy. You can easily deliver normally or vaginally. I mean, there are so many myths that are related with infertility and so many misconceptions that half the time of the consultation is just trying to solve these issues rather than doing the medical treatment.
So when we opened our first IVF in 1996 in Agra, and this professor of surgery came to see the lab, and he said, where is the test tube in which the baby will grow? I said, the baby will grow in the mother's womb, not in the test tube. I mean, that was a professor of surgery of a medical college talking like that. So
I had a patient, he came and said, "Mujhe shishi ka bachcha karana hai. Shishi wala bachcha karana." So that's how it's perceived.
Anything more you want to add on this social stigma? Koi aur story interesting?
Interesting kya means in the medical college, how many pages of infertility we read? Only 4-5 pages. So the grassroots level, at the post-graduation level or the MBBS level, we are not giving the proper education to the doctors. So this is important, very much important that we should give this in.
See,
Because they are not aware. That is the reason they ask them, where is the test tube and where is the professor level person.
I remember when we passed out, infertility was just 2 pages in that book.
Yes.
And if you read Harrison in medicine, depression was only half page. Today depression is 20 pages. 20.
But unless and
Gaurav,
until medical colleges have IVF
So
units,
medical colleges should
how will they end up?
so they
treating
don't
this?
have this thing. So they
Actually,
Yeah.
But
There
there
is-
is another problem of medical colleges. I will tell my experience about it. When I opened the IVF unit, which requires the full-time work, but they said you can't leave the labor room. You have to see the obstetric also. You have to do the cancer surgery also. You have to go for the teaching of MBBS at 8 o'clock morning also. Means so many things are there, and after that you have to work for IVF if you want, if you really
then
keen
the
for this.
other units will not send the PGs to you to study.
And nobody will go for this. Nobody will go. You do yourself only.
Nobody will go from the other units.
Yes.
Only your unit PGs.
So this was the problem.
So these are the major problems for teaching. Gaurav, anything you
Actually,
want to add on this point?
it's the stigma. I think that's the first thing.
Stigma.
IVF पेशेंट्स कहते हैं कि हमने अगर किसी को बताया तो लोग पूछेंगे कि वो सब कुछ ठीक नहीं था क्या. तो ये जो स्टिग्मा है, सबसे पहले तो इसी को दूर करना ज़रूरी है फॉर अस टू रीच टू टू गो बियॉन्ड द सिटीज.
किसका बच्चा ले आए हैं? So that's
हमारा तो होगा ना सर.
So now let's come to technology. So if we cannot go to the villages, can we link the villages with technology, Dr. Keshav? You're talking a lot about AI and everything and telemedicine and
yes, it can be done. There are now systems.
So robotic IVFs in villages,
Yes,
you can sit from
robotic
here and
automated labs do exist in the Western world. Robotic ICSI exists in India as well. It's nothing new as of now. But the only challenge that I perceive is that again it's going to still be at the same cost. So we have access to telemedicine. You can do consultation sitting in a city. You can treat patients. You can write prescriptions. You would still need a doctor to do the pickup. You will need an embryologist to load the equipment. All of the other things can be done by the automated systems. You will need someone to do the transfer after that. But again, cost is going to be the biggest
human
challenge in all
element.
of this.
So Dr. Indrani,
I have to say something.
Dr. Indrani, I mean, in COVID times, that is when I used to talk about this. You give the vaginal probe to the patient, takes home and right karo, left karo, you get the image of the ovaries, you titrate the dose and you monitor right.
Yes.
Sitting it. So something like that.
Telemedicine, I think, can have a big role to play in this. And with the advent of AI, I'm sure we're going to have more and more tools which are going to help us in providing technical support in between the clinician and the patient and the embryology lab.
Every single thing can be done by AI.
I think
now.
regarding cost, I have a point to make. I remember in the 90s, I was following up with an infertility clinic with Professor B.N. Chakravarti, and in those days also, the cost of an IVF cycle was around 2 lakhs. And that time the gold was 4,400 exactly. I can tell you the exact rate. The day I was told that the cost of IVF cycle is 2 lakhs, gold was 4,440 for 10 grams. I didn't have money, so I didn't buy. So now, even now it's 2 lakhs, 2.5 lakhs. But the gold is 95,000 if not 1 lakh. So if you look at it that way, the way inflation has affected our economy, the cost of IVF has not gone up, it has gone down incredibly. So, we have to look at it that way. Everything is about perspective. Now, if you think that 2 lakhs bahut zyada hai, then this. But if you change your perspective and if you look at like this, actually it has not gone up at all.
For the daughter's wedding, they'll buy so much gold. I mean, at 1 lakh also. But for an IVF cycle to have a
I always say कि जितना खर्चा अभी आप IVF में करने वाले हो, उससे ज़्यादा आप उसके फर्स्ट बर्थडे में कर दोगे.
I know.
Absolutely, that's true.
Yes, Dr. Sudha, you wanted
Baby
to
shower में हो जाए.
Telemedicine technology.
About the telemedicine, what I feel that it can go for the diagnosis, for the investigation, and probably if Madam said that the women can have their own vaginal probe and can show to the follicles. But finally, she has to come physically for the pickup. Embryologist has to come, and one day before keeping the media and to see the incubators, how they are working. So physical presence has to be there. So telemedicine is only up to the investigation and diagnosis.
And also in telemedicine right now, probably the rules are that you cannot prescribe medicines on WhatsApp or on. So that also has to be cleared.
That also, yes, very right.
Cleared, otherwise you cannot prescribe. You will be prescribing all types of drugs, even narcotics on WhatsApp.
There is a legal problem with
That's
this.
also where I think now, because AI is also coming into picture and AI based protocols are there, where you put in the ultrasound report for the first 3 or 4 days and the rest of the 6-7 days protocol is given.
Protocol is decided by
no need for an ultrasound scan after that. We need to have regulations and rules for the use of such technology. We need to have some publications and then only the country would be ready to actually use tech.
So as the panelists said, the telemedicine would give you a good idea about initial infertility screening, probably follow up, but for IVF itself they have to come back. So probably we could look for rural centers as a hybrid model where they do that much there and then come.
The hub and spoke model.
Hub and spoke model is
what our country needs.
That is what it is. So what about enough embryologists? Dr. Keshav,
I think we have enough.
Now you have
No, not at all. We don't have enough.
We
don't have enough.
Let's see embryologists going to
let me make my point. I think we have enough colleges now which are putting in master's degrees. There are hundreds, maybe almost 200 to 300 embryologists who are entering the workforce.
We are in better position.
Every single year. And we are doing about what, let's say about 3 lakh cycles.
We don't have
3 lakh cycles in a year, according to some of the papers and recent consensus is we have about 4,000 to 5,000 embryologists. That means that each embryologist is doing about 100 cycles a year, which is enough. So
but these are all in the urban. How about rural? That is what we want.
No, but there are already 300, 400 who are entering every single year. And when you I will post once on LinkedIn that I am hiring an embryologist, and I see hundreds, 200, 300 students who will send their CV, who have not been able to secure a job for the last 3 years, 4 years. The market is becoming very difficult. So I think this notion has to change, that we don't have enough workforce. We have enough workforce for the amount of work that we are doing. If we increase the work, yes, we'll need more people, but as of now, we've reached stagnation. And it's horrible. Honestly speaking, there is the training that's being done in colleges nowadays is something that needs to evolve rather than getting more numbers, because we need more quality people.
So we need more quality people and more people who are
better trained people
to go and serve in the role.
And I'll tell you one more thing, that the villages should have the facility to stay when we can't send the medical officer or interns for the village posting. How many embryologists and the IVF specialists will go there? So yes.
So quality, safety, ethical practice of going into the village. How about this ART Act affecting the villages? I think we'll all have to follow the ART Act.
Even in the urban, how much ART Act is working?
You have
this is also a question mark.
You have worked in the
I
public
think it's
sector
working
and
very
private
well.
sector. So how will they?
There is lots of difference.
Where we can help, or we can call.
No, that's what I said initially also. The private sector also should be registered with government, and straightway the patient should walk in, and registered IVF centers should do, and they should get the reambusment from that.
So
this will be the fantastic.
Like Gaurav said, we should have a hub and spoke.
Yes.
So also, the main center is in the center, and you have many centers there, and they finally.
Also, since you mentioned the PPP model, the government can do the setup, capital expenditure, and the private sector can be entrusted to go and run at the district level, where finding talent is still okay. Beyond that, it's really difficult to find good trained talent.
So our final question to all of you, what do you see is a roadmap for equitable IVF across Bharat in the next 5 years or so, by 2030? Are we going to see centers all over India, or are we going to see hub and spoke model or public-private partnership? What do you think is going to happen in the future?
The first thing is the IVF is here to stay, and really long live IVF. It's a great technology, it's science, and in the next 10 years, I think we will have more of PPP models and more access to infertility services all across the country.
I think unless and until insurance plays a big part in this journey, it will not spread to the rural areas. So I think that's one thing that needs to be strengthened. If it happens, centers will open across India.
Dr. Sudha?
We should have a more training program for the specialist. It is very much important that embryologists, andrologists, technicians, staff nurse, everybody should be trained for this. Then only they can work about it. Otherwise, no.
Yeah, totally agree with ma'am. If we are able to train people, then only we can open everywhere. Else, it will always remain concentrated to metro. Even if the demand is going to come, we will remain concentrated because of the lack of manpower. So the training is really the most important thing.
Ladies and gentlemen, that was the one-line punchline from all of them about how we are looking at the IVF centers, and it was 11:47 on today, 25th July, 47 years back, that hope was born to millions and millions. Happy birthday, Louis Brown, wherever you are, and I know you are in a lot of functions which we communicated in the morning by WhatsApp to you. Happy birthday to you all. Happy birthday to all the Indians who led this, right from Subhash Mukherjee to all the 3,000, 4,000 centers we have. Thank you very much, panelists. Thank you, IHW, for bringing this, giving this opportunity.
Thank you so much.
Thank you.
And let's salute our pioneers, the Indian pioneers, which we are there. Thank you.
Thank you to all our speakers for that interesting conversation. May I please invite Mr. Kamill to felicitate our guests.
Jaideep, take a picture.
Thank you.
No. Ladies and gentlemen, can we have a continued round of applause for that interesting conversation? Thank you, panelists. Thank you. Ladies and gentlemen, we now move to our fireside chat on business and leadership in IVF, a high stakes and high impact conversation that sits at the heart of this summit. As fertility care in India grows at an unprecedented pace, we must ask ourselves, are we building not just clinics but a system? not just businesses, but ecosystems of trust. This session brings together top leadership voices from across IVF chains, hospitals, and healthcare strategy who are driving that transformation, navigating patient needs, compliance, financial planning, and expansion beyond metros. Today, we will discuss what scale with substance looks like, the changing economics of fertility treatment, strategic partnerships and patient-first business models, and how India can create an IVF model rooted in both clinical depth and accessibility. May I now invite our panelists on the stage for this chat. We have Dr. Rajiv Agarwal, President, Sales and Marketing, Bharat Serums and Vaccines, Head Fertility Cluster. Dr. Agarwal brings deep insight into how pharma and biotech intersect with clinical delivery in IVF. He has been a pivotal force in driving access, affordability, and innovation in fertility medicine across India. We also have Dr. Sarthak Bakshi, CEO, Riza IVF. Under his leadership, Riza IVF has emerged as a trusted fertility brand known for blending ethical care, advanced embryology, and clinical transparency. To moderate this chat, we have Mr. Kamill Narayan. Please join me in welcoming them on stage.
Hello. Sorry, Dr. Rajiv, your introduction was wrong. But no, this was about BSVL, your previous role, I think. Huh? So
Yes, sir. May I please take this moment to correct myself? Dr. Rajiv Agarwal is the President of Sales and Marketing at GUFIC, Head Fertility Cluster. Apologies, sir, and I over to you, Kamal, sir, to moderate this panel. Thank you.
But I think in all your roles, you have been immensely contributing to the, well-being of the patients you were serving, or you were serving through the companies. So that introduction also remained equally important.
Thanks for the nice introduction, actually. I have been serving long, different roles, strategic roles in different past companies, and behind a lot of patient-centric activities. So I think
Yes. So let's to begin with, we are going to discuss a bit, about what are the roles and responsibility of our IVF leaders in, driving trust, access, empathy, and also, that kind of credibility around us. But before we get into that, let me, let's start with a small introduction in terms of what all areas you are focusing, what are the key areas in IVF you are focusing, and how you are bringing that important aspect to them.
see GUFIC, I just taken the role at GUFIC as a president for this fertility cluster 5 months back only. But GUFIC, as you know, is the largest lyophilized manufacturer. Many of the people will not know that we are the legacy of 54 years. And we came with the antibiotic MOX, if you remember that. And after that, we built our largest manufacturing facilities in lyophilized injections. And we are serving most of the IVF patients with our hormones and injections. And we have the capacity of manufacturing almost 100 million lyophilized injections in a year. That is one of the greatest capacity we have installed in Indore. A lot of patient-centric activities we are focused. For example, we have tied up with IFS also with the Made in India and Make in India movement. Today was the inauguration of that. And ISAR also, we are doing a lot of scientific initiatives, like we are sponsoring 100 couples, those who cannot afford the IVF treatments.
Wow,
So that is one of the major initiatives we have taken with ISAR. I
This
think
is 100 in a year or so? Or
100 in a year we have taken.
Wow.
So 100 couples will sponsored our injections, total hormone therapy. So that is one of the biggest initiative we have taken.
Wonderful.
So because IVF itself is a burden, cost is a huge,
Absolutely.
and many of the patients cannot afford to get the treatment. So how Gufic can really help the patients to do the treatment, because it's a boon to the society. So I think that which Dr. Patki has agreed and Isar has agreed. So I think we are going to do that, and we are going to launch that. Today was the day, but I think I am just announcing you.
Yeah, so we'll be having Dr. Patki in the evening, so I think you can have a formal launch of that. Yeah. So very, I think, remarkable and appreciable effort, because this is very critical to ensure that the IVF reaches to the people who really need it and cannot afford. So I think in that case, because normally, you know, I have grown up, you know, hearing or seeing, grown up mean professionally, because in my previous avatar I was journalist, and I used to do a few stories for various publications like you know, Hindustan Times or PTI related to IVF. And that time IVF, we only get to hear or report for which celebrity has got, you know, a surrogacy, children through surrogacy or IVF and all that. And somehow this stereotype remains in the public consciousness. We do not realize that a rickshawala or a rediwala or a driver may also be needing IVF. We look at IVF for those corporate people who are, you know, deliberately delaying parenthood, late marriage, different lifestyle. But there is a lot of about infertility which comes from the environmental effect also, the working hazards also.
I think as a company also, in the previous panel it was discussed, awareness has to be created not in the tier 2 and tier 3 cities, in rural areas also, because still it's a stigma, taboo is there. And if we can, and it's a strong barrier for patient to turn up, because knowledge is not there. They don't know, awareness is not there. If collectively we as a company, serious player, can do such thing and create an awareness, and definitely a lot of patients will turn, because 28 million patients suffer, but only 3 lakh cycles are happening. Absolutely. So I think if more and more awareness will be created, it definitely will turn around the patients. And it's a disease which can be curable. It's a lifestyle disorder which has to be taken seriously.
Yes.
So as a serious player, we are also doing a lot of things to create awareness.
Wonderful. Really appreciate that. So let me, before we go a little further on it, let me bring in Sarthak. Sarthak, so how is your company contributing to IVF? A bit overview.
Sure. So I'm a non-clinician, but I run a chain of fertility centers across North India and Nepal. We have 12 IVF centers. 12. Yeah. So in Delhi, Jalandhar, Nawashahar, Bareilly, Pilibhit, Dehradun, Karnal, Kathmandu. So we are spread across this geography. Wonderful. So we've been doing that for the past 11, 12 years. And I mean, it's been a very interesting journey, because, you know, someone who's not from the healthcare background itself, but when you start doing this, so it's a very different thing. You know, it's, people consider this as a business, but when you see couples, you know, and healthcare in itself, healthcare can never be a business. It has to be, while you're asking about, that there is a certain form of empathy and certain form of compassion that's needed to run any healthcare chain, a healthcare clinic, a hospital. Unless you have that compassion,
there is an inherent altruism in health.
There is, you know,
decide to serve patient.
You'll have to, you know, it cannot be, this is the product, this is the is the TFR, which is said 2.1 बच्चे होने चाहिए तब जाके population replenish होगी. Yes. Almost all developed countries, whole Europe, Japan, Australia, US, they are declined. They are as bad as that. I was just in Europe like last week, and I was just speaking to my friend who had a baby, and they said, you know how much the government is supporting? पहले तो there is free IVF for them. Secondly, they're paying them 250 euros per month कि आप बच्चा करो, हम आपको पैसे देंगे बच्चा करने के लिए, आपके लिए एजुकेशन फ्री, हेल्थ केयर फ्री, किंडरगार्टन तक फ्री. Plus they are paying you money because there is such a population decline. They don't have any people, couples are not getting any babies, they don't want to reproduce, procreate, whatever goes on in their mind, they're not doing that. So that is the economy that has gone down. And Trump himself had said that. That was the article I was reading today, that he's announcing benefits, that they will give you money to have babies.
Wonderful. So that is something which those countries now have to be awakened to, because sustaining the population is equally important, for them. But when it comes to in India, so he mentioned about that this is also about the how we look at IVF, and in some time when we talk to a few important people who can, work in the policy side and all that, and then can take those decisions that not providing maybe support till kindergarten, but at least covering the cost of IVF for those who cannot afford it. Many times you get to see this thought that why do we need more children?
Good question. In India में ना आप बहुत talks देते हैं, मतलब सबसे पहले question पूछा जाता है, do we require more children in India? Do we require more people? We get this question a lot. आप IVF बोल तो रहे हो, ठीक है, विदेशी problem है, और this is the problem for the West. With 1.45 billion people, the most populous country in the world, and I will ask this to the audience, do we require more people? 90% will say no, नहीं बहुत है, बहुत सारे people है, why do we require more people? But you don't understand that pain point of that couple which is not even having one child. It's not about the fourth person having the fifth child or the fifth person having the sixth or the second. As he said,
it is also like, if you have a billion population, and if you have 80% of them enjoy freedom, and 20% of them don't get even the basic freedom, you call it that, okay, why 80% are enjoying freedom, why do we need more freedom? So freedom is something which is needed for each and every individual. Similarly, the parenthood is also something which is a right for every living creature.
Coming to his point, I think पहले एक previous panel it was discussed, हम दो हमारे दो, अभी वो हम दो हमारे एक भी नहीं हो रहे हैं, तो फिर वो I think we have, where is the fair? So I think this we have to change the scenario. I think recent article in the Economics Times has also tell if this birth rate has reduced from 2.1 to 1.9. If this will continue in 2065, we have an old age scenario in India.
So our demographic dividend of having the maximum young population is also going to be now.
Yeah,
it will be like the Japanese.
So when, in this scenario, and since both of you are important leaders, business leaders in the space of IVF, you are bringing an important therapeutic and pharmaceutical support, and you are running 12 centers, and I am sure that it will soon become 120. So, and it is needed, and I am not saying it is because you will look into it as just a business opportunity. You may be driven by the thought of taking IVF to all those who need it. So the equitable access may also drive you, because as you mentioned that out of nearly 30 million, we are only serving or doing a cycle nearly 2 and 3 lakh, which is less than 1%. So there is a huge scope to increase this access. But while in a way everyone is expanding, and we are seeing that IVF centers being called as mushrooming to being promoted from auto rickshaw to where not. Do you think that the market is taking all those responsible path or actions which are needed for something as serious as IVF, dealing with a serious health issue of fertility or infertility? Are we really going on the right direction when we are marketing it, when we are promoting it? Is it more than awareness? It is becoming a product crying to be sold at all possible level.
I think as a IVF, it's not a commodity. It's requirement. I think we have to take it like it's necessary for the infertile couple who is going through a lot of traumas and like that. So I think awareness is required and a lot more clinics are required in IVF. Because of the ART law, I think there were some restrictions and laws has come, but I think still tier 2, tier 3 cities and a lot of more IVF centers are required, those who are really doing a lot of serious work in IVF. So I think it's a
need.
It's a need, yeah.
Even to say that guaranteed bachcha 9 mahine mein.
At least guaranteed jo bhi hai, success rate, so we all know ki, what is the success rate for
But
IVF.
that gives
But
the
at
wrong
least
impression.
That hope we can give to
But
the
is it well-founded hope all the time?
We cannot say well-founded hope, but at least they see some hope ki at least we can become the parent. That smile we can, that IVF.
So we can change the communication, and the same company starts saying that if you are, suffering from childlessness, you can become a parent. No more, or come talk to us. Maybe not saying that,
change the communication, and we can give the hope, and we can tell this is IVF is a science which can really make your parenthood, and we can bring the smile.
So what market is behaving or doing things, you also see an important need for it. And definitely, as if I'm saying that from rickshaw wala to ready wala would need, so advertising to that level is also equally important. How do you see, Sarthak, that? And do you feel that, as you said, that healthcare is a serious business? Healthcare has to be a bit altruistic in the nature. While you charge for the service you are providing, but it is not a plain service. In that scenario, because we don't see much of advertising saying that, get a sure sort of care for cancer or for heart, for, something like this, or even we put the cost sometime. Do you think as a business leader and somebody who is going to play a bigger role as you go forward and you deal with the states which are relatively, they need a different kind of a more simpler and more, I think, attractive, messaging. How do you see that? And do you feel that we can change it to make IVF a more respectable?
So I do agree that, you cannot stop anyone from marketing what they want to. There's a very fine line between guaranteed outcomes and fertility awareness. Though I assume everybody's intention is about getting that education, getting that literacy, getting that awareness out there, which probably can be taken in a wrong way when people are advertising about guaranteed outcomes and 100% success rate and so on and henceforth, and IVF treatment at XYZ cost, So एक वो हो जाता है, but because awareness नहीं है market में. And I'll literally tell you that you might think because you see ads in the metros and in bigger places, but anyone, if I have seen through my journey, the first point of contact for people not having a baby is not an IVF specialist. पहला point of contact होते हैं भगवान, मंदिर. पहले 4-5 घंटियाँ बजेंगी, तिरुपति जाएंगे, माता के द्वार पे जाएंगे, 3-4 जगह और जाएंगे, 1-2 साल सारा यज्ञ हवन जो कुछ करवाया जा सकता है करा जाएगा. चलिए, you have moved beyond that. उस 2-3 साल के बाद then they will say, okay, let us, local gram panchayat doctor or the local physician or something, let us start कि क्या हो सकता है. They go there. The next is probably the city gynecologist. By the time they reach to an IVF specialist, it's already 5-6 years. And that is where the peak fertility problem, which could have been solved earlier, through which the success rate could have come earlier, that has been deferred till such a long time कि वो IVF एक कमोडिटी लगने लग जाता है, अरे इतना पैसा मांग रहे हैं, ये हो रहा है, वो हो रहा है. इट्स प्रॉपर एविडेंस बेस्ड साइंस बैक्ड मैकेनिज्म. स्पर्म एनालिसिस करवाना है, AMH टेस्ट करना है, antral follicular count check करना है. It's properly evidence based and based on that you treatment. I'll tell you very funnily, we have all passed through schools. हमारे स्कूल में हमें क्या एजुकेशन दी जाती है? सेक्स एजुकेशन. बच्चा कैसे नहीं करना है, अगर ये करोगे तो बच्चा हो जाएगा. कभी भी क्या किसी ने फर्टिलिटी एजुकेशन दी है कि अगर आप 35 तक फॉर अ वुमेन इफ यू डोंट have a baby, then your AMH is decreased, you will have difficulty in conceiving if you are. Does anyone teach that to in a school? Does anybody, any student or any boy is getting, thought that, let me get my semen analysis done, just for the sake of it. Like we get our blood test done, we get our LFT, KFTs and all sorts of things. But nobody would get a semen analysis done because that is related to my mardangi. भाई कम आ गया तो मैं बोल नहीं सकता, तो I am not a man or I am not that big a macho man, but nobody would get that done. The awareness is only about how not to have a baby rather than giving a proper fertility channel. That at that age, your hormones are at a high, you are extremely fertile, it's very easy to have a baby. So what are the steps not to take?
You mean they also need to be taught that?
Exactly.
What is the best time for you to procreate, to contribute to the content. So that may be
true. So we require to give not sex education but fertility education. Yes, yes. There is a right time for everything.
Yes.
Do not think that it's up to you. I am 40, I am 36, I am 31. Ab to main karunga and ho jayega. That does not happen, and that's what we are getting to see when we are seeing couples every day at our centers.
Wonderful. No, I think a good suggestion, but somehow for all our problems, we start going to the school. So you need to address anything in the world under the sun. You want to reduce air pollution, you want to improve cardiac health, you want to improve
It's not
fitness,
that. I will disagree. देखिए आज के दिन में it has to be a storyteller. We have media with us. You are a media partner, you are a media company. Through podcasts, through Instagram, through Facebook, and it has to come out. When you say it's a social stigma, मैं अगर सारे IVF कपल जो मेरे पास आते हैं उनको बोलूँगा just go out there and say कि मैंने IVF कराया है. How many of think can you give me a number out of 10? How many will actually come out and say that we have got an IVF done?
Yeah.
Less than 20%. So because that is why the narrative does not change. Because people still, they will get the treatment, but they will not tell to the world that they have gotten the treatment.
Yeah, so that has a lot of those social aspect, those personal aspect, the emotional aspect which you said about, the so-called Mardanigi and the so-called, are being capable enough to produce children, for whether it is for male or female or for a couple as such. But, the feeling of that there is something deficient in us. We are not, so that is also somehow, and it may take a long time to, really get out of it. But yes, as a treatment, as a scientific intervention, IVF definitely need to be looked at a very different lens, and something which should be reached out to or should be looked for as naturally as we look for an intervention for cholesterol or an intervention for heart problem.
Intervention for AMH also. For example, if you see young girls between 20 to 30, if they go for the AMH testing, their AMH will be very, very low because of the lifestyle, changing food habits and all that. So that awareness has to be created in that segment also. भाई आप जाके अपना AMH भी check कराओ. जब 30 में जाके जब वो शादी होके जब वो they will try, then they will come to know. So at least they can go for the egg freezing and other things, which is available in the IVF. Okay.
Absolutely, absolutely. So while we look at that on the business side also, we in the past discussion also we heard that we need to open more centers, we need to expand, and IVF service is being looked at as a substantially lucrative business in India, from Blackstone to Temasek to who not is putting money in this particular thing, which is good to take it to, and I'm sure they will be driving a lot of responsibility also. How do you map the the business growth or the sector's growth
Sector growth is that, for example, IVF volumes in the clinics and regions and how the our molecules are doing, what is the result, efficacy about that, how many patient cycles we are serving. Like that we sector. Otherwise, if you see, we do clinical, commercial, emotional, all the three impact is a collective effort of all the three parameters by which we see that how we are influencing more IVF centers depending on their demand. For example, it is not that mapping the business on the numbers. How many patients, how many couples, cycles we are impacting. So that is important.
So from the cycle point of view, I think the number says around 2.5 lakh cycles we are doing.
Around 3 lakhs.
3 lakh maybe by now. 3 lakh cycles, and we have how many centers across the country?
5,000.
5,000. Is it, kind of in align those numbers, 5,000 centers, 3 lakh cycle, or we have more centers than the cycles?
You cannot actually just correlate the
because
treatment.
I think
and
I also got to understand that a lot of centers which we see are sometimes just a collection center, or those referral or those.
No, so that has been streamlined by the government because there are guidelines. There are level 2 ART clinics, level 1 ART clinics, which is properly defined. Level 2 clinics are those which have a lab, which have a proper IVF lab where the procedure happens. So you have approximately 4,500 plus centers registered with the government.
No.
As a regulatory body, yeah.
No, I don't think that. I think the last registration is already, I think, nearly 400 or so only.
No. They're way more than that. A level 2 ART clinics. That's public data.
Okay.
So that's so the point being, everybody is talking about there is a huge untapped market. There's a market which we are seeing when you're saying 3 lakh IVF cycles, 2.5 lakh IVF cycles, which is being catered to. And there may be regions, multiple, tier 3, tier 4 towns where you do not have IVF at all. When you say Blackstone is coming, Temasek is coming, TPG is coming, IHH is coming, all of them, why are they coming is because they see the potential. We may see infighting and marketing and guaranteed IVF and schemes like that. But from a broader horizon, from a bird's eye view, you will see the untapped Indian population. Ab similarly, China ke numbers relate kariye. China is now lesser population than us. But how many IVF cycles are they doing? They're doing more than 1 million plus IVF cycles.
1 billion?
Million, sorry. No. So they're doing more than that.
Okay.
So when you see why are they doing more than that and we are having a bigger population and less than that, or why is US also doing more than the cycles in India? That is when the numbers come out, So it's all data driven. I would like to tell you that IVF as a science-backed, data-driven model with everything, and it is not 100% success rate. So when people are undergoing one cycle, they have to undergo a second cycle, probably a third cycle. They see that there is a lot of scope in improving those success rates also. There will be couples, there will be people who will be ready to pay probably a premium if you can, do something. Get AI involved, get better media involved, get some other technology involved at a higher cost which can improve the success rates.
Right.
So the market is evolving with more potential, with an untapped potential. And that is where the India's growth story lies for the fertility industry.
Wonderful. So when the numbers are all, I think, in right direction and need to be enhanced, there is no need of being apprehensive that how many centers are being opened, why do we need more people, why do we need more children. I think all that is answered. To change a lot of that perception, how the business leaders like you can start talking beyond numbers, can bring those important storytelling to the people. What is the responsibility as a business leader you see that you have to now, kind of start taking up a different way of communicating to the people, or, the storytelling of that, the need of that, which can not only impact for the better uptake of IVF, driving more responsibility in the practitioners or let's say the stakeholders, but also can nudge the policymakers to really look into it as a empathetic issue where they have to bring that intervention, not only for the sake of a couple, but also for the long-term benefit of the country as to continue to have that demographic dividends and a sustainable population.
I think, as rightly said by Sarthak also, a lot of awareness is required in that segment. Because still, I think in urban, a lot of good things are happening, awareness is there. Digital platform is one platform which I think can definitely do wonders and penetrate all social media like Instagram, newspaper, print media and everywhere. I think as a collectively, company should also partner in digital platforms and tier 2, tier 3 cities. In rural areas, if you can do some nukkad natak like that to tell about कि नुक्कड़ नाटक की इनफर्टिलिटी क्या है, तो उसके बारे में अगर हम उस नुक्कड़ नाटक के थ्रू डिफरेंट इलाके में हम जा पाए तो वो अवेयरनेस कंपनी हैज़ टू सपोर्ट दैट एंड मिल के अगर हम लोग अवेयरनेस बढ़ा पाए तो आई थिंक इट विल क्रिएट लॉट ऑफ पेशेंट पूल. Patient will turn up and stigma and whatever the taboo is there. Definitely we can bring more patients. That is the biggest barrier, I think. So collectively we have to do a lot of awareness about that, and that is the reason you told why Blackstone and everybody, because they see the potential in the market. Huge potential is there in the market. But turning of the patient is less. That we have to bring the patient. How we can bring the patient collectively, it's the effort of the company, of the IVF chains, IVF centers. Everybody has to do collectively to create more awareness in this segment.
I think good point, and I believe your company and many other companies will try to start investing to the level of the that grassroots level, engaging those important stakeholders like gram panchayats and all that, which can help in terms of spreading the right messaging. Gram panchayats or those places have always been the places of the messaging hum do, hamare do, and more for family planning, which is about how not to have kids or why not to have kids, rather than the messaging has to change there. And maybe government, before the government step into that, it is the responsibility of the industry also to look into how do you see this, Sarthak?
So first of all, I think we have to be storytellers ourselves. We are part of the process. Nobody is. And if I would ask the audience now, 90% of the people don't know what the process is already. किसी से भी पूछो, बहुत painful होगा, तो बहुत दर्द होता है, मैंने सुना है, ऐसा हो जाता है, वैसा हो जाता है.
Emotional pain होता है अगर cycle fail हो जाता होगा.
Emotional भी होगा, financial भी होगा, but क्या is it an invasive procedure, non-invasive? Is it day care that आप आज कराए हैं, उसके बाद आपको काम पे जाना है, आप ऑफिस भी जा सकते हैं. There are people, IVF happens that way. You know, when you get the procedure done after probably your embryo transfer, you can go back to the office post that. People are not aware when we are talking about, and I actually believe that, we as, who are in the fertility industry, as healthcare specialists, we need to humanize the process.
So tell me one of the story which you found most moving and where you really felt that, okay, what you are doing right.
No, okay, for us, when I have always told, कोई भी couple आता है, देखिए, apart from a patient testimonial, which is our marketing, but if they go out there, if they humanize the process for me, अभी क्या है वो process ना ऐसा है, कभी कोई थोड़ा known to, मान लीजिए थोड़ा celebrity type आएगा ना, तो ऐसे टोपी पहन के ना ये छुप के बैठा रहता है, अपनी शक्ल ही नहीं दिखा रहा होता वो, किसी भी तरीके से भाई छुप जाओ, दिखाई ना दे कि मैं IVF center में आया हुआ हूँ. So they are trying to avoid the cameras ki bhai, as if it's a taboo that they have entered to an IVF industry. So that is one thing which I say, that fertility in men, our sperm count, our motility, morphology, whatever parameter that we have can be affected without our knowing. We will never get to know how it is affected. Because it's our lifestyle, it's our diet, it's the chemicals, it's the environment, it's so many things that आपके control में जो चीज़ें नहीं हैं, how do you actually make it happen for you? But if it's happened to you, it's not a big problem. It's not a taboo. It can happen to the best of us. From athletes, to a fat person, to someone consuming liquor every day, to consuming someone who hasn't had liquor at any point of time, किसी को भी हो सकता है. But अगर हो गया, तो चिंता की कोई बात नहीं है. तो वन इज दैट कि वो टैबू हटाना. सेकेंड, जैसा मैंने बोला कि ह्यूमनाइज करना है. आज अगर कोई बोलता है ना, उसको दिखाना है कि येस देर आर ऑलमोस्ट 20-25 इंजेक्शंस. सिरिंजेस अगर मैं लगा दूँ ना एक टेबल पे कि इतनी सिरिंजेस लगती हैं, तो प्रॉब्ली लोग डर जाएंगे, अरे इतना. बट दैट्स पार्ट ऑफ द प्रोसेस. दैट्स एक्चुअली द ट्रू पार्ट कि भाई रोज़ एक इंजेक्शन लग रहा है, शायद 2 लग रहे हैं, किसी दिन 3 भी लग सकते हैं. पोस्ट क्या होता है, द अवेयरनेस अबाउट द प्रोसेस इज नॉट देयर. एंड कैन यू बिलीव दैट, सबसे बेस्ट बात है, आप कभी भी कोई आपका रिलेटिव नोन टू हॉस्पिटल में एडमिट होता है तो आप उसको देखने जाते हैं. कभी लाइफ में सुना है कि कोई IVF सेंटर आए और आप भी मिलने आ रहे हैं उससे? कोई बताएगा? दैट इज द साइकोलॉजी एट द ग्रास रूट लेवल दैट वी आर ट्राइंग टू चेंज. और वट आई एम पर्सनली ट्राइंग टू टेक आउट द स्टोरी कि भाई यस, जैसे आज के दिन में वेट लॉस है, अगर कोई इंजेक्शन लगा के पतला हो रहा है तो बता रहे हैं मैंने ओजेम्पिक लगाया, मैंने मुंजारो लगाया, दैट इज़ माई की. मैंने कोई मेहनत नहीं करी, मैं ऐसे कोई भाग नहीं रहा था 4 घंटे दिन में, कोई जिम के अंदर 2 घंटे लगा नहीं हुआ था. इंजेक्शन लगाया, एपेटाइट सप्रेस करी और मैं हो गया पतला. अनलेस दे कैन गो बियॉन्ड दैट टैबू. अगर आज वेट लॉस उनके लिए टैबू नहीं है, तो फर्टिलिटी ऑल्सो हैज टू बी गो टू ऑलमोस्ट इक्वलेंट टू दैट लेवल.
So obesity has also, I think,
that's also one of the reasons why,
dealt
yes,
with that. That also has a taboo, that also has a stigma, that also has that perception that you know why somebody is obese, and there may be some certain when you feel, and since both of you are again industry leaders and a big runway for you to contribute to that, and you do see that we need to de-stigmatize infertility. We have to make it, people understand that this can happen to anyone, and when it happens to anyone, there is a care available which is scientific and which is just supporting you as it supports, as you know, in many other diseases. As naturally as you take a, you know, a statin to reduce your cholesterol or something like that. So do you think that the industry collectively should create some platforms like you have you know, certain platform, you know, certain collective messaging going on by the mutual funds? This mutual fund sahi hai. So this is not a one company running it, but the body which represents that is running that campaign. I think Dr. Patki will come, we can put this responsibility on his head, or maybe we have Dr. You know, Talwar here, he can take that up. But you know, like mutual fund sahi hai, और अच्छा किया, insurance लिया. So these are all collective messaging which somehow, you know, make people understand that this is something which they can go for. So there can be a better infertility, like obesity is not a disease, though it is being run by one company. We can say infertility is not a disease, and which
actually जैसे obesity आपको आते हुए दिखाई देती है, infertility is और hormonal, आपको कभी नहीं पता लगती. तो there is something when you say, you know, कि is open to your eyes, कि आते हुए पता लग रहा है मैं मोटा होते जा रहा हूँ, and people are not afraid to say कि we have taken an injection. Similarly, and you're right saying कि ऐसे digital health platforms हों, patient outcome stories हों, जहाँ पे patient खुल के बोले हमें हुई and हमने शायद अपनी story से देर कर दी. I thought कि भाई जैसा बोला 38-40 का हो गया, तब जाके you know, मैंने प्लानिंग करने की सोची. ये अगर कोई आके बोलेगा तो शायद लोग कनेक्ट कर पाएंगे. लोग बोलते नहीं है कि हमें क्यों हो गई, हमने क्या सोचा था, हमने प्लानिंग अपनी खुद लेट शुरू करी, आवर फर्स्ट प्रायोरिटीज वर डिफरेंट इन लाइफ. अनलेस पीपल स्टार्ट शेयरिंग अप कि व्हाट वाज द रीजन व्हाई दे डिलेड देयर marriage, why they delayed their procreation, why they did not want to, you know, start a family soon, what was their first priority to go to Maldives and, you know, spend and then roam around the world. Unless people start saying up ki yes, probably if we had done this 3 years ago, people will relate. It's all about creating that human relation to the problem that someone else has faced.
Great. So I think I have already got the message to wrap it up. Is there any question from the audience? If anyone want to ask, we can take one question. Sir, you want to ask something? Okay. Can we get a mic for him? No, there is at the back near camera. Quick one, only one question.
Okay, sir. Sir, in UAE, we can't discuss about the IVF.
In UAE?
Yes, sir.
Okay.
We can certainly discuss about IVF. UAE में सब
अभी हम इंडिया में हैं तो UAE का इंडिया से क्या रिलेशन है एक बार आप हाँ
because some reason the women women can produce the baby, not a man, first of all.
Women tend to
This is a big question. ये बोलने में 10 साल और लगेंगे इंडिया के अंदर.
आप क्या एक बार फिर से बोलिए, समझ में नहीं आई बात आपकी.
सर डॉक्टर सिद्धार्थ बता देंगे.
हाँ नहीं डॉक्टर सार्थक. हाँ
सॉरी सर.
ये डॉक्टर हैं डॉक्टर.
हाँ क्या क्वेश्चन है आपका, आप हिंदी में पूछ लीजिए.
सर क्वेश्चन तो बहुत सारे हैं लेकिन एक
ही पूछ लीजिए. हाँ
मतलब IVF को इंडिया में प्रोड्यूस करने के लिए शर्म आती है. वाई?
अच्छा IVF को
सेम थिंग जैसे हमने बताया कि किसी को भी ट्रीटमेंट चाहिए होती है तो वो आगे आके नहीं बोलता है. एंड उसका रीज़न जैसे बार बार बता रहे हैं कि इट्स नॉट आज 50% ऑफ द इनफर्टिलिटी इज ड्यू टू मेन, हम जैसों की जैसे मेरे जैसे लोगों की वजह से, हम मर्दों की वजह से. बट हम आके नहीं बोल पाते हैं कि प्रॉब्लम हम में है. थोड़ा सोसाइटी का जो थॉट प्रोसेस रहा है, और आज से नहीं सदियों साल से चला आता रहा है 500,000 साल से, कि ये विमेन रिलेटेड प्रॉब्लम है, जो अब नहीं है. मैं आपको अगर असली में आंकड़े बताऊंगा तो WHO पहले जो एक सीमेन एनालिसिस स्पर्म काउंट होता था वाज 100 मिलियन. मेरे फादर के टाइम पे, मेरे दादा के टाइम पे 100 मिलियन अबाव. आज WHO ने उसको स्टैंडर्डाइज करके 40 मिलियन कर दिया वो वैल्यू. एंड कुछ ऐसी स्टडीज आ रही हैं जो कह रही हैं 2050-55 तक भाई स्पर्म काउंट इतना डिक्रीज हो जाएगा कि प्रॉबेबली 1 मिलियन 2 मिलियन ऑन एन एवरेज रह जाएगा. तो आप ये देखिए कि मेल इनफर्टिलिटी कितनी बढ़ती जा रही है. एंड जब तक सोसाइटी हम लोग एक्सेप्ट करने को तैयार ना हो कि इनफर्टिलिटी कैन ड्यू टू बी मैन, इसलिए थोड़ा ज़्यादा स्टिग्मा रहता है.
सर एक क्वेश्चन और था जो कि बोला गया कि भाई हमें थोड़ा सा ट्रांसपोर्टेशन में थोड़ी दिक्कत आती है. रेड हेल्थ एक कंपनी है, उसके सेंटर्स बहुत ज़्यादा हैं. तो जैसे हम EMS पे जाते हैं, इमरजेंसी मेडिकल सर्विसेज में, तो कुछ ऐसे भी सर कुछ ट्रांसपोर्टेशन अवेलेबल हो सकती है सर?
बिल्कुल, हम कोलैबोरेट करेंगे रेड हेल्थ के साथ. आप मिलिए बाहर, हम लोग कोलैबोरेट करते हैं और आपके थ्रू ही हम पेशेंट ट्रांसपोर्टेशन करेंगे.
थैंक यू सो मच.
Thank you very much.
So much, Dr. Rajiv, for being part of this panel. And I wish that we will reach to a situation where we all can openly accept. We can also post a selfie from IVF center that just visited an IVF center, which may encourage others also to really look at it as just a normal, health condition. As we get into multiple other, because of multiple reason, some are choices, some environmental, but nothing to be too, shy about it or being stigmatized about it. So thank you so much all of you for joining us today, and thank you our esteemed panelists.
Thank you so much to the panel. May I please request Amrita from IHW to felicitate our speakers. Thank you so much, everyone. Ladies and gentlemen, we now move into a focused clinical keynote one that addresses a challenge that affects a large and growing number of fertility patients and often leaves them with more questions than answers: low egg count. This condition, often misunderstood and poorly communicated, has major emotional, biological, and financial consequences for patients. But science today offers us a spectrum of viable pathways, from advanced simulation protocols to donor programs to embryo pooling and beyond. And who better to guide us through this landscape than Dr. Gunjan Gupta? Dr. Gunjan Gupta is the founder and director of Gunjan IVF World, a pioneering fertility chain that has impacted thousands of families across India. Known for her transparent communication and sharp clinical acumen, she combines compassion with precision. With centers that serve both urban and semi-urban communities, Dr. Gunjan is at the front line of India's fertility dialogue, especially when it comes to tackling low ovarian reserve and premature ovarian aging. Please join me in welcoming Dr. Gunjan Gupta as she speaks on low egg count, exploring viable pathways. Over to you, ma'am.
Thank you. Good afternoon, everyone. So it is a moment of pride for me and all IVF fraternity to celebrate this day. So it's a pleasure to be here, and I want to thank the team IHW for organizing this event and giving us all a chance to come and speak from the platform. So good morning, everyone. So here we are. We know we are tackling with everything which is low in this world, whether it is low eggs, it is low sperms, it is less IVF centers, it is less finance. So it is a world of low, I feel sometimes. But yes, we need to start thinking positively. उसी में से उन्हीं तिलों में से ही तेल निकालना होगा is the strategy today. क्योंकि we have to understand the woman of today. You can't tell her you get a donor egg. It's so difficult, you know. Recently my embryologist said, ma'am, you always give me 1 egg, 2 egg, 3 egg, और फिर आप कहते हो pregnancy करनी है. How is it possible? मैंने कहा, Bhupen, his name is Bhupen. I said, समझ जा, भाई तुझे eggs भी इतने ही मिलने वाले हैं और कुछ ज़माने में sperms भी इतने ही मिलने वाले हैं, and we have to give a pregnancy if we want to really do good ethical work and respond to the women of today and tomorrow. Where do you think the Gen Zs and the millennials and they are going to head? Things would be to the So where are the Gen Zs and the millennials going to go? We don't know actually. I have a young daughter and she says, Mom, don't even think about it. Though I am trying to feed again and again. No, 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 no. Marriage has to be on time. Shadi has to be on time. Bacha has to be on time. But they are a different world. So we will, and you can sort of talk to one person, but what about the rest of the world? So yes, low egg count and exploring viable pathways. I am Dr. Gunjan, so I don't think there is much there. What I want to start is that as far as Gunjan IVF World is concerned, a little about things. We started in 2016. So IVF, I came into IVF, you can say industry or IVF as a field since 2016. Before that, I was practicing as a laparoscopic surgeon. I have been trained from KGMC and UK, and I was not really interested. But when I was doing laparoscopies, I realized that you reach an end result when you can't give them a baby, and that is where I started. But yes, we have been very lucky with that, that already we have worked a lot on innovations and technology. So we already have 2 posters which we have presented in ESHRE over the past years, and this year I really feel proud to share, because it is for our entire fraternity, that 2 of our papers have been accepted at ASRM. And as I had heard Keshav talking about AI, so that this is actually an AI dose calculator which we have made on the basis of BMI, AMH, AFC, and it has been done by my daughter who is an engineer, and on a regression analysis we have already done. So this is how we can scale. You know, the best part of this is what is the use of this paper. The use of this paper is for scaling, because you fill in these parameters, it will give you a dose for 10 or 11 days, because we have put a capping at 11 days of stimulation max, and it gives you a dose based on HMG and FSH, and it is really, really effective. So you don't need to do so many scans, you just need an AFC on day 2. And of course, we are doing trial of this test, so soon, maybe a year later, we will have better things. We will maybe doing some modifications also, but this is how we begin. And of course, another poster which I have written has been accepted, that is based on tuberculosis, about the Indian multicentric study. We need to understand that this is also something which is important. Nobody internationally talks about tuberculosis, which is rampant in our country and a major cause of infertility. So of course, this I will skip this journey. I started in 2016, and now we have 4 centers and 5 OPD centers, and we've been very, very lucky being awarded so many times, and both by Foxy and other bodies like Times of India, etc. So basically exploring viable pathways. So I would begin, what do you think the being healthy is? Many people will say disease free, but is there anybody can say, sitting in this whole place, that he has never been diseased, बीमारी हुए ही नहीं, ऐसा नहीं होता है. So basically health is not an absence of disease, but it is the ability to rejuvenate ourselves, to grow, springboard from every adverse situation and rejuvenate yourself. So it is rejuvenation which is being healthy, and that is what is the woman of today. Of course, we have a lot of celebrities who have been rejuvenating themselves, so we can rejuvenate our skin, we can rejuvenate our hair. Why not the poor ovary? Why should we leave her behind? So that is why we have to understand that aging is a rule, and declining ovarian reserve is also a rule which every woman has to understand. We are all aware of this. I have a very learned audience sitting in front of me about how the primordial and the primary follicles, and then it is the preantral and the antral follicles which are sensitive to FSH, and that is how they are follicles which are recruited, and once they get recruited, and then they develop, and then there is final ovulation. Of course, ovarian reserve, when we talk about, we are dealing with 2 things. One is the quantity and other is the quality of the reserve. So as the women age, they have fewer eggs, poor egg quality, increased chances of miscarriages. But the most important thing what we need to understand is, after 35, 1/3 of the women will have a difficulty in conceiving a baby. This is the message which we need to give to our people when they are delaying the pregnancy. Of course, we are aware of what these tests are. It is how do you assess the reserve, by means of AMH, AFC and age. So what I include in my counseling nowadays is what everybody needs to understand, which is the first organ to age in a human body. Do we talk like this? It is the ovary. After 38 ages, do we ever think about it that way? No, but it is a fact. So this is a statement which I have started making a part of my counseling ever since I sort of really hit on this fact like this. Of course, there are a lot of other variables associated, genetic, health, causes of infertility, years, nutrition, which leads to a low reserve. And influence of age we are aware of. It is mitochondrial function, granulosa cell apoptosis and oxidative stress which leads to. Influence of age we know as the number of oocyte which is retrieved from a younger person. If it less than 30, if it is around 15, it is less than 5 the moment she touches more than 40. And also the aneuploidy rates increases, we are aware of that. So how does it, sorry. So basically the most important part of this slide is, we all know is that when it is 6 oocytes which will give us a euploid embryo, above 40 it is the 16 oocytes. And where are the 16 oocytes? Who will give us those 16 oocytes at the age of 40, 41? Poseidon criteria age related, so it is not only the age but and the AMH which affect, but it is a multiplicity of factors, and that helps us to define the Poseidon criteria, which helps us making the decision. So what can we do? We have talked about how to assess, how do we know, how do we do, but how do we do, what do we do when we are stuck with? There are few things which are new, few things which are experimental. So basically these are the pathways which we need to do. So basically ovarian rejuvenation with PRP and stem cell, which is coming in the new way. Here what do we do? PRP, we know it is autologous, it is made from your blood, it can be injected inside the ovaries, and it, since it is a set of growth factors, it helps to rejuvenate the eggs, and it can be offered to women theoretically under 50, but of course I would say somewhere around 40, 42 we should take as a benchmark. Infertile women, women with premature ovarian failure and premature ovarian insufficiency. I am doing personally a lot of work on this thing, on ovarian rejuvenation with PRP. And what we also do at times, it we give GCSF, which improves the harvest of PRP, I can say. So it is injected directly into the ovaries, releases the growth factors and stimulates the endogenous stem cells to differentiate into eggs. Technique is very simple. We have lot of now kits available in the market which can be directly used. Initially we started by doing entire centrifugation ourselves and separating the plasma, but now there are kits which come with gel and they can be done. This is a video how the PRP is made. Video of the subendometrial injection, basically hysteroscopic, but what we are doing again is a OPU needle which we are using for vaginal instillation. And this is how the ovarian PRP procedure is performed. It's a simple technique. Somebody who is doing OPU, it is not a big deal for at all. The moment we inject, we'll see a white splash which is very easily visible. Basically, what I'd like to here give a word of caution for the ovarian PRP procedure is that a lot of young people are sitting. It is not easy as a pickup, reason being the ovary is much smaller, very firm. Sometimes when you are going in, you have to be very, very careful because you are doing it ultrasonologically, the major vessels are on the side, so you should never overshoot with the needle. Of course, there is evidence which says that preliminary evidences show that it may be of limited benefit, but of course when we are left with nothing, it is better we can offer to the patient, but definitely tell the patient that this is also under study, the patient should be aware. And as Cochrane has said that the information is insufficient, so further studies are needed. Stem cell works on the similar principles, just it is more invasive because to extract stem cells we have to do 2 procedures, give general because it's the iliac crest which is involved. So personally I have more experience with giving ovarian PRP. Now there is a new thing around the corner, which is the role of exosomes. Exosomes play a significant role in ovarian aging, and by acting as a communication vehicles in between the cells, what has been found that exosomes help to rejuvenate the ovaries very well as well. There are preparations which are available in the market, not available in India. I have been trying, I did a lot of chat GPT as well to get the exosomes. I left a message with Nath Brothers also, but somehow I did not get it. But I know something is available. There is, I spoke to somebody in South America as well. She was preparing it herself. I couldn't really get a hang on that, so, but yes, it seems to be very, very useful. And the best part is that exosomes also is found a lot in follicular fluid. So that means it is important, it can directly interact with the granulosa cells and the oocyte, impacting their development and survival. So basically, I don't know, it seems very far-fetched, but maybe the follicular fluid can be used to extract the exosomes as well. It is like a food for thought, which I feel people should think about it, and there are a lot of pharma people inside, they can use their R&D division to come with something like this. So it is something, this is how exosomes
are
work.
tiny nanoparticle
This is the principle of
that
exosomes. How
facilitate cell-to-cell communication. Exosomes are created by inward budding of endosomes and then secreted out of the cell membrane. Exosomes carry with them cargo, including proteins and nucleic acids, which they deliver to other cells, a bit like a message in a bottle. Once delivered, the cargo affects how the recipient cell behaves.
So this was about exosomes. So what's next? Yeah, this is another very interesting paper which I happened to just surf along. So this was an article in Forbes, and what is it? It says that AMH is a hormone which inhibits the recruitment of follicles. So they feel that if they give the woman AMH, maybe they will be able to delay menopause. Wow. So, and actually Viva Therapeutics is working on it. There was this article which has come in Forbes, so we may get to hear something like this, because every month the fact is that about 1,000 eggs are recruited and only one goes for ovulation. So what a waste of the eggs and what a waste of the hormones. So if we have something like this, they might be there. And lastly, what is the most important, another thing which is like when we are exploring the ways, the hippo pathway. I remember when I was doing medicine, there was nothing like that I remembered of studying the hippo pathway, because the entire study has been done over the last 20 years. So basically what they are saying, that hippo signaling pathway, it maintains primordial follicles in dormancy. Basically what it does, it's a very interesting pathway. What it does, it is the one which is responsible for what will be the size of growth of the organs, how will they develop, how will they not develop, koi ovary itni badi hogi, itne eggs honge, or any other organ, what will be the size of it. So basically it is the controlling, the size controller and the functional controller is the pathway. So what we do, if we disrupt the pathway, maybe we can activate the dormant follicles and their growth. So what they started doing, IVA is in vitro activation. What they did was, laparoscopically they cut a segment of ovarian cortex, they brought it out. Initially they kept it in vivo with AKT stimulators, and then 2 days later they did another laparoscopy and reinserted it either in the same ovary, contralateral ovary, or near the fallopian tube. Now is the time when they have already modified on that, and now they are doing a drug-free IVA. What is drug-free IVA? They are doing one sitting laparoscopically. You take the ovarian cortex, a part of the ovarian cortex out, cut it into small pieces of 1 mm, and then re-inject it in the contralateral ovary or in the same ovary. And it is supposedly giving very good results, because already we have a 2-year data on that from 23 to 25. We say 26% of the women showed follicular growth, 36% approximately were pregnancy rate among poor responders, and 21% actually had a live birth rate. For 2-year data, I think it is amazing. So there is something which we need to do about it. Maybe we should also start talking, discussing, and so how to go about it. So this was the major thing. Of course, then rest is laboratory options, ICSI for all, PGT ovarian pooling, we are all aware of, we are already doing that. Role of adjuvants, we are all aware of all the adjuvants which are there, androgens, DHEA, testosterone, then growth hormone, then antioxidants, coenzyme Q10, melatonin, luteal phase pre-treatment, and during stimulation you can give recombinant LH. So this was all about the adjuvants. The data has been limited. DHEA, they say it may help in poor responders. Testosterone, they may help in poor responders, but we know about the T-transport trial which said it was not effective. But yes, we all do use testosterone, because even Polizos feels that he did not use the adequate dose of that. Pre-treatment antioxidants, they are something which are low-hanging fruits which we do keep on using them. But of course, it is empirical, and again there is melatonin, which is another antioxidants. So this was about what we can do in a woman of low reserve. So now what we can do for the younger generation, we need to maybe educate them. This is a time for education. Like we started educating about cervical cancer screening and vaccination. Now majority of the girls get it done. So this is a small
Priyanka
video.
Chopra Jonas had her first baby at 40 without even getting pregnant. How is that possible? Is having a baby at 45 the new 25? Well, with egg freezing, it just might be. We already know what is egg freezing, but a lot of times we have a lot of questions as, what if I become infertile after it? What are the side effects? What if I'm not married? What if I am not sexually active? Well, to answer all of these questions, let's speak to Dr. Gunjan.
Well, even if you're not sexually active or unmarried, it can be done, because it is done by a fine needle using an ultrasound, which is just like using a tampon. Also, this procedure does not lead to infertility for sure, because we are using the eggs which would have been otherwise destroyed, as I mentioned in my previous video as well. So if required, it is safe to go ahead.
Well, that is reassuring, but I am wondering, when is the right time to start egg freezing? How long can my eggs be frozen for?
Well, it goes without saying, the younger you are, the better is the egg quality. Best age I would rate as 25 to 30 years, though you can freeze it 35, 37, any age when you realize it. Also, how long can it be frozen? Very interesting, because there is no upper limit to it. You can freeze it for 10 years, 15 years, though majority of the time it is frozen between 5 to 10 years.
So guys, that's a wrap on all things.
So this was an educational video which I had created with my daughter. So this was it. So of course we are aware it is the race against time, and that is why I have written a book also on egg freezing, and it will be my pleasure if I can have all the seniors coming with me for that. So this is our success rates. Basically, one success rate is low AMH cases. This was last year data, and what we see, even in 0 to 0.5 and 0.5 to 1, we have a success rate averaged out around 65%. What I am trying to say is that we should not just shy away if a woman comes with low reserve and offer donor eggs to her. Of course, here I just want to give a background, because there are a lot of students here, that we have a GIFT Academy, and we are training youngsters in various programs, and if they want, they can join our fellowship program. IFS has also helped us to be a part of their academy as well. The amity exam is being held on 27th, so you can give the exam for that and choose the centers to your choice. So I think thank you. That is all, and thanks everybody for your patient hearing.
Thank you, Dr. Gunjan, for that interesting presentation. For the launch of the book, may I please invite Mr. Kamill Narayan, Mr. Narendra Malhotra, Mr. Jaideep Malhotra, Dr. Pankaj Talwar, Dr. Indrani Lod, and Dr. Professor Shweta Mittal Gupta on the stage. Dr. Jaideep Malhotra as well, please. Yeah, please. Can we please have a huge round of applause as we launch the book? Let's keep the applause going, ladies and gentlemen. Thank you. Thank you, everyone. Ladies and gentlemen, as we move forward with the day, it's time now to explore a domain that is truly at the cutting edge of reproductive science, where technology meets time and choice meets biology. Welcome to session 3, Preservation and Genetics, where we will discuss how fertility preservation and genetic interventions are redefining the very idea of family planning in the 21st century. From egg freezing and oncofertility to pre-implementation genetic testing, this session will delve into the tools and choices now available to help individuals and couples take control of their reproductive future, not just as a response to medical necessity, but as a proactive, empowering choice. We are honored to be joined by an accomplished and diverse panel of experts who bring clinical, ethical, and practical perspectives to this conversation. Introducing the panelists, we have Dr. Professor Shweta Mittal Gupta, who is the co-director of the Department of IVF and Human Reproduction at Sir Gangaram Hospital and the Secretary General of IFS. She brings unparalleled experience in reproductive endocrinology and is a strong advocate for safe and ethical fertility preservation. We have Dr. Jaideep Malhotra, Managing Director, Rainbow IVF, who is a global name in reproductive medicine. With decades of experience and innovations to her credit, she is a trailblazer in genetics, fertility access, and women-centric care. We have Dr. Vasundhara Jagannathan, Managing Director of Sri Chakra Fertility, who is known for her patient-first approach and her advocacy for awareness around fertility preservation across different age groups. We also have Dr. Rita Bakshi, Chairman, RISA IVF, who is a well-respected voice in both clinical IVF practice and patient counseling. Her expertise includes both conventional and emerging fertility preservation methods. Our moderator for this panel is Dr. Zainab Zaidi, Country Director at TIMOS. With deep experience in quality, ethics, and cross-border reproductive care, Dr. Zaidi brings the perfect balance of insight and inquiry to this nuanced topic. Ladies and gentlemen, can I please have a huge round of applause for all the doctors on stage? Over to you, ma'am, to moderate the session. I'll just get the mics. No, I'll just get the mics. Pleasure meeting you. Same here.
I think you can give the mics. Okay, you can share.
Good afternoon, everyone. I know it's a before lunch session, so let's wait a bit because we have all our experts and senior leaders from reproductive medicine here to deal and to talk about a very relevant and trendy topic that is preservation, genetics, and future of family planning. So welcome all of you. And dear audience, I believe that we had a very impactful session since morning. We talked about the social, the tier 2 requirements of IVF, the male infertility. We had a wonderful Dr. Gunjan's presentation on all the upcoming processes and innovations which we are we are actually witnessing in the industry. And here, nothing is, it's still a time, and I believe that we are on the right track, because the most important and most forward-looking session should be this, and I believe that we will come up with some very valid points to be taken for the advocacy, for policy making, because this is what we know, what we require right now. And with this, I'll request the panelists that we do reflect on very key questions, that how do we integrate preservation technologies into reproductive care? How should we ensure the ethical boundaries while using these genetical insights and technologies and accesses? And how could we scale it up to be more responsible, equitable, and also into a normal reproductive care? And how could we also deal with the challenges of ethical dilemmas and social responsibilities, and the youngsters, obviously, to deal with, to aware this and to educate them. So with that, shall we begin?
Yeah, sure.
Thank you. Sure. So my first question is to Dr. Jaideep. So we all know that egg freezing now is not a Western trend. It is popular, though more popular in the metros rather than the other cities. So from your experience, what do you think that how the Indian mindset is evolving around this preservation, especially when it is driven by, as our earlier speakers were mentioning, about the career planning, about the focus, the concern, the single parenthood, etc. So please, ma'am.
I think it's a very dichotomous kind of a situation, which we really need to deal with. We've come a long way. Women are now educated, they are very much career oriented, and sometimes, like Sarthak was also talking about, fertility comes like fourth in the list of priorities as far as young couples are concerned. And there's a lot of competition between men and women for, having a neck-to-neck career and life. And we doctors and also we mothers and we mother-in-laws are in the midst of all of that. Because we have to understand, and what I'm going to say here, where a balance needs to be sort of procured at a level, whether it's a metro or a tier 2 or a tier 3 city, it doesn't really matter. But what is important here is that prioritizing. And when we talk about freedom, we talk about choices, we talk about a lot of things, but we also have to think about that there's only a window for, and we are very privileged as women, where we only can produce, and there is only a small window where we can have a healthy child. So I started purposely with this, because there are a whole lot of options which are available to us, which are important, but to use the options wisely is something also which the onus lies on us when we are counseling them. Because we have now the technology, we have now all the affordability and a lot of accessibility as far as the metros are concerned. And I'm not talking about accessibility in the tier 2 also, because I am from a tier 2 city. And I can tell you, like, very recently, this is very recent, like a 19-year-old young girl, she had already had 2 surgeries for endometriosis, for a unilateral endometriosis, and imagine, like, what she was going through, and she came to me for the 3rd time. Now, my job is now to tell her that yes, fertility preservation is an option. So it's not only for just career-oriented girls or for, single mothers, but it's also for people who are having, early diseases like endometriosis, or they have malignancies, because they are also on the rise. So the onus lies on us to tell them about the options, and which are very important, and then show them the way. And she went ahead and she froze her eggs. She comes from Aligarh, so you can imagine, not even Aligarh, a village near Aligarh. So you can imagine, like, now the onus lies on us to give the right kind of counseling and the platform for them to sort of make their choices. Now, I work on a very different level because I've worked with the WHO. I have been the chair of the REI committee for FIGO. We came out with a position statement on fertility preservation because it's important for us to understand that not many of us are really educating young couples on fertility preservation, and it's not only for women, it's also for men also. And the ethical and the other cost benefit issues are also many, because a lot of people come and say only 8% of the people who actually froze their eggs have utilized it over the last decade. Now again, it's very important, it's all about choices. I want to bring this point because supposing if we have not done it, they'll never have the choice. And it's also like an investment which you have made. You may not use it in your lifetime, but you are very, very confident that you have an investment in place. You have your eggs, or you have your embryos, or you have your sperms, or you have your ovarian tissue. If required, I can always get it back. So I would say that yes, the sky is the limit, but I think we need to counsel our patients well about all the pros and cons and how to really ethically, help them in making their choices, which is again very important. Making a choice. We can't market social freezing in a way which we are doing without them understanding why, because then we are driving them towards very different kind of a environment and socially, because they are anyway following their peers. Yes. Most of them. So we have to understand all those things, and I think a good counseling is very, very important. Of course, the technology is available not only in metros but tier 2 and tier 3 cities also.
Yes, Dr. I believe that the ethical factor, the ethical issues and the counseling does have a very important role. In fact, the informed decision is important over here, and those are very important aspects to be covered. And as you rightly said, there are medical indications, and the oncology and those driven indications are there, and people don't know now they have an option, and this could be utilized in a very good way, in a very positive way for that. Thank you so much. I'll come back with few more questions. I have so many in my mind. So Dr. Shweta, the next question is to you about the PGT career screening and how the expanded genetic testing becoming a mainstream of IVF. How is it ensuring that women are making informed choices?
Okay, so when we talk of IVF and when we talk of genetic screening, I think genetic screening becomes 10 to 15% of the whole IVF cycle. It doesn't become the majority. Number two, I could be a referral center and I could be having more patients being referred because I have a very robust genetic department, and then maybe I could be doing much more genetic screening for diseases, for translocations as compared to others. But what is the actual need? The actual need is not more than 10 to 15%. See, the genetic screening, one important thing is giving medical treatment to the patient. The second is using technology which aids the medical treatment to improve the efficiency of the process. And third is the actual need of genetic testing. Now, for example, earlier we would only do karyotype of the patient. Now, the recent guideline in Gangaram, we have taken out that we should do SMA screening, how you are doing for thalassemia screening. So make SMA as a test of preconceptional screening. Then came DMD, Duchenne's muscular dystrophy. Then you see carrier screening. Then you see whole exome sequencing. Then you see whole genome sequencing. The question is that should it be offered to all the patients, right? Should it be offered? Now there is a small segment which is our oocyte donors. We are also offering genetic testing. There are a couple of couples who come to me and say we want to test, and then there is a recommendation by the genetic department that yes, you perform these many tests. But the most important thing is that as a clinician you should know that what you're ordering, why you are asking for that test, what is the interpretation of the test, how I'm going to counsel this patient when the report comes. This is very, very important. Now, for example, I'll tell you, an oocyte donor, the recipient tells me I have to get a carrier screening done. And once I do the carrier screening, she shares 6 disorders with the husband, right? And there is one health implication which the donor has, which my genetic department refused to declare. They said that that health implication we are only going to declare when the donor comes to us. So the cycle is cancelled. You know, there is a correlation of the disease. We know it, then it's fine. But then the second case scenario that this couple comes to me, husband is a carrier of polycystic kidney and he wants a genetic screening. He doesn't want his child to have this disorder. So I do a whole exome sequencing carrier screening for the couple, and suddenly both husband and wife come positive for a disorder called Lynch syndrome. Now this carries a risk of familial cancers. So now the counseling changes. So the whole scenario changes, and now I am also looking into the literature, then the whole, then I send them to a genetic lab, and the couple goes through a whole cancer gene screening of multiple cancer disorders, and it has been found out that parents are not carriers. So the bottom line is that we cannot offer genetic screening for Lynch syndrome, but we can offer it for polycystic kidneys. So there are hundreds of combinations. We have the technology, but just don't order it left, right, and center. When you are prescribing a test, you should know what I'm expecting, how I'm going to interpret, how I'm going to react, what is the clinical implication to the patient, how much is it relevant. That is very, very important. You have to be empathetic to the patient, you have to be ethical, you have to be under the boundaries of your regulatory framework. So genetic is a tricky branch, and it has to be used with the right knowledge. This is what I'm saying. And a robust genetic department is very, very important. Do not shy away if you cannot interpret. Just tell the patient, I'm going to look into the literature, I'm going to get back to my genetic department, I'm going to get back, we can have a combined counseling. So the technology is there, it's very advanced, many things are there, but they need to be used cautiously.
So, yeah, so a very valid point, Dr. Shweta. Thank you so much for that. I mean, having a referral system and a good experience, I mean, this is something very unique and very, odd one, getting 6 or 7 cancer traits in a couple. I mean, actually having them and then going for it. And I believe that very rightly you said that, yeah, we cannot just order the genetic testing for all, but yes, how should we counsel, what should be the criteria, and who would take the actually, the responsibility of doing so. So genetic centers are referral centers, your hospitals and your labs are tertiary care facilities, but the primary and secondary care counseling is essential because that's where the issue lies, and how should we go, those are also very relevant things to discuss and maybe to have a framework developed. So I would request Dr. Saab from you that more women today, we are talking about the solo motherhood through IVF or a social freezing. So what do you think should be a change in the law or the clinic setup? Because we have to have some governance, some ruling, some ART rules applicable for this as well, for genetic testing, for referrals, for consents, for decision making. So what do you think is available, and what do you think we should look forward to if not available?
So Dr. Zainab, our country and Prime Minister may look conservative, but the law that has come out is actually, he has, or let's say the art law allows single women to become parents. So whether IVF is allowed for unmarried, divorced, widowed, single women. Of course, it doesn't allow single men, but single women are allowed. So already, I would say we are on the path to progress. And the law is very clear, the consents are very clear, they have been outlined. When a single woman walks in, then, and I have been doing that, in fact, I have so many single women walk in with their parents, with their brothers, who are, they know that these girls are not meant for marriage, but parenthood is probably their right now. And when the law allows, I don't think we really have to work very hard towards it, because this is already in progress. As egg freezing is also becoming so common, and we again have parents and brothers walk in along with the, it's not that they don't require consents of their husbands or their partners when they're coming for egg freezing. So I think our clinics are already attuned. There was a time, I remember about 20 years back, when when a woman walked in and they said, "What's your husband's name?" And now, of course, at that time, people went aghast. So now you only have to ask, do you have a partner? You don't even say husband or whatever. So now I think all our clinics they know how to behave with dignity towards women who require this kind of service. So I think we are already in place for that.
And what about the infrastructure upgradation? So
I think we only require women above 21 years. They just have to, we just have to see that they are in the right age, 21 to 50. That's what our country allows. So the law of the country has to be followed. There is nothing really changed in the infrastructure. It's just the soft behavior of the staff that you have to see. And I think that's already, most clinics who cater to this kind of clientele already know that.
And I think the rest of the technology and whatever we do for IVF, all the infrastructure and the resources, they're all in place. So there's nothing extra which needs to be added apart from what she has said.
So we're saying that the genetic testing laboratories, if it is there and the clinic is well equipped, we are all equipped with some soft skill training to
absolutely.
take it forward.
See, we already, the centers are now legally, we have to have a level 2 legality in place. So already we have the whole we don't get the legality or the license to practice unless we have the things in place.
Sure.
So already the infrastructure is already in place.
And if you want to do the genetic screening in your clinic, then over and above, you have to get registered as a genetic testing center. And once you are, you just have to follow the protocol and the right forms.
So you're saying that the rules, the ART rules are very descriptive in terms of defining the infrastructure, the consents and the requirement of the staff.
Absolutely.
That's great.
And also when there is a center which is catering to genetic testing, counseling or fertility preservation, I think part of it we should have a genetic counselor who can do pre-test and post-test counseling. True. And also a psychological counselor in place who can be a part of their fertility preservation journey. That's very, very important.
So that also actually comes under the law. We all have to have a psychologist and counselors in place before we even get a license. So when they come to check, they already check that.
Including the genetic counselor?
I think most of us look forward for
they are
help
rotating.
from
They are mostly they are rotating. They are not. Some of them, of course, have.
The name counselor is not there with the genetic, but you need to be attached to a genetic department. It could be any geneticist.
Yes.
And also these genetic labs also provide counselors, because it's important that not all of us may have the knowledge and the skills, to counsel, because I've seen families breaking down even when you tell them that they have a small career gene which can be transmitted. So we have to be very, very mindful of how we counsel them. It's very, very important.
So the counseling of the counselors is also required, and kind of a trainer program.
Training.
Yes. So, so Dr. Vasundhara, obviously now with the ending of almost more questions, we are worried about the advancement, about the innovations, technologies which are there. Would you like to highlight few for our audience and for us to understand what are the newer technologies in the tissue preservation and also embryo monitoring?
Right, so the technology is moving leaps and bounds. If you look at, oocyte vitrification, I think it's no more an experimental procedure. It's a well-versed procedure. It's well documented success rate post-thaw. The oocyte survival is more than 90% in standardized labs with experienced embryologists. So, and then we have this closed system vitrification models, which stores your gametes in appropriate environment, avoids contamination, cross contaminations, etc. We do have automated systems, but then we are talking about innovations. The bottom line, I would say, is all these are expensive things which I'm going to talk now. We need to look at experienced embryology team, basic requirements in your lab, and morphology of the embryo and patient's age. So these are the bottom lines before we even, take all these technological advancements. The second thing is your embryoscope, which is going to monitor the, embryos in the morphokinetics at every stage, critical stage in the embryo development, from fertilization to cleavage and fragmentation. Then they deliver the AI algorithm and scoring for us to decide which embryo has got a better potential to implant and the transfer priority. This is a very, very expensive gadget. Still, there are not much randomized trials really advocating this over your morphological grading or your genetic testing, and then transferring the embryos would be better in certain group of patients. However, when embryoscope is available, I think we can use it for a segment of patients who have had previous recurrent IVF failures or advanced maternal age, or where your center is really looking at single embryo transfers, and then you want to prioritize which embryo is going to go. And also when you're doing PGT cycles, we can also reduce the number of embryos that's going to be biopsied based on your embryoscope images and developmental potential of these embryos. Having said that, ovarian tissue cryopreservation, again, we need to have more training and more attachment with the oncology team, and that should be really the future for adolescent girls who are having cancer, and we need to propagate this to the multidisciplinary team, and each and every city we need to collaborate and then work towards this. And this is again very, very important for our future girls who are having cancer treatment. With this, AI is like, again, a big, big journey. Now AI is telling us about the sperm, about the oocyte. Recently, there was a lot of thing about the star baby, where, the sperm was identified in a man who had like 17 IVF failures, and then it was there. But again, we cannot take that alone with a pinch of salt. We have to look at a lot of things, whether we can adapt it to our Indian scenario, and how future of AI is going to, help us. Definitely AI is there, because it's all the data, and it's just going to, how we are going to utilize it with our clinical experience and knowledge. So, and again, I would say digitalization is also coming in a long way, where, patients' dashboards are being created, where the clinician, the embryologist, and the patients are having their lifetime update of their embryos, whatever is the status, and then they are collaborating, and then, knowing their outcomes real time, and that's improving the transparency, and then the patient continuing your treatment, and then there's success rate, and so on and so forth. So many things are happening, and then obviously people are talking about designer babies. I don't want to go in there. It's an area in itself. So I think innovations are there. We have to adapt it based on evidence and experience, and not as a marketing tool, to bring in patients to the center. We have to look at definitely experience. Women's age is the single most priority thing. Madam had started the topic with that. I think we should not move away from those basics.
Yes, very rightly said. And I believe that you have also given a way forward about the digitalization and AI incorporation. That is the future, and that's where every healthcare and medical field is going. Before moving to that futuristic approach and the next step which should be taken, I really wanted to have us, because you all, it's an opportunity to have all of you such experienced experts. How many, do you really get a very easy conversation from the patients who are coming to you regarding the egg freezing, or is it a difficult task yet? What are the common, misconceptions about the egg freezing, about social freezing, and how do you address that?
I would start with saying that I don't think it's a difficult conversation. People are aware. They're coming on their own. First, the people who are coming on their own. Secondly, I think the biggest myth that they have is that, are they going to lose all the eggs? Will they finish with their fertility if they, if you take out the eggs? So when you explain to them that this is only this cycle, and anyway these eggs are going to die down, they will be, undergoing apoptosis. So then they understand that their fertility is not going to be future affected. And as Dr. Jaideep said, only 8%. So they know, I mean, you know, when you put the statistics in place, they know that their fertility is not really, if they get married at 32, 33, they're going to have their babies. So I think the only myth that I really come across is one, this. Second problem that I face is of the unmarried girls who are virginal. And they do have to have the, you know, the process has to go through the vagina. So that's another thing, and that's the biggest thing that I face, you know, in the girls who are not sexually active.
So I can tell you two scenarios. One are ones who really need it, and they are the ones who it's very difficult to convince them, and they don't come forward. For example, a girl with CA breast has visited an onco-fertility specialist and has been told, let's start chemotherapy 2 days later. And then suddenly they remember, okay, fertility preservation is a thing. They come to you. Now in India, when you say fertility preservation, out of 10 girls, if I have counseled, only 2 must have done. 8 don't do it. Reasons: financial. Number 2, not prepared. Number 3, they are scared. My cancer will spread if I don't get the treatment quickly. Number 4, they kind of feel, okay, if ovaries conk off, maybe I will use donor eggs later. So the one sector where you really want to do onco preservation, you know, fertility preservation, are the most difficult ones where you can convince them, or early endometrial cancers. Yesterday I got a girl who's 30 years, severe endometriosis. Her ovarian reserve I did and is very low, so I've counseled her. But I've done at least the priming. I've introduced her the concept of fertility preservation. So this is one. The second is voluntary fertility preservation, which you call social egg freezing. Now the term is not used anymore with the American Society. They walk into your clinic because they have heard, their friends have gotten it done, their neighbors or anybody. It's not difficult to counsel them. They get it done. But this is the population which is hardly ever using it, may not use it. They are in the tanks. In last 10 years in Gangaram Hospital, hardly 5 or 10 people must have used from this. The third is emergency egg freezing, where on the day of egg collection, husband just couldn't collect the sperm. In the testicular sample, there was no sperm. Her husband couldn't come, family accident, anything. They are the ones where we have used them maximally. And before the law came in, where you know, donors would have been a perfect group for egg freezing, where people would have chosen, but now it's not allowed in India anymore, so that segment is gone. So these are the 4 scenarios what we come across.
I think more than the myths, it's the understanding which is more required. And I feel like, you know, in our country, if you just understand the percentage of people having premature ovarian insufficiency, like when we quote the Western figures, it's 1%. Today in our country, we have 3 to 5%. So more and more young women are coming with low AMH. Now when you tell them, okay, now this is an option for you, it is one of the most difficult areas of counseling. And the women from the urban background or career-oriented women understand much better because they still don't have a partner in sight, and you know, all those people will understand. But people coming from tier 2, tier 3 cities where parents are, they are not really, you know, empowered enough. Parents are the ones who are going to support. It is a huge area and a lacunae which is there. And second important thing is that this is another gray area where these women can still have a natural pregnancy. So when you counsel them for fertility preservation, again you can be on a gray list as a person who is promoting something which probably will never be used. And I mean, it is a fact that these women who have premature ovarian insufficiency, they still can conceive. But you know, so the way you counsel them is very important, and that is something which we must understand. And the another important aspect which Shweta was also talking about, which probably will be our problem for the future, is that there will be a lot of this unused material which will be lying with us, and we will not know what to do with it.
One of the biggest challenges, like, you know, 2 extremes of patients. One, you know, in the IT segment, like, you know, either it's Google or Meta, they have their fertility, covered. They promote fertility preservation, and they do ensure, and then the patients come forward, whether it is for medical reasons or social reasons. But the other group of patients, whether it's for endometriosis or premature ovarian insufficiency or social freezing, their finances is the main issue. So the questions is like how long they can freeze the material, what is the cost incurring. So it's a big challenge in those areas actually.
The fate of definitely the eggs, as you rightly said. So thank you so much all of us over here, because now we are at the end of the session, I believe, and throughout this session we have explored a lot of relevant do's, don'ts and the way ahead. I believe that I have taken some point out, like how we can make egg freezing more accessible for the women in their 20s and 30s. How could we integrate fertility preservation into cancer care pathways and the treatment, medical illness, and perhaps launching the national registry as well for the eggs, and also for a nationwide fertility campaign which should be digital and AI driven. So with these very valuable recommendations, and where we can actually now end the session. Before that, may I request anyone has any question from our esteemed panelists? If somebody want to ask something? Yeah, please.
I think thank you, esteemed panelist, and my question is to all of you, Dr. Jaideep, Professor Shweta. There's also, a continuous increase in, a lot of cases where we have heard that there are, unethical and unorganized clinics which are operating. The recent case has been of Gurgaon, where, there's a high-profile clinic was operating. How do we deal with these situations for the patients to understand that how, what is the right format for them to go in a right direction, getting to the right doctors? I mean, if you can throw some light on that part, please. Thank you so much.
I think we are not the right authority to give this answer to you, because this is the role of our ART registry and the board which has been formed. I think eventually you just have to put once unanimously all the centers in India have been given a number, because like in UP there is no board yet, right? See, this is the challenges what centers are facing. So they can just put their registration number on their websites and in their IVF centers. That's the only way to know that they are accredited by the board. Till that time, we are not the authority to tell who are functioning properly and who are not. That's the role of the authority to do it.
For patients, what is that
Patients need to be smart. They are smart. Patients are so smart as of today.
I don't really agree with you, because a lot of people who will definitely be duped by these. Now, we have to also understand that, of course, I totally agree with Shweta that this is the responsibility of the authority, but we also as individuals have some responsibility. Now, what I understand from this center, there was no doctor operating there. It is being run by somebody who is not an ART person or who's not a doctor at all. They claim themselves to be an ultrasound clinic. Now, if it is existing, if it is doing that kind of work, I'm not even sure. So if it is really doing that kind of work, then people who are around in that area, of course, are aware of it. Now, I think we have a responsibility. Because ultimately it is all of us who are going to suffer because of it, because patients do not even know the difference between a doctor and a nurse. There are patients, I mean, I come from, I have done the whole landscape well. So people do not even understand who's a doctor and who's a nurse. So if somebody is sitting down there and if you are aware of it, I think you should definitely report.
I think future, the only way out is to see the enrollment number, the registration number, because I think there is a situation where one center takes over the other center. That could also be a problem. So basically it's not a problem. They have qualified people, but they have not registered. I think Dr. Pankaj...
And making people accountable to work, even the authorities accountable for their work, is also our job.
Ma'am, I want to make one small point, ma'am. How to now regulate it? Should we regulate, should the patients regulate themselves or the centers regulate themselves? Because ART boards, ART boards, state boards, they have got around more than 30, 40 districts under them. We can't expect them to go to every corporate building and look at in one nook, and this center is a very advanced center. I know about this. No, I think the right way here is that the vendors are limited. The people who apply catheters, needles, media are barely 5 vendors in the country. Now those vendors should not supply till the time they don't see Form 3. This is what I'm recommending now to the comment that
very valid suggestion.
a very simple way to check
idea.
it. They should Form 3 देखेंगे तो देंगे वरना नहीं देंगे आपको. Like an Aadhaar card.
And I feel there should be a public-private partnership in this also.
Yeah, government. No,
we should.
I know. I won't talk more than more than this, because this is what we are recommending also for a similar case.
I think a very valid suggestion.
Yeah, very
like
good.
we are doing for ART Bank, we are looking at the registrations.
Yeah.
Similarly, this could
Because
be done.
this has jeopardized the functioning of lot of centers in the state, and that's exactly what is happening, because we are paying the price of what people are doing.
And by
all
the way,
the
just
centers should be taking courage in putting realistic success rates on their website, and we know that the take-home baby rates or live birth rates, it's only 40 to 45%. So we and also these should be regulated by bodies, and then we all should be following the same. So
I think once the art registry comes in place, and then if we have to and this is what is happening, at least in our donor and surrogacy, every single patient is being monitored. So if we could put the same kind of art registry in IVF, then probably even a success rate, everything will be validated.
So we will have an Indian benchmark as well to monitor and to look at the indicators. By the way, just
one more thing is about to add, ma'am, here about the same case. You see, what we need to do is that the embryologists are the key people. See, since morning we have not spoken about embryologists at all. It's a World Embryology Day also. I just want to inform everyone. So they are now floating from one center to 10 centers. As a gynecologist, we can't do that, but they are doing it. So we do multiple inquiries about this. हमें तो पता ही नहीं है. We are an embryologist. It's the responsibility of the center to look at Form 3s and registrations. They won't even know that whether they are registered or not. I think it's a very important job, and Sarabpreet, you'll have to take on this, that you people now, until they are not qualified, why are they working in a center, and why should they work in 10 centers? And once they stop doing it, I think a lot of things can be corrected.
Exactly. I totally agree with you, yeah.
7 to 8 cryocans lying full, multiple places, and they don't know what these are. And embryologists.
So because all the embryologists are also not those well qualified ones, so they are ones who are roaming here and there.
So I think we'll all have to get down together on this. Thank you.
So I think that's what the suggestion is, that implementation and the aggressive implementation of the law is what we need. By the way, for the UP, they have authority now, they have started registration, just for the information. I recently came to know.
That's really great.
Yes, we all were waiting. So, and if there's no more question, we'll wrap up the session. Thank you so much.
Excuse
all our
ma'am.
panelists.
Thank you. I just want to congratulations to all the ladies who are sitting here. So it's really very happy to see the panel which is full of women and leading the conversation on the IVF. It's really very informative session and the insightful. Thank you very much.
Thank you.
Thank you.
Thank you so much. Thank you.
Thank you so much. Thank you to all our panelists. May I now invite Nenika from IHW to please felicitate our speakers. Ladies and gentlemen, can we please have the applause going for our lovely speakers? Thank you, everyone. Ladies and gentlemen, we now move to a keynote that zooms out to look at the larger ecosystem of equity and accessibility in IVF care across India. As we've seen today, access to fertility care is still deeply uneven. Geography, income, awareness, and social stigma continue to dictate who gets to become a parent with help and who does not. Our next speaker, Dr. Madhur Hamine, brings a strong lens of clinical experience, patient equity, and system design to this conversation. Dr. Madhur is the co-founder and director of OOSFAIR ART, a pioneering IVF lab network that is raising the bar for clinical embryology and ART lab excellence across India. With a strong academic background in clinical embryology and a commitment to global standards, Dr. Madhur brings over a decade of experience in embryology, fertility diagnostics, and ART lab design. He has worked with some of the country's top IVF clinicians and centers, helping optimize lab outcomes and patient success rates through evidence-based technology forward practices. Please join me in welcoming Dr. Madhur on stage as he delivers his keynote on Bridging the Gap, Equity and Accessibility in India's IVF Landscape. Can we please have a huge round of applause as he joins us on stage? Over to you, sir. Requesting everybody to please remain seated as after this session we will be breaking for lunch. Thank you. Over to you, sir.
Thank you. Yeah. So first of all, I would like to thank everyone. And especially the IW Council, Mr. Kamill, and ESR members and IFS members. I think, am I audible? Yeah. So can you please increase this sound because I will be little moving. मुझे लगता है कि बहुत सारे लोग लंच के टेबल के पास में है. And they must be very hungry. So I will keep my presentation very crisp and very small because most of the points about accessibility and equity is covered in previous two sessions. What I will do is I will just present you the structured discussion what you had heard in two previous sessions. So let us move on to. This is not moving. और थोड़ा देर भूख सहन करना पड़ेगा. Yeah. Yeah. So I would start with the disclaimer. I will start with the disclaimer that I am not an IVF specialist, neither I am a lawyer or a policymaker, and I don't represent a corporate IVF chain. And also, I am not a IVF equipment seller. Now, having said that, what we have learned is basically from working at a grassroots level, from Tier 4, Tier 3 cities to the metros, Tier 3 towns, Tier 4 towns which are less traveled, interaction with 600 plus gynecologists, we have gathered the insights, and a real world conversation between them. So through this, what, again, I think it is stuck. Can I have stuck? Yeah. So what we are doing is, fortunately, I have my co-director, Dr. Dilip Walke, who is an eminent name in Foxy Circle for his medical, legal and ethics
work across country. So he is my co-director. I have more than 25 years of experience in the healthcare management field, and along with us, we have Advocate Amit Karkhanis, who is a medical legal expert. Now, what we have put together is a collective domain wisdom of 50 years, more than 75 plus IVF centers, mostly concentrating in Tier 3, Tier 4 cities of India. And we provide a 360-degree IVF turnkey solution, starting from feasibility, whether you should start the IVF center or not, to running the IVF center. So we have onboarded around 60 ART consultants and embryologists with us who are specialized, they are top-notch people, and that is how we have developed a trusted partnerships with the gynecologists, with the investors, to reach out to the people which is where it is needed the most. So that is where we are making the difference. Next, please. So let us talk about the accessibility and equity in IVF especially. So accessibility means access to the IVF center irrespective of the physical condition, the financial problems, the social and cultural stigma it has. Irrespective of that, the intending couple should have the access. And equity is a fair opportunity for all, irrespective of a geography or income. I'll tell you one small story about recently happened in 2022. In a small village in Odisha, a 12-year-old girl died because of a common crate snake poisoning bite. Now that girl died in a very remote place wherein the equity or the accessibility to the better facility is not available. And just compare it with the 80% of the population which is residing in Tier 3, Tier 4 cities, especially when it comes to the IVF facilities. Next slide, please. Next. So we have been discussing about the IVF revolution in India and the growth it has seen. Now you can certainly see from the birth of Kanupriya in 78 to the present, it has grown tremendously. The ART registry shows around 2,500 clinics registered and approximately 6,500 clinics have applied, out of which only 2,500 has been registered. And we have seen also a huge growth in terms of corporate chains, AI genetic screening and all. Whenever we attend the conferences, especially when it comes to the ART practices, what happens is we talk very high-end gadgets or the evaluation methods or the treatment methods. And then with all that, we are currently doing around 300 cycles, which is expected to grow almost double till 2027. Next, please. Now, what this slide will show you is an inequality when it comes to the larger population. So this slide shows that around 55% of the IVF cycles are happening in Tier 1 and metro cities, Tier 3 cities and rural around 33, and only 12% where 70% of the population is staying. Only 12% of the cycles are happening in Tier 4 and rural cities where the need is most. Next slide, please. So we will address the entire scenario in 4 sectors. Let us understand the problem statement. Most of the slides you might have heard the discussion upon, so I will skip it very quickly. Next slide. So this is a gross dichotomy which has presented to us. These are, I usually call these as a IVF deserts. So these are Northeast India, Eastern India, Central India, Western tribal belts, and probably South Indian coastal area, which has got a very less concentration of IVF center. Now when you say most of the IVF centers, almost 70% of the registered or unregistered IVF centers yet to be registered IVF centers, are situated in 8 metro cities of India. Now, this census, what we have seen, or current papers are there, are basically based upon census of 2011 and the white paper published by EY in 2015. Now, the numbers may be a little more, but the dichotomy is huge. So almost 60 to 75% of the population which is eligible for infertility treatment is not rich. And that is where exactly we focus upon. So we are basically a business catalyst. What we do, I'll explain you. Next slide, please. These are the barriers in accessibility. I think most of the panelists have discussed about geographical limitations and high treatment cost and social stigma and lack of awareness. So let us fine tune, let us see one by one. As you see in this graph, awareness about versus the affordability, tier wise if you see, as you move from tier 1 and metro cities towards tier 4 cities, where the most of the population stay in tier 3, tier 4 city or tier 2 city partially, the awareness and affordability is slowly decreasing. इसलिए metro cities में ज़्यादा concentration है IVF center and IVF facility का. They have got more equipped treatment modalities than tier 3, tier 4 cities. And that is where, and I have defined the kind of the tier system which I am talking about. So less than 1 million tier 4 cities are 5,000 cities in India approximately. So we are talking about a huge population which remains underserved. Next slide please. Financial inaccessibility, ये तो सबको मालूम है कि IVF के cost ज़्यादा है and where the results are not very assured. I mean, nobody can say कि भाई मैं 100% result देता हूँ. So that is where we need to be addressing the issue. Having said this, the treatment is not limited to one cycle only. You may require repeated cycles. You may require frozen embryo transfers. There are patients who require repeated stimulated cycles. So we need to understand all these things. And next slide, please. I would tell you the cost versus income. Now, the NNI per person, per capita, is 2.05 per year. Now, if you compare this to the current cost of one IVF cycle, which is a stimulated cycle, is to the tune of around 1.2 to 1.5. Now, ये लेने में उसका almost 60 to 75% of the NNI or the income per year would go. So they are not left with many options. Either they don't, जो previous panel में बताया गया था कि वो मंदिर की घंटी बजाते हैं, जंतर मंतर के पास जाते हैं. So those are the kind of solutions they find solace in. So that is why we need to think about this, and especially when it comes to the rural area or tier 4 cities or low income groups, that is where we need to focus upon. Next slide, please. Cultural, social stigma, barriers, I think most of the panelists have discussed about it. Next slide, please. There is a huge awareness gap, and I would come to the solutions to this in my later slide. But then still it is I mean, even in metro cities and tier 1 cities, if you ask even the medical professional, apart from gynecologists भी ऐसे है कि most of the people, they don't know what is happening inside the IVF lab. And that is where exactly the concern is. Even in metro cities, I would say the awareness is moderate. It is not completely, I mean, they are not fully aware that what happens. Most of the people, they think that IVF किया है तो दूसरे का बच्चा है. And that is where the problem is. Next slide. Now, good that Indian government has come out with a very elaborate, and it is still evolving, the ART Act. Is it an equity enabler or barrier? Now, positives are good. I mean, there are structured way of how the IVF center, level 1, level 2, all these things should be there. And there are challenges which we are facing because we have tasted the dust of the tier 3, tier 4 cities roads. I'll tell you, health being a concurrent subject in the list, which is there in the central government also and in the state government also. ART Act is implemented by state government at a altogether different level, because we have worked in 5 major states in tier 4 cities. The appropriate authority at those state level are not at all aware of what needs to be done. So there is no checklist as such given to them. We are in fact proposing the central government that let us have a mass scale webinars to address the issues which are happening, which are there at tier 4 cities at the level of appropriate authority. उनको मालूम ही नहीं है. बहुत सारे cities में, even in Pune where I come from, the appropriate authorities are PCPNDT authorities. And PCPNDT authority जब inspection के लिए आता है तो उसको बताना पड़ता है कि सर बताओ क्या देखना है इसमें. So there is no checklist even given by, and there has to be uniform system. Kerala में there is a insistence upon getting an embryologist who is having 3 years after doing MSc clinical embryology, who is having experience in a recognized IVF center for 3 years. Now tell me, the act is implemented in 2022. Where you will get such embryologists? So 3 साल होते ही नहीं है. There will be very rare instances wherein people will have. So they were hell-bent upon to get one embryologist who is PhD holder having one experience. And that too they are insisting that PhD full-time करना चाहिए. So these are the things which needs to be addressed. Next slide please. And also I will briefly tell you that in the act, donor gametes का pricing बढ़ने के वजह से there are a lot of issues happening at multiple levels. So eventually that burden, financial burden, is passed upon to the patient who are in need. So I think that is also one area wherein the concerned authority need to have a look at it. When it comes to the insurance and IVF, what is missing? I think these are the things which needs to be seen correctly. We are fortunate enough to partner with my good friend Mr. Vikas Anand, his company Safety. They are launching India's first and most affordable insurance for IVF treatment. The policy will be enforced very soon. I think today he is going to elaborately talk upon that. So it is going to be on both the sides. जिनको infertility की ज़रूरत नहीं है वो भी करने वाले हैं, and जिसको infertility बताया गया है उनके लिए भी उन्होंने policy निकाला है. So once that is covered, then it makes lot of sense कि equity or accessibility will be covered at most of the places, and this is going to be kind of national level. So next slide please. And I thank Vikas for taking us as a knowledge partner in designing that policy. Now, ongoing mitigation, let us have a look at ongoing mitigation. Next slide, please. Role of gynecologist, ये बहुत सारी जगह हो रहा है, and that is why I am covering this. Okay, so there are gynecologists who are remotely trained or advised, and then the procedures are done by the qualified ART consultants. So that is happening. Also, I would say that there is a collaborative efforts which is going on कि 10 gynecologists एक साथ आकर they are creating a facility which can be kind of a open culture IVF center which can be used under a highly trained IVF consultant. Next slide. Cost-effective IVF model is also happening at multiple places like mini IVF. Batch IVF is one very good way to mitigate the high costing in IVF treatment. There are adapted protocols which are again done at tier 3, tier 4 cities by expert ART consultants. Pricing structured, again, I would say that, as you move on to the tier 3, tier 4 cities, the pricing structure needs to be mitigated as per the affordability of the population in that area. And of course, what I was talking about is an open culture IVF center. One good facility like Cloud9 or a Motherhood or a LaFem like facility which can be utilized by many gynecologists, but then that has to be monitored, and the gynecologist needs to be trained by qualified ART consultant and a team of a good embryologist. Next slide, please. And this is also being used quite rampantly. The tele IVF consultation, the AI power tools, and of course this is just a beginning of AI era. But then still there are a lot of efforts which are going on to develop those systems wherein those will be used quite rampantly, and this will reach to the unreached population which is staying in even metros and even tier 3, tier 4 cities. Next slide, please. Now, this is what we see as a vision. Next slide. Government partnerships and public-private models. Fortunately, in Maharashtra and some of the other states, they are coming up with an IVF center at medical colleges. But again, the tender निकलता है, tender भरा जाता है, IVF center खड़ा हो जाता है, but उसको motivate करने के लिए, run करने के लिए कोई नहीं रहता है. So this is the irony of it. So I would say that one of the panelists, I think Dr. Keshav said that those facilities can be outsourced to the established IVF players, which can run it efficiently, so that it will be fruitful PPP model. We can always deploy on wheels infertility screening programs at rural places, wherein educate them, screen them. हम लोग बार बार करेंगे तो ही उनके दिमाग में बत्ती ही जलेगा. Unless we do it, I mean, 3 महीने में एक बार करने से होता नहीं है. I think we need to be repetitive in our efforts in terms of screening them and educating them simultaneously. We can also focus upon various NGOs, ASHA workers, even the PSC level health workers to educate them. I think मुझे लगता है, instead of talking only about educating the patients per se, let us think about B2B conversation or education also, so that we can educate the business to business or doctor to doctor communication and awareness, make them aware. Even the GPs are not aware that what is happening. Leave apart the gynecologist in the rural areas, but then we need to address this by mass educating people so that they start talking about infertility issues openly. Next slide, please. We can always think about cross-subsidy models in IVF, wherein there are many people who are having a chain of IVF center, wherein their metro city IVF center is doing fantastically well. The price points are also high, but can they deviate some of the profit and subsidize IVF cycles in tier 2, tier 3 cities, which is a great possibility, which can be a great enabler to access to the IVF centers. Of course, there are hybrid delivery models, and then CSR outreach funds. There are many companies which will be interested in doing so. Next slide, please. Policy recommendation for equity would be subsidize the IVF package. Now there are 2-3 thought processes I have. Probably you will see in the next slides how we can subsidize it. Like they have done it in stent, medical gadgets, equipments. Then we can have training program grants from government, which will train larger pool of population, medicos and embryologists at mass scales. Because whatever is said and done, we at least need double the number of IVF centers what we have currently. And for that, the current system is not sufficing enough to cater to that. Building India's inclusive fertility ecosystem, I think most of the panelists, they have discussed and covered all these things. Let us move on to next. Next slide, please. I think this is a very interesting slide, which will show what should be the call to action for stakeholders. Now, what I would tell you is government and policymaker are one of the stakeholders. then gynecologist IVF experts and digital health innovators can contribute in decentralizing the IVF center. Pharma and medtech companies can definitely have a cost-effective tied pricing, wherein media disposable consumables and gonadotropins can be, made available through something called as Jana Aushadhi Yojana. So if a government intervenes and then ask them to reduce the pricing or give them some incentives in which because the major factor in pricing is gonadotropins, media disposable consumable. These are the direct costing. And of course, the manpower cost and the other costs are intangible. So those actions needs to be very collaborative in terms of investors, social entrepreneurs, pharma sector, gynecologist IVF centers, government and policymakers. Next slide, please. The future vision for fertility for all everywhere. I think this is where oosphere thinks about reaching the unreached, even the unreached in metros and unreached in tier 3, tier 4 cities. How we can do that? To empower the gynecologist in that area and create a facility backed by a trained manpower, ART consultants and embryologists. That facility can be supervised and the procedures can be done there by the experts. But then if you create that facility in the proximity, obviously that will always enable more people to go to the IVF center and take the facility, take the advantage of the facility. And we can always do a lot of patient education programs in vernacular. Still, IVF के बारे में बहुत कम vernacular languages में, especially when it comes to the South Indian part, vernacular language IVF education is not happening. And whatever is happening is limited to the only people who are using digital platforms like, social media वहाँ पे हो रहा है. So there is no mass scale outreach program to educate the end user of the facility. Next slide, please. Now we have, because we are working in all these tier 3, tier 4 cities or rural India, we have come out with very good sample studies for you. Bid, Satara, Sangli are 3 places, 3 very small tier 4, tier 3 cities in Maharashtra. What we have done is we have created a facility which is invested by 1 or 2 gynecologists, and we have developed a pool of almost 20 practicing gynecologists around the vicinity of a radius of around 40-50 kilometers. And those gynecologists are also part of this, not financially, but then they are trained right from case taking se lekar stimulation kaisa dena hai, how to monitor it, and then they are pulling the patient to that. I'll tell you one example wherein we started this in Bid. This gynecologist came to us and he asked कि मुझे चालू करना है, and then how would it work? So we helped them in doing this. He is joined by 20 more gynecologists as associate partner. Initially, when we analyzed his practice, we said that he will be able to generate 6-7 cycles in a month. Now he's sitting on 45 cycles in a month right from day 1. And this is happening in a very, very remote place, which is a Adivasi place. So that can be, if that can be achieved in such place, the similar model can be scaled up in various places. Now you would see the key performance KPIs: time to break even, 6 to 8 months. Patient volume, 240 to 300 cycles a year. Outcome parity, comparable to success rates which are there in metro and tier 1 cities. Now this center is doing everything. Whatever popular terms are there, because I am not an ART specialist, but that they are doing blastocyst transfer, they are using assisted laser hatching machine, they are using whatever embryo glue or whatever, the embryologist would tell me the correct definition. But then the results are beta SCG positive, success rate is around 70-75%, which is unseen, unheard of in that area. So they are very happy. More number of people are getting educated as well as they are taking the benefit of this treatment. So this is what we do. Next slide. This is about us. I'm joined by our director, Dr. Dilip Walke. I am there for almost 25 years of healthcare management experience. Mayura is there, and Advocate Amit Karkhanis is there. Along with this, we have 50 associates working with us. We have 60 odd embryologists and ART consultants on board, and we have full-time biomedical engineers to look after the machinery part. So all in all, right from feasibility to running the IVF center, we help people. We don't give our brand to them. So I can proudly tell that I have chain of IVFs, 30 centers of in a chain, but without my name. So I'm enabling gynecologists, helping them out with a successful business model. Next slide, please. Now, these are some of the actionable ideas. I leave it to you. You can think over it. We can discuss it. Anybody wants my presentation, they can meet me. I am ready to share it with you. Yeah, you can, next slide. Yeah. Can we have IVF screening on wheels in rural areas? Can we have public-private fertility hubs which can cater to the masses? Can we include IVF e-Sanjeevani? Can ESAR and IFS can come together and create a pool of ART consultants which can be consulted anytime by any gynecologist? Can we do that? Or can we have pool of embryologists who can help training the people at grassroots level? Can we come out with Ayushman Bharat inclusion, not with 60,000 of course, because it is 60,000 in IVF treatment in Ayushman Bharat. Can we have IVF innovation? Now we are talking about made in Bharat, made in India. Can we have that IVF innovation challenge every year which is happening in medtech companies also? Can we have IVF Jana Aushadhi? Can we include fertility curriculum in 10th, 12th standard in schools and colleges so that the awareness, because 70%, 74% literacy rate is there now in India. I think we should include this. जितना भी टाबू है उतना निकल जाएगा. And can we have IVF startup incubator in medical colleges? So those who are doing PG in gynecology, they should be taught. They should be also explained the business aspect of this industry, and so that we can enable entire Indian population to have equity and access to all these centers. Next. So India's IVF landscape is growing. Let's ensure it grows fairly. Thank you very much for joining. I am Dr. Madhur signing off. Thank you.
Thank you, Dr. Madhur, for that informative keynote. I now request Dr. Amrita, Public Health Policy Expert at IHW, to felicitate our speaker. Can we have a huge round of applause for our speaker? Thank you so much, everybody. We will now break for lunch and reconvene sharp at 3 p.m. Thank you.
फोटोशूट सही है कोई
announcement.
अब ये फर्टिलिस्ट का वेट करा
सर पहले एक हम Sometimes the only way to know is to jump.
I will sit there and smile.
Welcome back, ladies and gentlemen. I hope you had a nice lunch. As we return, we now shift to something both urgent and often overlooked, our responsibility towards the environment, even in healthcare. We are proud to now present the Sustainability Hour in IVF, a flagship initiative of the IHW Council, previously hosted on global platforms including COP summits and high-level climate health dialogues. Today, for the first time, we bring Sustainability Hour into a mainstream healthcare conference and into the heart of fertility and reproductive care. Why, you might ask? Because behind every IVF cycle lies a carbon cost. Behind every state-of-the-art lab is a growing energy footprint. And behind every clinical protocol, the need for responsible innovation that protects both people and the planet. We believe that conversations on green IVF, sustainable embryology labs, and circular practices are not just desirable, they are necessary. And the time to act is now. To lead this very timely conversation, we are proud to partner with the Indian Fertility Society under the visionary leadership of Dr. Pankaj Talwar, President of IFS, and with support from Gufic Biosciences, who share our vision of sustainable clinical innovation. Before we begin the panel, we will now play a short video that captures the ethos of sustainability R and the future we want to shape together.
At a time, 79th United Nations General Assembly brainstormed SDGs progress, revitalizing the Pact for the future. IHW Council initiated the world's first Sustainability Hour from the global land of opportunities. Dubai, United Arab Emirate, a platform where SDGs champions took the center stage to influence the world through their impact stories of driving change, groundbreaking innovation, transforming global goals into grassroots action and local sustainability realities, building this pivotal moment with sustainability. Stories from sustainable healthcare, nutritional security, water security, climate action, clean energy, green mobility, circular economy, sustainable agriculture and food systems, social sustainability, biodiversity conservation, gender inclusion, sustainable businesses. Be part of the growing momentum of Sustainability Hour and join us to take this to every part of the world too. Share, engage, be the change. Together, we build a sustainable future.
And now, to officially introduce the session and guide us into this landmark discussion, please join me in welcoming Dr. Pankaj Talwar, President, Indian Fertility Society, Dr. Sarabpreet Singh, Director, The Fertilis Academy, Dr. Shalini Chawla Khanna, Associate Director, Department of IVF at Max Healthcare, Dr. Yogesh Kumar, Professor and Head, Clinical Embryology and Principal, SEART, Dr. Aanchal Agarwal, Director, Fertility and IVF, Cloud9 Fertility, Punjabi Bagh, and finally, our moderator, Dr. Meenu Vashisht Ahuja, Senior Consultant, Cloud9 Fertility. Can we have a huge round of applause for our panelists? Over to you, ma'am, to moderate the session.
Wonderful. Good afternoon to everybody here. Post-lunch, a different kind of a topic. First time ever, I think we are having a collaboration between, the fertility sector. So Indian Fertility Society has taken this initiative with IHW to talk about a very different kind of a topic today, sustainability in IVF. Spearheaded by our very dynamic president from the Indian Fertility Society, Dr. Colonel Pankaj Talwar sir, and all the people here that you see on stage with me here, they're all accomplished in their own fields. So I just want to do a little context setting before we really get started. We all know that the world is sitting atop a ticking time bomb. In the race for supremacy, the humankind has done irrevocable damage to Mother Earth. We are actually facing a huge planetary crisis. There is climate change, there is biodiversity loss, there is land degradation. Post-industrialization, I must tell you, after the mid-1800s, the incessant burning of fossil fuels has, done damage. So much of greenhouse gases being emitted into the atmosphere. The carbon dioxide level in the last 1,000 years has increased, doubled. And that is pretty alarming, I must tell you that. So by the end of the century, if this is how we go on, the globe is going to be 4 degrees warmer. The social, environmental, and the economic consequences of all this is going to be devastating. But we could do something about it. If we check the stop to increase of temperature to below 2 degrees, we could do something about it. And for this, we would need sustained policy action, climate smart solutions. Now just let me give you a very simple definition of what sustainability is. It means meeting the need of the present without compromising the ability of the future generations to meet their own needs. And as it was just being run, you saw the SDG goals there. So in 2015, the UN, they adopted the 2030 agenda for sustainable development. And keeping in nature with that, the target was that you bring about progression, but keeping climate change in context. So all the audience here would wonder, and especially my colleagues from the medical fraternity and the IVF fraternity, they would wonder, what is the context? Why are we talking about all this? What has GHG emissions got to do with IVF or with medical? But definitely it is extremely relevant, need of the hour. You ought to know that the global carbon footprint is extremely high, to the note of 4.4%. And in India, healthcare is contributing about 5% to the GHG emissions. And this is not a small figure. I should reiterate that here, that it is not a small figure. Now, what is the problem statement of the IVF sector per se? It has potential of rapid expansion, we are all aware. Why? Because obviously there is increased demand and the technological advancement that is happening. A projected compound annual growth rate of 16.5%. So that is driving the industry. Currently we are doing 2.25 lakh IVF cycles annually, and this figure is only expected to triple in the next 5 years. Single IVF cycle, please take note. Single IVF cycle generates about 1.19 tons of CO2 emissions. And if you look at that cumulatively across the globe, that is a huge number. You cannot really overlook that. You cannot. Now, how is it that the IVF industry, ultimately is practically contributing to all this? Very resource intensive, very energy intensive. So the emissions in the industry, they stem from extensive energy consumption, because energy hungry equipments, emissions generated by the procurement process, extensive use of plastic disposables, inadequate management of generated biomedical waste, and cryopreservation logistics. So all these are responsible. And unfortunately, contributing to environmental damage, to plastic pollution, all the endocrine disrupting chemicals that are being released are in fact lowering fertility. So paradoxically, the technology which was supposed to help with fertility is actually contributing to the problem. And there is a need for concrete solutions here. Indian Fertility Society, our president, Dr. Professor Pankaj Talwar sir, and the Secretary General IFS, Dr. Shweta Mittal, wanted the medical fraternity, the IVF community, to become aware of all these facts and bring about changes for a better, greener, more sustainable future. And hence we have started a project called Green ART. So the visionary behind all of this, who breathed life into the concept of Green ART, is none other than President Dr. Colonel Pankaj Talwar sir. So sir, please share with our audience how this path-breaking idea germinated, and also what has IFS, under your guidance and leadership, done by taking up the project, And the first time ever that we are starting a program targeting sustainability in IVF.
So thank you, Dr. Meenu. I think first of all, a heartiest welcome to all of you for this very special session we are having on green ART clinics. I'm quite a vintage person, looking at my grey hairs, and today I have with me 3 clinicians and 2.5 embryologists, including me. What we have seen, what I saw, see, we contribute in multiple ways in embryology as well as a clinician. When we construct a center, an average ART clinic takes around 4,000 square feet of area. And it has got a huge air conditioning backup, it's got heating, ventilating backup, a large amount of paint, a large amount of building material goes into it. It was my trip to Israel sometime back. When I was in Haifa, when I was walking in the corridors, I felt that as I'm walking, lights are dimming, lights are trying to go up in the intensity. I actually thought place is haunted. I went to my professor and told him, sir, yahan kuch haunted hai, lights apne aap jalte hui hain. He said, no, idiot, it is not like that. It is, they're biosensing. And then when I come back to India, you find that every ART clinic is a huge elephant, just guzzling away. Like for carbon footprinting, we talk about giraffe, as we all know about it. I think it's a multiple giraffes generating carbon dioxide. They generate a lot of carbon dioxide. We have got huge AC plants. And the whole day and night our AC plants are working, HVACs are working. The whole day and night our UPS and inverters are working. And in case you look at the energy being consumed is enormous, enormous. So what I did, I wanted to find out how is the energy being generated. Simply so I went to a place in Nagpur. And then I realized that whatever we use here, all the lights are coming to us, there is a coal burning behind it. हमारे देश के अंदर बिजली अभी भी न्यूक्लियर प्लांट से बहुत कम बनती है, though we have 2 places in India which make nuclear energy. We are burning coal somewhere, and when hydrocarbons they burn, they give you carbon dioxide. So that is leading to more of carbon footprinting. That's number one, which I felt was very, very sad, because that is leading to global warming. Second important thing is that when we have more excessive air conditioning, we don't have compliant centers, we are running air conditioning plants. And when they run, they are raising the temperature of the whole area by the very fact they are running 24/7. So we thought, why don't we apply it to our ART clinic? So we sat down and we worked out how much is the carbon footprint of a ART clinic, which is a huge establishment. It is, though we may feel that we only do around 30, 40 or 100 cases a month, but it guzzles energy because we don't stop anything. It keeps working around the clock like any big hospital. So there's a time when we thought that let's do something for the community. And IFS has always stood by transforming lives and guiding people to do something for the nation. दूसरा जो मेरे में जो feeling थी, being an army guy, that was that we should have something made in India. Guys, the most important problem of carbon footprinting is the number of aircraft sailing into our country, the number of ships sailing to our country. They're called Scope 3. So there are 3 types of missions. I think Dr. Meenu and the team will cover up. So we have got traveling, or everything is coming from outside the country. And even for a small syringe which we use, I think both Yogesh and Sarpit will agree that when you use a syringe for an embryo transfer, you prefer an HSW syringe. A green syringe comes from Germany. So everything is coming from outside the country, and when it comes to your country, they are guzzling fuel in the air. Tons and tons of petrol engine are burning, and that is generating large amount of carbon footprint. So I thought, why not Atmanirbhar Bharat? And that's my feeling as an army guy who came to me, that why don't we go in for make in India, made in India, and making our country self-reliant. And for that, I think, again, in case we start making things in our own country, we won't have dependence upon all these European countries. As you've seen, I never knew that Trump will come to power, and whatever you're seeing all over the world, tariff wars, things are occurring. In case we are compliant with our own things, we don't need anyone. And that's my second fundamental, that Indian Fertility Society and not IFS, we are all one. Amit was sitting here. We are all one. We are all doctors like you. like each other. We want that we should buy minimal things from the outside the country. For that, we have to make things in our country, and that will automatically reduce carbon footprinting. So these three things were in mind, and that began our journey further.
Sir, I would like the audience to know what work we have done so far as the 9 teams that we created and how you have led it so far. A little on that, sir.
So I was remembering, Amit, he just left. I was saying in green emission, we are all the same. I mean, it's just an idea when we all work together. What we did was that we started with a launch program. See, I personally, again, my army background, I don't believe in ideation. I believe in execution. And that's what the whole team has done with the group of embryologists and clinicians. We have made 9 teams. These 9 teams are looking after the whole, and they are all over the country. We picked up people. We've got nearly 100 people in our teams. So what we are doing is that we have divided. As you can see, we do multiple meetings. Our team 1 is here, which talks about sustainable IVF. What is that? Second is the team on designing a sustainable lab. Then how does the clinician look at it to an ART clinic? Then we've got low cost, low down environment, and so on, biomedical waste and embryology, cryobiology. So we made teams. The teams are working all over the country, and now we ideated first. Initially we ideated. We didn't know whether it's going to work or not, so we ideated. And for ideation we had a CME, and then we came to the second thing called execution. Now here we are working 24/7. I think we have had more than 60 meetings done internally, and multiple of them done on Zoom meeting, on Zoom platform. And we are executing now with these multiple meetings which we are doing. We are releasing our first white paper. I think it will be the first white paper from Asian subcontinent, coming from that too from ART Fertility, which is coming in month of August. I think we are on line for that.
Yes, sir.
So we are releasing a white paper, and every month we create a bulletin. We need to create a bulletin, and today morning so Gufik, Mr. Rajiv in case he is there, and Rajiv ji is there. Rajiv ji, thank you so much for being with us. And today morning we initiated a very formal walkathon, and because I personally feel that we always talk about taking tablets. हम दवाई खाना चाहते हैं to reduce epigenetic changes. Because if we have green atmosphere around us, the babies will be green. They won't need the drug therapies. They will live longer by itself, and they'll have minimal deformities. So these bulletins we are now starting, and with the help of Gufik, we launched a program in the morning with some Zumba and walkathon, and you would have seen us all over the social media today. And now to actually execute, we have taken 5 centers have been selected. These 5 centers will be beginning their work from 15th of August. That's the plan. It's an ongoing process. It's not in my tenure. It's going to carry on for a couple of years. And these units have been selected. And the units we are now marking we are trying to mark their carbon footprint before we start, and then carbon footprinting, how things change later. So I think I owe it to you all, Dr. Meenu, Shalini, and everyone. So thanks for being with me. That's a plan for us, and I request all of you to join in this cause that goes beyond any societies, goes beyond any organizations. Any one of you who wants to join us, you're most welcome. It's not our mission, it's everybody's mission to change the world. As I end, I've been talking from past 4 or 5 minutes, maybe more. The dinosaurs would have thought that they rule the world with big claws and big teeth, eating everyone, eating each other also. But before dinosaurs, they realized one meteor hit probably, and they all vanished. In case we don't wake up today, gentlemen, ladies, we'll be like dinosaurs only. And I really wonder why the whole of US is talking about relocating to Mars. So when I read the plans, I went through what Elon Musk is saying. I actually follow him. I'm a great fan of his. They want to make a big domes on the Mars, big domes on the moon, and they want to transport people from here to Mars to stay because Earth is becoming polluted. And then they fill those domes with oxygen there. When we can't look after our own Earth, how will we maintain Mars and Moon? So I think it's time has come for all of us, and I think I'm so grateful to IHW Council and Gufik for giving us this opportunity. And thank you so much, Meenu.
Thank you,
everyone
sir.
enough.
So This was to tell you as to how the thought originated and how we've been trying to work on it. Now, to make it very practical, this may all seem like, okay, this is all just talk, but we want to make it practical. And so we have, kind of divided this into practical steps possible for us as clinicians, as embryologists, to really work on it in our own day-to-day clinics, our labs. So my first question to my two accomplished clinician colleagues here, Dr. Shalini and Dr. Anchal, one after the other, I would like you to, tell our audiences here that how can we be more mindful of our sustainable actions while we are handling our day-to-day clinical work in the clinics, in our OT labs. So Dr. Shalini ma'am, if you could start first.
Yeah. So, Meenu, beginning with that, we as a clinicians, we have to be very, very cautious about the minute and the small little things. Like as a clinicians, when we are doing IVF for the patients, the patients have to come. There are centers which call patients daily. Now, when patients are coming daily, they are using the transport, the fuel is burning, the fossil fuel is burning. Yes. Yeah, that is scope 3. Again, it is there. The hormones, they are being used, and these hormones are also being transported. The injections also, they are being transported. Then the extensive monitoring, we call them, so the small little things. It is not needed that we do the ultrasound monitoring every day. We can call them every 3 or 4 days. We can teach them to use injections at their place. The hormonal testing that is required, that also we can avoid. This is from the clinical part. Now, once we are in the IVF center, we as a persons, we as a clinicians, we can small little things like, once the sir took this great initiative, and once we read that paper, and once we realized small little things, like we are using paper. Right, left, center, we are using, for the discharge slips, we are using paper so much. Our IVF records are full of plethora of paperwork. So we can be mindful of that. Each paper requires so much, the trees are cut for generating paper. So we can be mindful of that. The scrub stations that we use, the water tap keeps on running for 1 minute, these sensors are there. So why not put it off and use them diligently? These disposables, these plastics, and these head caps and the masks, why can't be they like this can be used, the fabric caps can be used, and the cloths and all laundry bags that we are using are full of plastics, and plastics we know that they are endocrine disruptors. So these small little things, I think the change has to come from within. We don't want the change to be exhaustive. We want these small little things like switch off, have sensors, like sir said, it was blinking on and off. So let's have those sensors, these small little things. Energy intense, all IVF units are energy intense. But if we are little mindful of all those things, if we just train our staff a little bit, I think we can bring a whole lot of change in that. These small little things will definitely go a long way. If we tell our sisters to, not to waste paper, to switch off the lights, and to use the paper judiciously, to switch off the lights and avoid consumption.
Very correctly said,
water.
ma'am. Now, Dr. Anchal, what's your 2 pence on it? On the clinical side, please.
Yeah, so in addition to what Dr. Shalini has elaborated, I agree to all she says. In addition to that, a very, very important and practical point is the consents and the form filling that we do in IVF. Form F, Form G, all kinds of consents for embryo freezing, for IVF cycle, for surrogacy, for donor. So many paper consents we are taking. So if we can have a digital way of taking consents, we save our data, IVF data digitally, we take the consents digitally, and if we can devise a system with government approval so that we have video consults and we have digitally recorded consents, that is also going to save us a lot of paper. In addition to that, those who are now building new centers can incorporate the renewable sources of energy. Like we all can have solar panels. It's nowadays very good solar panel energy is available. So if not completely, at least a large portion of it can be generated through the renewable sources of energy. So this is in addition to what we
And just a little another input, like we all have our clinics wherein our patients have access to water. So the water bottles, and even here in the program, now this is the plastic water bottles should be done away with. This is all adding to the plastic burden. So this is also something we should consciously think of, the paper cups that we have in our reception areas. So these are little things that you can tweak and actually contribute. So one should not really overlook all this. And you will also realize on the long run that this will save you cost. Now this being the clinical perspective, now if you have to design your labs, what can be the measures that will help with the building material, the selection of the building management systems, the energy water efficiency? What all can contribute to making the IVF labs more sustainable? I would like to ask Dr. Pankaj Talwar sir about this particular aspect, sir.
I think, first of all, we look at the infrastructure. We should be using green paints. Something called green paints are available which have got a very low VOC output. So green paints are something like what Shah Rukh Khan is marketing on the TV. They are 5 to 20 grams per liter of VOC, they're low VOC content. So we should be using green paints in case we use them. Whatever we use, we should be using, suppose we use a silicone glue. Just for, the silicone glue also comes in multiple ways. We use a silicone glue which has got very low VOC. So they are low VOC transparent glues. That's about the type of building material should be low VOC. We shouldn't be using MDF boards because they've got resin in them. When heated and cooled, they bring out VOC. That's about the building material. Then I think energy conservation is very, very important. And average IVF center, when I look at them, they got a monthly bill of around 20 lakh rupees on bijli ka bill aata hai, 20 lakh rupee ka. On average in the peak of summers because HVAC is working throughout 24/7. So I think we should have auto-regulated HVAC systems. HVACs are to some extent mandatory the way we work. So we have to save on the electricity so that it shuts off by itself. We should use dimmers, which works without our intervention. See, we have to bring AI into the whole thing so that when we are working, that things happen by themselves. I think we have to look at the energy consumption. And thirdly, which is very important thing, which I always talk is that wastage of water. I've seen that in our scrubs everywhere, water is being guzzled 24/7. I think we should have automated water dispensers. When you go to a scrub, that should have an electronic sort of thing so that we don't use much of water. And then I think there are three things which I like to add. Otherwise, I've covered everything before.
And of course, sir, rather than that, there are lots of innovations happening. The kind of lighting that we can allow with the new kind of window systems and all. So a lot of innovation is happening in this field. And of course, it might look very energy intensive and cost-wise, you might think that setting up something like this will incur a lot of cost. But if you see the ROI on the long term and the benefit that you give yourselves and the society and your patients, this will definitely go a long way. Now, after having spoken about how and what you can do about making your labs sustainable, now our labs are the sanctum sanctorum of our IVF units. So my next question would be to Dr. Sarabpreet, who is the embryology chair of IFS and in our program. So what is your talk on measures that can be taken inside our IVF labs such that we minimize the GHG emissions?
Yeah, first of all, thanks for the opportunity. Thanks to IHW Council and GUFIC and IFS, Dr. Talwar. I've been hearing this discussion and everything looks so basic. But honestly, the basic is the only thing which needs to be reiterated. So 3 B's for me here. Basic needs to be reiterated. Mere karne se kya hoga? Nahi. Do your bit. And back to the future. We have to look back into what we used to do in the past. We used to drive glass pipettes. We can go back to glass pipettes for denudation. We can go back to pasture pipettes for picking up oocytes. Small things will make a cumulative huge difference, I feel. Along with it, education, engagement, awareness, and and total involvement of the whole staff has to be ensured. Otherwise, we really can't make a difference. We really can't make a difference if we are doing it, all by ourselves. We have to involve the whole team.
A top-down or a bottom-up kind of an approach. Yes,
yeah,
yes.
I think for a new lab, top-down. For an old lab, it can be a bottoms-up approach also, which works. Because, ultimately, you have to involve people. Secondly, as Sir said, whenever you're making infrastructure, you have to look at the star ratings, you have to go for the most cost-efficient and most energy-efficient material, HVACs, their fans. You have to look into the minute details, the incubators, the people who are doing the job, the quality control program has to be in place, SOP adherence is a must. This will not only, ensure a very good result, but also ensure that wastage is to a minimum. So again, 4 R's for me: reduce gases, reduce energy consumption, recycle whatever you can, maybe reuse scrubs, masks, you can wash, you can have cloth, as well as re-christian or innovate or reformulate the procedures. So we can have, if we are making 10 dishes, no point in using 10 pipettes. You can use a single test tube, put oil into it, and layer the dish one by one. Various ways, small things in which you can reduce the use of single-use plastics. And the list goes on and on. I mean, there is no end to it. So equipment has to be bought in a very judicious way. Then consumables and disposables, you can go for Make in India plastics, which are available now. They are world class. And even the consumables, the media, the injectables, everything is available now, Make in India, and which is actually at par with the rest of the world. So I think this is from my side, and maybe Yogesh can throw some light on the cryopreservation also.
Absolutely. So now, Dr. Yogesh, just please share with our audience how the cryogenic logistics, they contribute to the greenhouse emissions, and what you can do to minimize that.
Very first of all, thank you Talwar Sahab, IFS, GUFIC and organizers for giving us opportunity. What we are talking about, sustainable development, sustainability. It is not that cause that I am telling and you are following. It is individual's responsibility. If I am responsible for the environment, then it can help me out. Whatever I am feeling at the level of cryobiology and handling the embryos, oocytes, gametes, anything. So I am working for the gynecologist, Minu madam and Dr. Archana and Dr. Shalini. They are saying me freeze it, I will freeze it. They will tell me thaw it, I will thaw it. But what we are thawing. At the time of a number of the times I am using this liquid nitrogen, I am just adding something to the environment that is not good. More the time I am exposing. Liquid nitrogen is meant for only and only for the evaporation. It evaporates, once it evaporates, you requires more and more and more. When you requires more, you will place the order, then you will get all those trucks to carry those small liters of the liquid nitrogen to your lab. And then what I am telling, that engine is exhaust, that exhaust is exhausting something that is adding to the carbon emissions to the environment daily. So what I can minimize? I can minimize that I can tell you gynecologist to make the batch IVF or club the more of the patients so that we can do all of our work as far as this consumption of the liquid nitrogen is concerned in one go only. And talking about this daily routine work, if I am working for a good, huge lab, there are many number of the patients are happening, then we can think about this in-house production of the liquid nitrogen. There are the countries like Netherlands, small countries, very small size of number of the peoples are there. They have taken the initiative. They are using it. They are bringing everything into their lab so that minimal exposure, so that they are very less dependency over the fuels that is coming from the fossil. Fossil fuels is being burning, and when something is burning, then we are adding carbon emissions. Carbon emissions means carbon footprinting. Carbon footprinting means you are just doing something hazardous to the ozone. Once something is happening at the level of the ozone, then directly, indirectly, sooner or later it will kill me. So what we are giving our generation. So what I am doing in my lab, just I am shifted from this big box to the smaller box. I am just shifting from all the thawing and freezing in one go only. Just taking all the decision from all you gynecologists that tell me, madam, how many patients are to be done on that very day. So in one go only, so I am just not whole day involved in freezing and thawing, keeping this liquid nitrogen in and out, in and out. In one go only, small box, helping me out. And what but I am anticipating from you as an individual working for the patients, because few days back, 5 years back, there was debate in many conferences like freeze-all cycle. If you are telling me freeze-all cycle, I need to freeze it. Freeze it means what? 4 cycle failure, 5 cycle failures means how many failures we have taken and how many times we have used that liquid nitrogen that been carried by these wheels, on the wheels. So we need to minimize it. So
very right there, Dr. Yogesh, because
so much.
We all have gone into that mode of freeze all, but also then we should realize that where indicated, of course, clinically, we should not really just automatically, think of that. That should not be the norm, and even otherwise.
One more point I want to add very beautifully, because last days I was just going through this literature, comparing the fresh cycle versus the frozen. I came to know that all these frozen cycle babies, those are having more, the birth weight is higher than the fresh cycles. So why we are thinking, if they, we all very intellectual people, so if we can minimize it from freeze all to the few of the patients with the fresh cycle, then we can minimize. Then if we are collectively, as madam said, 2.5 lakh cycles in a year, and it is going to be triple. So we can minimize. If we are minimizing, then indirectly or directly, without knowing or without unknowingly, we can sustain our environment. This is something from my side.
Thank you so much, Dr. Yogesh. So again, not only on the embryology side, also on the clinical side, we have to kind of go back to the basics, try and minimize cost and our resources. So making IVF, it definitely incurs huge cost as of now. We are all aware of it. But how, as clinicians, now my embryology colleagues have spoken of what they can do inside the labs. But Dr. Anchal, as a clinician's perspective, how can we really lower the cost and thus contribute to, again, because lower cost would mean lesser resources, and that ultimately, because every activity contributing to GHG emissions. So your take on that.
So a very, very important contributor of reducing the cost is Made in India. Which was, the initiative was launched by Government of India in 2014, and we need to fall in line with that. If we reduce first and then completely stop importing stuff from outside, consumables, media, hormones. So we have such big pharmaceutical companies who are, but most of the hormones are being packaged here, raw materials being imported from outside. So why can't we have our own setups to make our own hormones? If we could make COVID vaccine, we can make whatever
absolutely,
we need.
Absolutely, correct.
So, and that was made in emergency, in a dire situation. Now we can very well plan and execute it also. In addition to that, media. I remember our old senior embryologist, while I was doing my fellowship, they used to make media in-house because it was very difficult to import from outside, and we were still getting results. Now we are 25 years above that. We are 25 years ahead of that. So we can make our own media, we can make our own consumables, thereby reducing the cost drastically. So Made in India is something we really need to focus upon. And also, in addition to that, I think we should now reduce the stimulations. Giving the same protocol, giving 225 units, 300 units to everybody and hyperstimulating. I guess now the technology is so advanced, we are moving on to single embryo transfer. So why are we stimulating so much? Why can't we give lesser doses of hormones, reduce the cost of hormone in an IVF cycle, and thereby reducing the overall cost? So this is the bit we can do on our end, and along with that create awareness and maybe put in some request to the government to make some changes in policy so that in-house production can be encouraged, some subsidies can be given, and also some technological advancements can be done
Anchal,
on our end.
we'd like to come to that a little later though. Again, Dr. Shalini, talking about the low cost that can be, implemented in IVF, what are the other steps we could think of, like, in terms of the day-to-day work, the luteal phase support that we push in, or the, adjuvants? Shouldn't we think about all that? All that adds to the cost as well.
Yeah, certainly. These little minute details and these minor uses of like add-ons, every center, every clinician, myself also, like we use so much of co-cues, antioxidants, everything. We are just, using so much of all these drugs, luteal phase, not even just one product. We are using multiple drugs and multiple ways. So these small little things, like Achal said, minimal stimulation. If it is a PCOS patient, use it very judiciously, minimize the use of the gonadotrophins, and then minimize the use of hormones, injections, tablets in the luteal phase also. So these are the small little things, I think, which can certainly go a long way if all we collectively take small baby steps.
And while we are working, the lab is working, the clinic is working, a lot of biomedical waste is being generated. So the dry waste, the wet waste, the medically hazardous waste. So there has to be proper, sequence of handling all this. This is important again. Why? Because this will all end up in your landfills or being handled inappropriately, and again contributing to your greenhouse gas emissions. So since Dr. Shalini is part of the team which is delving with this particular topic particularly, my next question is again targeted to you, Dr. Shalini ma'am, that what is it that can be done best for good waste management in this context?
So the old paradigm of 3 R's, reduce, reuse, recycle. Now we have to move on to the first and the most important basic step is prevention. So if we do the prevention at the first step, that will take us a long way. So it is prevent, reuse, reduce, reuse and recycle. So like as in my first talk also I said, in my first answer also I said that prevention means by consciously we are making an effort to reduce the consumption of all these things, be it paper, be it electricity, be it water, be it the consumption of plastics. We all know plastics like these Bisleri bottles and all, they contain so harsh chemicals. These are endocrine disruptors. So minimize the use of all of these. Dr. Pankaj Talwar sir, Dr. Sarapri, Dr. Yogesh, everybody said minimize the use of pipettes, use glass pipettes, minimize plastic use. So all this, it has to come from within all of us. Prevention is the first and most important thing. Our aim is to reduce the waste. The proper biomedical waste guidelines are there. Proper segregators, if they are the central segregators, like if we segregate the green, the wet and the dry waste, and these yellow, red, blue and white, if we segregate the waste properly, it will certainly helping in reducing the amount of recycling of the waste that we are doing. In fact, if we do the proper segregation, the recycling amount can be reduced to as high as 30%. Now, incinerators, while we are incinerating the products, we are generating the carbon footprints, we are generating the carbons, they are depleting the ozone layer, the greenhouse gas effect, they are leading to global warming and eutrophication of the toxic products. So all this is leading to so much, causing so much of harm to the aquatic animals and so much of harm to the other animals also. So I think that is very, very important, and along with that, we must focus on recycled material also, like the packaging material that comes, the gel foams that we use, they can be recycled. There should be a policy that these gels and all, the company should take it back, the plastics they should take it back and reuse, and maybe use it to generate something good which can be used for another purposes. So I think all these would take us a long way.
And again, very recently I had come across a little article which said in Lucknow, one of our own Indian cities, where the landfill waste has been treated so beautifully. They have done a wonderful job of it. And I think initiatives like this, which are becoming rather a way of life now in India. I think these need to be, spoken of, done practically on ground.
Composting.
Yes, and now that we have, spoken of the general change in paradigm or the thought process that we should bring about, we are trying to make a change, and even if they are tiny steps, and we're just beginning the journey, I think they will take us somewhere. So again, to wind up, a final word, Dr. Talwar, sir, would you like us to, have some takeaways from the conversation here today, and what is it that you envision? Is it an initiative like ours? Is it going to really make a difference? So what do you, the audience, what should they take away from the conversation that we have conducted here today? As an awareness drive, of course, but what else, sir?
I think every breath makes a difference. Every breath we take makes a difference. Every thought makes a difference. And every time we don't work to see the outcome, we know what is right, what is wrong for us. I think all of us should get involved into this. And as you people go home today, I think we spent around 4 hours every day on WhatsApp or social media looking at what people say about us or we say something about them. Today, as you're driving back home, just go to the carbon calculator on your mobile phones and calculate how much is a carbon footprint which you are generating. And then sit with your wife, look at the household carbon footprint. My carbon footprint, I think, is worth around 500 people, common citizens of the country. So much is the carbon footprint I have. And my household is mind-boggling carbon footprint. So I think मेरा एक ही थोड़ा सलाह रहेगा सबको कि इसके बारे में आप प्लीज़ आज पढ़ें और it'll take only 10 minutes for you to know how much carbon you are generating, and we must look at the Paris Treaty which says that we should be having zero emission by 2040 or say by 2045, and I think that's the thing which will probably, I'm sure that is going to shake you up. आप ज़रूर हिलेंगे और जानेंगे कि हम कितना अपने वातावरण को प्रदूषित कर रहे हैं, and that is very, very important. So first thing, Meenu, will be realization that we are doing something wrong.
Yes, first at the individual level.
Because carbon footprint for every individual is already calculated. We know how much we should generate, and we're generating for 300 people. That's by traveling every time, taking flight at drop of the hat. Everyone is having their own. So get an e-vehicle, get an electrical vehicle, something of that nature.
Yes.
But एक बार अपने अंदर झांक के देखें हम क्या कर सकते हैं. Only then we can do the things. Or one day definitely this will go like a dinosaur, and we are hitting that. Thank you so much. That's from my end.
Thank you to my wonderful panel here. I am really thankful to IHW for giving us a platform so that we could discuss something like this. And a request to all of you to be, we are compassionate to our patients, but let's be compassionate to our own selves, because by doing this, we are going to be, ensuring that our future generations at least have some future to look forward to. We do not have a planet B. We only have a Mother Earth. And I think this is the only chance, even if we start today, and this is not a one-time fix. This is going to be a sustained practice which we should follow at an individual level, at an organizational level. So it's an earnest request to each and every one of you that try and sensitize yourselves to this and try and take your little steps and do your little bit. Thank you so much.
I'm going to say something as we end. All the people who from pharma friends who actually support us all the time, I think you must look at your ESG report. There is some report which we submit every year that how much we are polluting the environment as a company. So I think when we have more made in India coming up now, all the big companies, small companies, you and me, everyone should, we look at a carbon footprint, but they look at their ESG outcome. And let us not do greenwashing. Greenwashing is like a little pigeon who will close his eyes, or a rabbit who will close his eyes. When I was in the army, to hunt a rabbit is very simple. You go out in the mountains in the night, we had jeeps or gypsies that time, and the rabbits will just freeze and they'll close their eyes, and we used to pick up the rabbits, and then people could eat them. So we are like that, we are shutting our eyes to the problem. So let's not lie to ourselves. Know the carbon footprint of your own homes. With your wives, you get a number. For yourself, get a number, and then don't do any greenwashing. Ke sab chalta hai. I think this is one thing which we have to stop it right away from today. Thank you so much.
Indeed, sir. Thank you so much, sir. So as individuals, as policymakers, the government agencies, the pharmaceutical industry, earnest request to everyone to work towards this. Thank you so much for having us here, IHW. Thank you for this platform. Thank you, everyone.
Thank you to all our speakers for this informative session. It's definitely the need of the hour. May I please invite Mr. Kamill to felicitate our guests?
So thank you, Dr. Talwar and all our speakers for making this sustainability hour possible in this very unusual conference where sustainability is normally not a conversation we jump on. One thing, Dr. Salini, so you mentioned about the plastic bottle. We do try to keep glass bottles, but sometime what happens, we believe and we learn every day. So some people came up with a argument that recycling a glass bottle is much more carbon generating than the plastic bottle. So many times you have to recycle the bottle which you buy, but you recycle on a lesser frequency. The second is, recently I learned that these are more harmful because of microplastic. So more than sustainability, it is good not to drink from this plastic bottle for microplastic, which also lead to infertility. So
In addition, because we don't know how they are transported. They've been transported in heat in vehicles, and how long they have been in higher temperatures, we are not aware of that. They come to us cooled, but before that there are a lot of harmful chemicals which are already in that water.
So I think we need to learn a lot every day and try to put in some effort whichever way we can do. And I'm sure there are a lot of action point you all have suggested. This will definitely help the industry and for all of them in their private life, in their personal life also. Thank you so much.
Small little change, like while we are going to the market, let's not take the water in these plastic bottles. We can take our own steel bottles. So, these small little things which will certainly help us.
Can we have a huge round of applause, ladies and gentlemen?
No hierarchy in good work. And we have especially got plant for this session. So we are trying to... Plant will be given by Dr. Patel. Yes. This is for Dr. Achal. We are starting from here.
Let's keep the applause going, ladies and gentlemen. Thank you so much. Thank you to all the panelists. I would request Dr. Pankaj Talwar to stay back with us on stage for a little longer.
Before you. Come closer. For doing solidarity between IVF and Islam.
Thank you, everyone. So now we have Dr. Pankaj Talwar with us on stage again for a deeply personal, reflective keynote. His journey mirrors the evolution of fertility care in India. This isn't just a talk about achievements or titles. It's about the lived experience of a clinician, a scientist, a mentor, and a change maker, whose story is also the story of how Indian reproductive medicine came of age. Please give a huge round of applause for Dr. Talwar, and over to you, sir, for the keynote.
So at the very onset, I want to thank, is my mic on? I want to thank Kamill Narayan ji for giving me this opportunity. I think that when I had to pick up a topic for this particular talk, I thought I'll speak about dual stimulation, I'll speak on Poseidon criteria or Aphrodite criteria. But something told me to talk from the heart, and that's the reason I'm here with you today. My topic for today is a bit different from what we normally look at. I thought I'll talk about a journey of a Indian gynecologist. उसके लाइफ में क्या क्या होता है before she is able to actually start working independently, what all happens in her life. And now today I'm going to put my hands into a honeybee's hive, probably to look at the queen bee, which all our women gynecologists are. So it's going to be a tribute to them. And this tribute, before I go to that, let's look at the Foxy web page. 46,000 gynecologists, I think around 40,000 will be active. Out of these, around 35 or 34,000 will be female gynecologists. That's my number as per my understanding. And look at the various specialties when you come to obs and gynae. Majority, around 80% all over the world are female gynecologists, and male gynecologists are disappearing from the scene. Abhi bhi, I think there are only two in this forum, Dr. Amit and me. We are disappearing. Third one, lovely, but still percentage. So this is one Dr. G. Look at him in the female setup. And this is Dr. T, Dr. G and Dr. T, immensely popular doctor, my favorite guy, Richard Gare. And but so when we start this race today, when I planned about this talk, I think the female, I am focusing on female gynecologists, not a male gynecologist, because we are as such useless people. Now, so many court cases going on, wherever you go, there is some litigation going on, people are talking about us, medical negligence, forcible deliveries, and whatnot. I think we are in thick soup. So I chose this particular topic. I've been interacting with large number of doctors all over the world in the past few years. We have maybe around 2,400 doctors. I've learned from them. It's nothing which I'm going to talk to you today. It's nothing from my own. मेरे दिमाग की उपज नहीं है. And this one picture we will find two male gynecologists. Otherwise, out of work we have done, majority of them, they are female gynecologists. I hardly see any male gynecologists in this picture. There are few of them. So, जो भी आपसे बात करूँगा आज, मैंने उनसे सीखा, उनसे पहले पूछा, सीखा, ट्रैक किया और उसको यहाँ पे मैं आज रिप्रोड्यूस करने वाला हूँ. So we are not living in only, we in our country we have got tier 1, tier 2, tier 3 cities, and this is a place where I come from. The world is not Gurugram or Mumbai. The world can be something, a small city like that. So I think the things available to a gynec will differ from place to place. So why am I here today? That's my background. I have trained the journey of a gynecologist after talking to people, and whatever they told me in the past 5 years, I'm putting in front of you. I think it's a tribute to a female gynecologist. And how will it help all of us? Let's understand the complexity of evolution of a female gynecologist, evolution of a female gynecologist, nuances of being a female gynecologist, and deep dive into the unknown subject. We take a gynecologist for granted. This is what I wanted to show, that how much they do for the community. And who is a gynecologist? Someone who can probably wear gloves like that and who can go to the labor room. Obstetrician is the most important thing, and then they probably deliver a lovely baby. That's a job of a gynecologist. Maybe she'll take out a uterus or something, but this is what a gynecologist does. Now, the life of a gynecologist is a journey of 10 centimeters. Actually, I'm also a gynecologist. It's only 10 centimeters which drives our life. It's a fact, ma'am. Dr. C.N. Purandare said that. I'm quoting Dr. C.N. Purandare. In that 10 centimeters journey of delivering the little baby, she's dealing at 3 lives. Life of the baby, life of the mother. And I think she dies every time she delivers a child, because I know I've been an obstetrician myself for more than 15-20 years. She's dealing with, but unfortunately we don't speak about her life. We speak about the life of the little baby. We speak about the life of the mother, maternal mortality, fetal mortality, but we never talk about her mortality. She's dying every day, she's pulsating and intensely judgmental surrounding, everybody looking at her, and just to jump upon her, people are there. Timeline journey of a female gynecologist. Now look at it very intensely. We have very senior gynecologists sitting over here. Just think about the timeline journey and tell me in case I'm wrong. Do stop me there. Now this little girl has taken birth, and then the girl grows up and she's finally in the queue appear for NEET exam. And sometimes the exams are feared, sometimes they have to repeat the exam. And then look at her journey. From class 10 to the class 10 to 12th journey is for 3 years, I said, because she may not get gynae in the first attempt, maybe 2 to 3 years. Then journey 2 is from MBBS and internship, 6 years, NEET, PG and MD, 4 years, then senior residency, 2 years, then she's gonna come to probably IVF, like all of you, like me too, 3 years, and then independent consultant, 1 year, and now she's ready to shoot. So by this time, she has already achieved age of around 37, 38 years, and she's put in around, on average, around 17 years to reach this point of time. I think all of us, so launch of a satellite, free satellite of an IVF gynecologist is 19 years. IVF gynecologist, 19 years ke baad, she is saksham to head her own clinic and her own center. Then look at the timeline of chronological age of an IVF specialist, passing out at 18 years, and that's the way she goes. At 35 years, 36 years, she is willing to now, she is able to work independently, like a satellite. Biological journey, just a passport journey. Let's look at her biological journey. She attains competence at around 40 years. Iske beech mein there will be marriage, 2 children, maybe 1 odd abortion, no break for honeymoon, she is always working, no family holidays, and she is doing whatever a superwoman can do. What happens at 40 now? She comes at 40, 39, 40. The elder child of her is at 14 years of age. 14 years. Look at this, nearing class 10th. His NEET journey has started now, or her NEET journey has started now. They all want to have the children to be doctors probably, or anything. Younger one is at class 6, ready after 2 years to go into that NEET journey. The battle starts at 40 for her, the first child, and she may be settled or unsettled, but she's not able to compete with the people around her, because she's worked so hard in her life, but now when she wants to actually relay the satellite images, the child comes forward. Bachche ko dekhna hai pehle. Intense competition for gynecologists. Now look at this lovely picture, and this is true from the heart, that she becomes a gynae oncologist, but she's competing with oncologists outside or a surgeon outside. Tier 2, tier 3 cities. She does gynae laparoscopy, she's competing with a routine surgeon who's doing laparoscopies. Fetal-maternal medicine, radiologists are opened up their own labs nowadays and they are doing dual marker, triple marker, quadruple markers. I've forgotten how many markers there are. IVF is a safe haven as yet, but I don't know how long. So the people are moving towards IVF. Obstetrics is the elephant in the room. Let's look at it, the partogram. This is a partogram. She's looking at reduced variability of the FHS, CTGs, but no one looks at her CTG. No one looks at her CTG, but she's looking at every other CTG in partograms, and no one gives her this little cocoon, bundle of joy, some warmth she's not getting. And her whole life revolves around her kitchen, making some food or doing an ARM in the labor room. So life just carries on and life revolves around these many things, and she's maybe, I remember my own time when I used to get up in the morning, come home at 4 o'clock in the night, at 7 o'clock when I used to wake up, I never thought I'll brush my teeth or I'll go to the washroom. I'll ask patient ne susu kara ki nahi kara, I'll call the labor room, urine pass kara, fetus pass kara, because that becomes more important for me as a gynecologist, and that's what happens with a woman and for anyone. So she's caught in the whirlpool of very demanding patients and specialties, and what I felt after I heard from them that they are not adequately trained in ultrasounds. But there is lacking in our main postgraduate program. She is not adequately trained or not trained at all in andrology, not adequately trained in laparoscopy, and she is not actually, this is a word, not trained to be an entrepreneur. But now every gynec is actually becoming an entrepreneur. She is not trained the MBA language, she doesn't know about ROIs, and she is on dependent for other people in small cities, tier 2, tier 3 cities, on other surgeons to help her when the rate of litigation is very high. Time spent per week. Now look at this lovely picture. This is a truth for all of you. And these, keeping in our country, there are no midwives. So deliveries are, majority of our, we have midwives, but majority of deliveries are being done by the gynec. I'm very, very sure that when we are doing obstetrics, all the work we are normally doing or sitting in the labor room. She has no holidays, no Sundays. We can't switch off our mobile phone at any point of time. She is never sleeping with assurance that no call will come, no litigation will occur, and she is doing on average one emergency duty per week, minimum one emergency duty per week. So no probably henna for her, no big marriage ceremonies for her. Look at number of hours she is putting up. This is an American data, not an Indian data. Look at OBG. OBG comes second. Our women gynecologists are putting, they are second in the terms of full-time work they are putting up. And if you look at the complete specialty wise, they are somehow putting in around on average 54, 55 hours or 55 hours per week. And average working hours for Indian are 46 hours. An Indian works 46 hours, they're already putting in around 55 hours per week as a mother. So average emergency specialist puts in around 65 hours, but an Indian woman, when I run my calculation, which is a true calculation, she's putting around 82 to 83 hours per week. Because in our country, there are no midwives. That data was from European countries where for every delivery, midwife is the first point of contact. You are hardly ever called. Now here, there is no midwife working. So she's working around the clock and she's putting around 83 to 85 hours per week. Think about it, more than double which an Indian is putting, our female gynecologists are putting. Just think about this, and I think we don't even realize it. The most hardworking people in our country are gynecologists. Extracurricular activity jobs of the gynecologist, PTMs, they have to attend parent-teacher meeting, they have no option. They have to make tiffin for the children, ensure that there are enough pens and pencils and erasers to be kept in the bag of the child. They have to wash vegetables, wash utensils, and what happens behind this lovely snacks which she has created, we never realize. She is as good as delivering the baby or applying a forceps or a vacuum as making bhaji at home. We never realize that. So these all things she's doing, looking at the kitchen, children's exams, and so on, which we never even realize that she's doing. So she's a multitasker. She's a multitasker. Indian women are multitasker. This is me. This is actually me as a gynecologist also. In case I come home after even if I do 13 cesareans in the day, which I used to do at once upon a time, come home, have my little drink, watch some TV and sleep. I never bothered about घर में क्या हो रहा है, मुझे क्या फर्क पड़ने वाला है. But women are not like that. Men, we become totally confused. In case you give me a lot of inputs, I'll get confused, but the women fight back. Issues which gynecologists face, again female gynecologists face, they face some amount of depression. Obviously they get tired and there is no one to, because no one actually understands them. She's got no one to talk to. She keeps working. Little babies, no one to take care of. Who will take care of? Nuclear families, sasu ma, dadi ma, saath mein hai nahi. They are staying in big cities or small cities. They are all alone. Probably she's crying like this. And this is all I have learned from my people who come to me for learning. Look at the burnout rate, obs and gynae, 53%. That's the burnout rate of obs and gynae. And as per another gradation, it is fourth highest burnout rate amongst all specialty gentlemen ladies is in the gynecologists, and they are female gynecologists because they are nearly 85%, and male gynecologists, even if they are there like me, we are of no use. We hardly participate in what's happening at home. Medical legal issues in gynecology are burning them day in, day out. There are medical legal things coming up, and here we all know about this doctor. Don't harass innocent doctors. Love you, please मेरे बच्चों को माँ की कमी महसूस नहीं होने देना. She's a gynecologist. I've never heard anyone else doing like this because so much of pressure she's under and no one talks it. मेरा मरना शायद मेरी बेगुनाही को साबित कर देगा. Just look at this. I think they are superheroes, superwomen. Burnout rate, low self-esteem, depression, suicide, divorces. I think every time I meet a couple of doctors, one of them is going through a divorce proceedings. All are very educated doctors, but life is in a different motion. So a tribute to a gynecologist, as I said, how to strengthen her. I think we have to, for all of us in this room, we have to actually remove our cobwebs. We have to look at the gynecologists with a different perception thereafter. Their mother-in-laws, the husbands like me who are of no use, we never help our wives in anything. I think we have to give a woman boxing gloves to fight the world. That's very important for us. I think we have to hold her hand and pull her up because she's being ignored after working so hard. So one thing is that we should be having midwife training programs in this country where they are able to take away the work of a female gynecologist. And I think it's a very important thing I want to do. Resilience and bounce backing of the woman is very important, is what we do. I think give them complete cover, give them assurance that when they're working, not to worry about anyone. There is someone watching her all the time. This is what Foxy is always doing, watching our gynecologist and making them feel free. And I think more number of men, today we are only 3 in the room, we should be minimum 30 to 40% more gynae should come into play. We have Hitendra sitting behind, he didn't raise his hand, the 4th one is also here. Okay. So I think we have to rehash her training pattern. We have to strengthen her so that she looks at her specialty with a newer perspective. Why are we limiting our gynecologists to the labor room? Now they all at 40 wants to break free, but she doesn't know what to do. Why should she be doing only ARMs and looking at meconium stand like us? I think she needs more training, and then we have to protect her professional integrity, talking about her work at the national level and glorifying her work. That's very, very important. And a tribute, I read this beautiful paper by Dr. C.N. Purandare, which came in the Foxy Journal. His 45-year-old journey, which actually mimics what I learned from nearly 2,500 doctors with whom I spoke before I gave this presentation. I have spoken to so many doctors over nearly 90 hours each, and then I have come to this presentation, and I found that Dr. Purandare has already written it over here. He's already written it over here. That's why he's Dr. Purandare. He didn't need to meet so many people. And my tribute to my teacher, Vice Admiral Ponita Arora, Lieutenant General Mrs. Ponita Arora, the first woman general of the country, and she is a gynecologist. She is a gynecologist. I think a tribute to her, tribute to Dr. C.N. Purandare. And a woman is being supported, a woman supported by the parents. Now when she comes, marries a person, a male, I think we should give her wings to fly. We shouldn't put everything on her. I can be probably, I don't do these things, but I should be also doing. she needs care of her mentors and seniors more than a male gynecologist. We don't understand what is happening in her life, so please take care of a woman gynecologist. Family life is very challenging for her. Try getting up for any male. Hitendra, how many times have you made tiffin for your children? I just want to ask you. Not. We don't. I think we should look inwards and introspect. And we have to give her, not only give her wings, we have to make her spread her wings and fly. That is our duty. And society has to be sensitized towards a woman's growth, and this is the superwoman we have. And I think we have to give her a lot of colors in her life, give her growth, we should hold her hand and make her grow further. So we have to give her wings and make her fly. This is my last message to you, and I think this is it. So I've taken around 14 minutes. I think it calls for a standing ovation for a woman gynecologist amongst us. I think all of us can, it's an occasion where we must clap for them. And today when we go home, we should actually know with whom we are dealing with. That's very, very important. So thank you so much, gentlemen, ladies. I have done my presentation. अरे ज्योति आ गई मैंने ठीक बोला ना वैसे मैंने मैंने 2300 डॉक्टर से सुना है मैंने ये सेम कहानी हम पता ही नहीं हम लोग कितने निर्मोही क्यों हैं एज ए मेल्स वी नेवर रियलाइज दिस Yes, Tendra Raja. Good. Thank you so much. Great. Thank you so much.
Thank you, Dr. Pankaj, for such a meaningful talk. Ladies and gentlemen, we now continue with our next session of the day, Innovations and Access in Fertility Care, Making IVF Affordable, Accountable and Accessible. While India has seen a rapid expansion in IVF centers, the cost, information gap and social stigma continue to make fertility care out of reach for many. This session brings together leaders from healthcare delivery, financing, law and entrepreneurship to ask the big urgent questions. How do we reduce the financial burden of IVF without compromising on quality? Can innovation and inclusion go hand in hand in reproductive care? What role do corporates, insurers and legal frameworks play in shaping the future of access? And how can we bring more transparency and patient protection into the fertility ecosystem? May I now introduce and invite the panelists. Ms. Ojaswini Kapoor, CEO, Bloom IVF Group. As the CEO of India's leading IVF networks, Ms. Kapoor combines business leadership with a patient-first approach. Under her stewardship, Bloom has grown its footprint while maintaining a sharp focus on clinical ethics, trust and transparency. She brings a strong understanding of both scale and accountability in fertility services. We also have Dr. Shweta Gupta, Director, Reproductive Medicine and ART, Max Healthcare. A senior clinical voice in reproductive medicine, Dr. Gupta is known for her excellence in IVF outcomes and her advocacy for evidence-based protocols. Her work at Max bridges both the clinical and systemic barriers that affect patient access, especially in complex fertility cases. We also have Mr. Sarvendra Mani Tripathi, partner Lex Curium, a legal strategist with deep expertise in healthcare, law and reproductive rights. Mr. Tripathi brings clarity into the often grey areas of consent, liability and compliance in ART. His insights help frame regulation not as restriction but as responsibility. We also have Mr. Sakti Prasad Menon, Executive Vice President, FIBE India. At the forefront of fintech and digital lending, Mr. Menon is helping design financial solutions that can enable more inclusive access to IVF treatments. His work explores how smart financing can support patient journeys and institutional models alike. We also once again have Dr. Vasundhara Jagannathan, Managing Director, Sri Chakra Fertility. As our moderator, we have Mr. Vikas Anand, co-founder and CEO, SafeTree. Having just introduced us to IVF insurance products, Vikas now returns as moderator, bringing together perspectives across business, law, healthcare, and finance. His position at SafeTree gives him a unique vantage point to lead this discussion on affordability, innovation, and responsible expansion in fertility care. The panel is titled Innovations and Access in Fertility Care, Making IVF Affordable, Accountable, and Accessible. Just allow us a couple of moments to set the stage, and we will then invite all our speakers. May I request all the speakers to please join me on stage? And can we have a huge round of applause for everybody? And over to you, Mr. Anand, to moderate the session. Thank you.
Good afternoon, everyone. Fertility care in India has been evolving at an amazing rate. Medical advancements, the number of IVF clinics we have got, and also the acceptability of IVF has increased significantly over the years, which has given lots of hope to millions of aspiring parents. However, the challenges of affordability, accessibility, accountability still remains. Recently, there was a UN report which said the decline in the fertility rate has been much more than many of the experts would have stated. So it's very, very important that we need to have a complete discussion. How can we bring innovation, accessibility, and also accountability in this process? And in this, we have an esteemed panel with us, and we have panels from clinical excellence, law, finance, innovation in healthcare, and we'll try to talk about ways how we can redefine the future of fertility. And I'm hopeful of we are able to come up with lots of discussion, useful discussions. Starting with Ojaswini. Affordability is a big, big problem. We have talked about it. If you could just explain us how the operational and clinical innovations at Bloom have helped reduce the cost and expand access without compromising on the quality.
Sure. First of all, I'm really happy to be here in this August gathering, and thanks to ISW Council for organizing this. My question is specific to Bloom IVF, how we are, tackling this problem. And our group headed by Dr. Rishikesh Pai and Dr. Nandita Palshetkar has been, focused on providing access to IVF since more than 30 years. Now there are two parts to it. One is operational part and one is the clinical part. So operationally, of course, there is one very important thing that we have done, that is hub and spoke model. So not all the centers of ours are IVF. This is how many chains are operating. So suppose there is a spoke center in tier 2 or tier 3 city, and a very connected city, tier 1 city has the IVF center. So that is how we are reducing the cost and increasing accessibility for those patients. Second thing is digital counseling and telemedicine, which actually after COVID has really expanded. So that helps in patients not needing to come many times. Of course, they have to come for monitoring. They have to do all that. Monitoring can happen in their areas also. So that is another thing. Now when we come, so this is more of like management and operations. Now, clinically, how the doctors are, of course, all the doctors here will explain it better, but just in a short brief, one is that we have mild stimulation protocols. We try to use that. We use antagonist protocols nowadays. So that helps in, reducing the cost for the patient. Then things like we have batching system. That is very important. That is how we are reducing the cost. That suppose there is a tier 2 and tier 3 city where we have a center. So we don't do IVF cases all the time there. We batch them into, within a week or within 2-3 days. So that is how we save the cost. Then technologically we have AI, we have embryoscope. So how that helps is by increasing the success rate, we are decreasing the cost of multiple IVF cycles for the patient. So that is also one way that we look at. And there was, I think, one more point, which I'm forgetting now, so I'll add it later.
No, that's extremely useful. Mr. Menon, many young adults in India cite financial limitation as a major barrier to starting a family, and traditional health insurance they don't cover about IVF. From a fintech and financial services standpoint, how can innovative financing solutions help IVF affordable? And what role can financial industry play in ensuring hopeful parents aren't turned away from the treatment due to the cost?
Thank you so much and good evening all. Coming back straight to the point, we all were discussing, and even in the previous panel, and this is a very recurring discussion that happens in this space. How do we bridge the gap between what they want and what they can afford, right? So definitely what they want in this common discussion is to become from a probable parent to a parent and have another person added to the family. But what we have seen while we have been working in this industry is that there's a huge gap in the understanding. The moment people think about affordability, it becomes like, hey, I have to take a loan. And taking a loan itself is a burden. And already people walk into this decision after a lot of mental stress. And then after a lot of mental stress and then another loan, it kind of creates a difficulty burden to the probable parents. And what, as a lending company and a fintech company, we do in this space is to eradicate that process of having another mental block. So why are we here is because we are as strong as the partners we work with. So today I take a pride that we work with a lot of large IVF chains in the country, and we've been able to co-create programs with most of the chains, where rather than it looks like a loan, we create it more like a program. And it's not like look. When I say look, it looks like a very fabricated word, but we actually mean it. So when like what ma'am was saying, when they walk into for a counseling, we make it part of the counseling, which says that, hey, rather than you spending a lot of investment on day one, why don't you make the treatments into a differential plan? Or rather than going for a single cycle procedure, you can split it into multiple procedures. And one of the coupling questions that you have had is on the limitation of insurance. Today, either you need to be employed with a large corporate to have that insurance, or else you don't have that. So I still remember last year, one of the agenda that we took away from this session was, we will work towards it, and I'm super proud. Yes, Safety is one of the partners, and also we are working very closely with few insurance companies in this space, and we have also co-created a lot of products which could cover all the cycles, and the IVF chains definitely don't have to compromise on the profit part of it, and the second, the patient also doesn't have to burn his pocket. So this is how we have been trying to bridge that gap, and as I said, when we work together as a fraternity, the insurance companies will someday have to get into the space where they can also, bring in more innovation to bring this. Today, there's no regulator who's asking it, so that it's spread across. Nobody wants to take the ownership. So I think with Safety also being part of this scope, insurance and affordability and the science behind it, definitely I leave the doctors to talk about it. Science come together, it becomes a much better prospect for the people or the probable parents.
Can I just make a concern over here from a clinician's perspective? Because, see, whenever there is an insurance discussion that happens, especially where patients are there, they might be in their 33, 34, but then we see patients with decreased ovarian reserve. Or, nowadays the marriage age is like, getting married itself at 38, 40. And insurance cover, if they take, I presume there is a waiting period. So are we really, doing justice in, giving insurance, because their biological clock is anyway ticking and they're already in that pressure. And somehow I think we have to work on the waiting timelines is my sincere suggestion. I'm sure you must be working on those lines, because this is the need of the hour, basically.
100% agree, and today we are launching few products which does cover a reduced waiting period. So an attempt has been made by Safety to get similar kind of a product, but can I have a product with zero waiting period? That won't be possible. Insurance is a risk mitigation tool. It's like similar to wearing a seat belt or a helmet, that in case there is an accident, my ability to mitigate the loss is reduced. So it can't be something of once the accident has happened, then I go for it. So definitely we have come up with the products with much lower reduced waiting periods, but asking for a product which doesn't have a waiting period from an insurance industry perspective won't happen.
Yeah, that's quite good that you're bringing out at least a shorter waiting period. More important would be like how he was saying that he's collaborating with other partners or employers to give benefits to the employers. Everybody getting included, all the MNCs coming together, so that then they have their reproductive autonomy. Exactly. That is more important, and that work.
I just wanted to ask, I think nowadays the corporate are also covering some of the IVF procedures, isn't it?
Yes, ma'am. So like I said, that again limits the democracy. So today what's happening is that people who works with a Google or a PayPal would be able to afford it, versus someone who is working in a smaller company is not able to get that. So how we are bridging that gap is working with the TPAs or the companies providing insurance, saying that we should add it as part of the package, or else we plug it as an affordability suite, so that the day they join the company, it becomes a part of their joining benefits.
I think the biggest challenge is, the mindset and the lifestyle. I mean, I work in South Delhi in Mac, so, they are all having money. That's not the problem, but they have come so late that the requirement, the cost, the add-ons, everything, because as a clinician, I want to get her pregnant and she can afford. This is how the younger generation is. In fact, they all are coming for egg freezing also, which is good, but not all. Last couple of years, I think we have seen this change, that they are getting awareness from their friends and also they're coming. But they come so late, that lifestyle, that the cost is at that point becomes very secondary. I think that awareness has to be there, but that's about the, the well-off people. Of course, the other part, of course, if you go to the tier 2 and tier 3 and the small, the people who can't afford much, where there is a problem, of course, the affordability is a problem. And ultimately, whether you are rich or poor, you do look at the cost also. Yeah.
True. Along with the affordability, ma'am, you rightly said, it's the awareness problem. I think there has been discussion. We need to make couples at the start of they getting married. A child is an option. They want to defer it, but there are means available, like you rightly said, egg freezing, insurance is coming up. So these kind of things, we need to make them aware.
Yeah, access is not equal to affordability. I think it is the awareness, it is the acceptance, going to grassroots levels in the villages where there is a lot of taboo and misconceptions, And then, you know, getting out, they also might need egg freezing. They also need all those, you know, we need to create that equality amongst the segment. So accessibility is not equal to affordability. And it's probably, you know, we should ask the patient, nowadays it's a common statement, I can't afford IVF. It's not about affording, it is about whether you're feeling safe throughout the journey, whether the entire system is transparent, whether you're explained your individualized success rates, and whether you're emotionally supported through the journey. I think everything is important in accessibility to fertility care.
100%. Transparency is very important. I'll just, there was an article by one of the magazine, Ken, which talks about the lack of transparency within the ecosystem. So we will talk about that. You rightly said that. Mr. Tripathi, how are the new ART and surrogacy regulations shaping affordability, transparency, and ethical practices within the IVF sector?
See, I think I thank you all for inviting me here. I think the affordability question is answered by Ojaswini ji. I think that is the best answer I found. However, the transparency and other thing are there. So the consent management platforms, the consent management regulations, ART regulations, and surrogacy regulations, all are there. These regulations are providing confidence to the people also, so that they think now they are knowing it, like this is the good way to do things in that way. And the other transparency part for the because of counseling and other management systems which are being introduced by the ART and IVF clinics. So these are also added with ART and surrogacy regulations, which are supplementing all these questions.
This is promising. One of the things, preamble of these regulations was to bring transparency, and I'm very pleased to know that this is working.
Yes.
So can I just add?
Yeah, sure.
So I think obviously last, since the law has come to India, so the registration part has definitely, all the registration is there. But even now, we don't have those performance, KPI, the honest statistics which we have if we compare to HFA or if we compare to the Gulf countries or US. I think that is still maybe because it's in early days. So the transparency is still not complete. Yeah, it is up to the stage of getting the registration, but not on the results. So the patients wants to know the results as well, how good or how competent that IVF center is. Otherwise, everything is equal.
Exactly.
So, sorry, can I add one question actually to you only, ma'am? Actually, while I was reading few months back about some study, so what they were saying, like HFA and all, they display their results, online.
Very honestly.
But they also mentioned that because of that, what is happening is that sometimes poor responders and patients who have repeated IVF cycles, the clinicians are not ready to take them, because what will happen is they know that the success rate might decrease.
So the statistic is made on the basis of some categories, less than 35, more than 35. So you can actually go into much detail. If you are a thorough, if you want to see the statistics, then it is divided on the basis of age, category, you can divide it in different. So there are some standard performance indexes to check the embryology team, to check the clinicians, which is followed. I think probably in few years we will go that far, and each center will have to do an annual reporting of some sort where they will send this and maybe keep
I
it.
believe many things comes through competition. So the government may not be fully onboarded to these extent of KPIs. I think the more market awareness, more customer awareness, and the competition rises, this will be one of the things everyone would be asking about. So it's the way any market has evolved, and I feel infertility market is no different from anything else. With you, ma'am, Dr. Gupta, from a clinician standpoint, where do the real cost inefficiencies lie, and what solutions are workable without compromising on outcomes?
So, so from a clinician, I want to get her pregnant, and if possible in the very first attempt, so that the overall, as Ojaswini also saying, overall cost will definitely reduce, because why does she need 3 cycles if you can give the best result in the first? Sometimes, so in that, when you want to give or reduce the time to the pregnancy, you have to individualize. So from the clinicians, of course, the cost is important, but at the same time, how I can give the superior result. That is what and of course, that is where the excellence or the expertise of clinician is, that at the same time you have to keep the cost less. So sometimes people think that, as we discussed in the previous panel, okay, give her 450 dose, a high dose. It doesn't work like that. You have to individualize. Sometimes the minimal stimulation or the moderate one, even with 300, so you actually reduce the cost. So your knowledge, expertise, you must be at par with what is the latest standards, guidelines, the different ASHRAE, or even, the different guidelines of ASRM. So one needs to keep updated, but yes, you can reduce, like the right kind of, injections. Why should we add all the add-ons to one patient, individualized? So there are ways, and clinicians should always keep in mind. I think the previous panel was very good, where they said, everyone is freezing. Why are you freezing it? Not just because, you're putting it in a chemical. You can have sometimes a better result with a fresh cycle. So just don't make the attempts, give it the best. So I think those minor things about the cost must be kept in mind by a good clinician.
So customization becomes important.
And sometimes we do pooling as well. So, if required, as Ojaswini was saying, you can get only 2 eggs or 3 eggs. Then we have to pool and then maybe take it to the day 5 and then do 1 embryo transfer. So it all depends upon the case, individualize or customize, yes.
Thank you, ma'am. Dr. Jagannath, you deal with a large number of patients. What is your assessment regarding affordability and thoughts to improve affordability?
See, affordability, again, one cycle and done all. So for that, we need to have quality products, which can be, procured. We should also look at what is the KPIs and the standards of the drugs which we are using. See, at every level we need to look at, so that we optimize one cycle and done all. But the main problem I am facing is patients are accumulate their lifetime money, and they reach us only at 39, 40 years, and then expect a result in the first IVF cycle, or maybe they will be just landing up in donor oocyte programs or embryo adoption. So the cycle cost goes up that way. We need to do appropriate counseling, financial counseling, support them emotionally, and then explain to them the costs, and then they're able to accept. And when we, as trained clinicians and embryologists, keep auditing our performance, we know that, we are maintaining the industry standards or the, world standards of providing the quality of care to our patients. And we show those data to our patients, they do agree. It is not that, one patient is having 2.5 lakhs, the other patient have to go for a pre-GTA cycle, and her cycle is going to 3.5. We need to sit and say that, advanced maternal age, if you are a suitable candidate, if you're going to do a PGT cycle, you're going to reduce the time to pregnancy, and that is how you will reduce the cost, rather than doing multiple IVF cycles and having a failure and then doing a donor cycle, and that's going to escalate your costs. So these are the various clinical scenarios we face, and definitely there are patients who do drop out. And, we as clinicians also have the onus to say, probably you need to go for adoption. Don't keep on trying cycles, because we have patients who have multiple IVF failures, maybe 8, 9 miscarriages, and it's on the onus for us to say stop treatment as well. So I have done that discussion also with the patient, and I agree many would have done the same situation as well.
Thank you. Coming to you, Ojaswini. This sector has seen lots of private investments, and private investments comes, and there is a possibility the IVF being used from a need to want. How does an IVF chain ensure ethical practices and accountability, and how do you balance between growth and profitability with transparency?
See, IVF need and want, I really don't think that people want to go for IVF. Definitely not. I've never seen that. See, everyone wants minimal, solutions which are minimized in, nature. So, of course, they come for their checkups, they, get whatever IUI and whatever is done, and if required, they go for IVF. But yes, as you're saying that as we are into this model of expanding to all the cities and all the chains want to expand, so obviously there's a lot of competition and all, but how you maintain, transparency with the patients, as well as what is important is that you continuously give the results. Because the problem with IVF is one of those, rare specialities where it's not a 100% result. Like if it's a knee replacement, so okay, knee replacement ho gaya and it's done. But with IVF, it's always a 50-50 is the best case scenario. Otherwise, whatever 30-40%. So, like if you're expanding into different regions, then most important thing is the standardized protocols. That you have, as a chain, have some standardized protocols which you train your entire staff. From the, of course, the clinician till the ground level GDA or the nursing attendant in the OT or the OT assistant, because that is how, overall, because every small part matters in that. You can reduce the cost for the patient by, automating certain things. Like we have witness system in the embryology, so there's no mix-up. You're sure that there's no mix-up. There's no need of repeated, witnessing. So things like that you can do. But obviously, nothing can compare to the magic of the doctors and embryologists. So, they are trained, like if there's a junior embryologist, or as I said before, you have a batching system that the senior doctors and embryologists go once a month or something, and they do the procedures there so that, the patients are also happy with the results.
Thank you. Mr. Menon, how is fertility financing evolving in India? Are models like pay later, EMI, bundle financial products viable and ethical for IVF? The reason why I'm asking is I was talking to one of the leading IVF chain recently. The CEO mentioned that there used to be a couple of years back 4 or 5 companies who were in this financing this thing, and over the years that have come down to 2. So definitely I'm sure their NPAs would have increased, that's why they are out of business. So how is this sector evolving given the current scenario?
I'll break this into 2. One is about what happened with our peers, and one is most importantly the ethical part, like you said. We as an organization would never want to even position us as a loan providing company. We do that in other capacities when we give personal loans, but when it comes to healthcare, we're very certain that we are there to create impact. So fertility is not the only space we work. We work with around 2,000 odd hospitals across the country providing financing for surgery. So people who don't have insurance, short of insurance, also reach out to us, and we work with large chains across the countries for that matter. So we always take a pride in saying that we want to work as a impact creator rather than someone who is giving loan and then behind them to just get the repayment back. So even to make that happen, we have different models. Like say if somebody doesn't, we understand if someone goes through a treatment and he or she's under rehabilitation, they'll not be able to pay EMI immediately. So we have cooling period or moratorium period for them to get out of the rehab. Say we give 6 months of a cooling off period. They don't have to make the EMI, so they get off the bed, and when they start working, then they make the payment. So we work with different models in that space to make it ethical. At the same time, when it comes to IVF, I would like to take a point what doctor was mentioning is on the counseling. Counseling is where the largest change happens. Today, what we have clearly seen is that people are in a hurry to make money. And I have had good and bad experiences. So definitely bad experiences teach us what and how we can change is on since they are incentivized. The staff on the clinic centers are incentivized to just close the cases. It's more to do with them and we working together to tell the patient that when to declare this is not going to happen. And if it is going to happen, it's not about just money, how to plan it properly. So we have given them calculators, we have given them models to work on, saying that if one package is say for X, how can they convert that into 6 months, 10 months, 12 months package program, so that it doesn't burden out. So that's how we work along with these partners, and we don't work as a company alone. Like we don't say tomorrow this is the 3 months, you only get 3 month option. No, we work with each and every individual partners. They tell us what they want for their patient, so that their clinical staff can counsel the patients better. To the second side of the question about what happened to the peers, see, financial industry, like whatever I say, if I have to make money, I have to get the money back. Otherwise, I don't survive. What would have happened, and I don't want to comment on what would have happened otherwise, is largely a lot of NPAs would have happened when you don't underwrite the loan applicants correctly. So you have to know what they can afford to, and how you can mix it with the right set of partners. So we work with the right set of partners so that we ensure that we give money only to the people who deserve it, and how do we give it. And we are very good at collecting back the money, not in a very pushy way. Like I said, we wait for 6 months or 9 months depending on the financial status. That's why today I take pride, Bajaj and 5 are the only 2 players who are still in this market for the last 4 years. And we have been growing it steadily, and last month we've been able to finance 800 cycles. So in the last 1 year, we take pride that around when we published it last 4,000, we've been able to provide babies for 4,000 babies out there, and the patient stories that come back to us when they're 2-year-old, they send us cards, and that's what makes us work more and more better.
Just one quick question I had, just taking what Ujasvi just mentioned. This procedure is different from a knee surgery. Have you had any kind of a pattern between financing for fertility treatment versus any other? Any pattern that it's...
Very much, because knee surgery, like what Ujasvi said, is very clear. You replace it, and 99% of the time it's successful. If it's a very
my
rare.
question was from a financing
So
perspective.
again, financing is a black and white. You give money, that's it. But the larger part is about the outcome. So when it comes to IVF, it's always about the outcome, and that's why we don't get into finance first. We go to the counseling first, make them understand you're taking money not for the success rate, but you're taking money for the treatment. Treatment could depend on multiple conditions, and the clinics would be able to explain it better. So please don't relate your outcome versus the money that you borrow, because that needs to be treated differently. So that's how we've been able to mitigate it better in our hospital business versus what we do in IVF.
Got it, thank you. Dr. Gupta, can you just throw light on how hospitals are using digital tools, workflow improvements to bring down the cost while improving customer experience?
Yeah, so, now as in the previous talk, we were saying lots of notes, and so there is an electronic patient records. I think that helps. That saves the time of the clinician and also the patients to carry all the notes, because it's there on the system. Also, IVF is a teamwork. So, there is, if something embryology has put, I don't have to wait. I can see in the system, or I have an update and I can tell. So I think over a period of time, digitalization is definitely there, which has improved, I think, everyone's life. AI has been there, which whether it's an embryo selection, and I think with time there will be more areas where AI will be used in IVF, whether it's a dose, accuracy, or the result prediction, which we are depending on the counseling, but slowly I think it will get into more structured, and more reliable it may become. But of course, there are some issues which are not solved yet with AI, because suppose some mistake happens, who's to be blamed? AI. Nowadays, even the patients come and they say, this is what I got a reply in AI, which add-on I should use. I said, let me check what is written. So, but then who takes the responsibility, ownership? So, and ethical problems and the data privacy. So there are problems, but it is helpful. I think, especially for the new center, if the embryologist is not that trained, or then the AI can help us in a better selection, because that can be used. So it's a good thing to support to get a better result.
Yeah, Yes, ma'am. AI can definitely reduce the cost in routine transactions, but you rightly said that when it comes to decision making, who makes AI responsible, that's a point we still need to ponder. And finally, to Dr. Jagannath, ma'am, beyond cost, what patients do you find most inaccessible in IVF? Counseling, transparency, emotional support?
I think, in my center, and I think most of the centers are evolving in, having psychological counseling support professionals in their center. Financial counselor is separate from a psychological counselor, and we do extensive work, and every patient, irrespective of whether they are going for an IVF cycle or an IUI cycle, or they're just coming for a basic fertility treatment, we actually triage them and see what family background they are coming up with, or whether there is a couple relationship issue, or whether it is the work issue. Everything is analyzed in their first 2 or 3 visits, and then they are categorized. And then appropriately they are given counseling, and then once they scale up to an IVF treatment, that embryo transfer wait period time is extremely stressful for the patients, and so they have we have some structured patterns like some behavioral therapies and other exercises based on their mental health conditions, and then we teach them how to cope up with this wait period. So this is extremely important, why I'm stressing more on psychological counseling, because at the end of the day, it is not the success or the failure. When the patient comes to you with a failure, when they tell you, doctor, you have done the best, we are able to accept the failure better, that is very important, rather than one failure and then they are not able to get up and come back for a second embryo which is frozen there to do a retransfer. So I think this is very important, and also we form some support groups for the patients to be heard in a non-judgmental way. Maybe some support groups can be formed and then help them evolve through this fertility journey. I think these are the main areas that we need to work more on. That's what I feel.
As we, in the interest of time, I have been told to wrap up now. So as we conclude this very insightful discussion, one thing is very clear. IVF is not just the science. It's about creating a world where hope is accessible to all. By combining innovation, affordability, accountability, we build a system where no couple has to give up on the dream of parenthood due to financial or any other reason. I want to thank distinguished panelists for sharing their expertise and inspiring us to think bigger, act bolder, and collaborate better. I hope together we can redefine the future of fertility in India. Thank you very much.
Thank you.
May I please invite Advocate Sudhir Mishra, Founder and Managing Partner, Trust Legal, to felicitate our guests. Can we have the applause going for all our guests, please?
This also. Sure.
Oh yes, Dr. Vasundhara. Yes.
Sorry, the name had an issue.
No, I already received one
Yeah.
from the second one. So
Because
Thank you so much, everyone. Advocate Mishra, I would request you to stay back with us for a little longer and just share a few words with our audience.
I'll take maximum. Good afternoon. Already a lawyer has spoken, so I'm just putting some rejoinders, if I call it. My own journey in the space of IVF lawyering would be, I would say for last 11 years, I had the opportunity of doing one of the first consumer cases on IVF, which was way back in 2011. And I'll come straight to the point. That time there was no ART Act, there was no surrogacy related laws, there was no control of ICMR. We just had a radiology related few legislations. There are doctors in the room, I have worked with them. Dr. Shweta, I have worked for many years in many roles. And I can tell you, you should be very happy that despite few losses, which the sector has, like the surrogacy, which was happening in a manner where opportunity used to come from across the globe. Now it is much regulated to very limited manner. But at the same time, there is a exponential growth which has happened in the IVF sector as such. And if you see that and couple it with the kind of legal regime which is being created around it, you are in much safer atmosphere now. Supreme Courts, normally any litigation or any big legal issue reaches at a very late stage. In my own understanding, in last 25 years, many of the matters which I started in 98, 99 when I started practicing, they never reached Supreme Court actually. But here, in last 3 years, at least 4 to 5 critical IVF related matters have gone right up to Supreme Court. And what are those matters? And why I'm talking about them is that every issue, whether it's the age of the donor, age of the parents, age of the mother, age of the father, all these issues have started going right up to Supreme Court. ICMR is not supposed to be the only agency which will regulate like Competition Commission or any other regulator. ICMR is more advisory in nature, and they still crib that the overall growth of the IVF sector is not depicted in their registry, because hardly 20-22% clinics are mandatorily registered with ICMR. But I can tell you, there are two wings of my limited address. One is that if you see the respect which the Indian IVF sector has got in last 5 years, how will you see that when the health law related panels happen in the lawyers body? We have bodies like International Bar Association, Indo-Pacific Bar Association, and health is a very important subject. You know what they discuss? They don't discuss pharma. They don't discuss public health. They discuss knee transplant and IVF mostly, because these are the costs which is discussed in these forums. So how much is the cost in your country? What are the legal regime? How much time it takes? How many failed cycle? And there are countries which have caps on the failed cycle in our country, still we are in the evolution phase. But what I can tell you that every minor offenses are now going to go up and up into courts, because consumer courts are sitting mostly in an online manner. Unless some judge, my lawyer friend will agree, unless some judge insists, a lot of people are now willing to listen it to online. The Supreme Court expects most of these tribunals to listen to matters online. It has become easy to sit in Noida and file a case in Lucknow in a consumer forum, which was a task 10 years back. I remember representing hospitals before Lucknow Consumer Forum. It was a task for a hospital. But it was not difficult for the complainant. He used to go, he had more time. Now he will be there. Now it is up to you, you want to defend online or you want to go to the court. So access to justice, access to legal recourse has become a little easier. Just be alive to that. The second thing is, a lot of protocols with working with great doctors. Dr. Shweta is here. I had the privilege of working with her in many, many places. We have devised a lot of systems on data, privacy, how patients should be interacted with, how you write a prescription, how you'll protect your overall IPR, how will you do your contracts. Now the contracts are also under a new regime after the passing of a Supreme Court judgment that you can actually stop your consultants and employees. They just can't go from one company to another company because of the fundamental rights which we have been guaranteed in our constitution. Now the Supreme Court judgment says that if you can show that you have trained or you have spent money in the training of a doctor or a consultant, then you have ways and means to recover that amount before that person decides to migrate to some other company. So all this landscape is changing very fast. And this is sometimes swinging in favor of a patient, sometimes it is swinging in favor of the doctor. My two important reminders to you is ICMR 20% factor, please remember, but the other factor you must remember, that what is your best example of advocacy and policy in health sector in India? With due respect, pharma. You see, anybody who wants to do advocacy and policy in India, and I'm talking about law firms, I'm talking about the consulting companies, where do they look at? Cricket and pharma. You know why? Because cricket, across political parties, there is no discrimination, no discord. You will find one Rajya Sabha MP from Congress as the BCCI Vice President, IPL Commissioner, same person in Rajya Sabha criticizing the other side. So that kind of coordination is there in pharma also. Whether it's a domestic pharma or international pharma, their voice before the parliament through member of parliaments is very, very vocal, very organized. It's in fact a case study for other industries, for steel, for hospitality. Gaming has not been able to do it. Hospitals have not been able to do it. IVF has certainly not been able to do it. So when the Surrogacy Act came, when a lot of restrictions came on you, we were part of the debates. My partner, Patel Chandok, was going to the parliament. She was contributing to the surrogacy bill and all the deliberations. We were helping them. We had represented by then 7 to 8 IVF chains. And we were knowing what all is coming our way. It was a clean sweep for the government. There was no unity amongst doctors or any IVF. With due respect, you criticize me, like me, don't like me. My request to you, now you're getting bigger and bigger. Every nook and corner, when I start from my house in Noida in Sector 40, I go to Supreme Court, not even a single IVF clinic was there. Now there are at least 7, Dr. Shweta. Kailash also has got into IVF, I just saw. So what I'm saying, now is the time for you, and this is my last piece of advice, that please start creating a robust regulator, ombudsman for you. Kamill is here who understands this sector. We are happy to provide you all the knowledge in this regard. Don't be dependent upon any industrial body, any business body, any other representative body. Become your own regulator, become your own ombudsman. That will serve you great purpose in future when more legislation will happen. Look at what is happening to gaming now. First, gaming was not legalized. And then everybody went and cried and cried. Finally, it was legalized by the Supreme Court. The government say, okay, fine, we'll give 55,000 jobs and a lot of revenue will come. Suddenly, for last 6 months, the taxation issue and the GST and other aspects. So even if they are very united, it's getting very difficult. So my suggestion is become big, create more clinics, but as I always said, that create your policy and robustness in such a manner, create your ombudsman in such a manner that the government should learn from you. The government should say, yes, this sector, we will learn from them. They are creating a policy document. Thank you.
Thank you, sir. May I now request Dr. Amit Patki to please felicitate our speaker. Thank you, ladies and gentlemen. We now move into a conversation that could redefine the economics of fertility care in India and bring real structural change to the way IVF is accessed. Today, the financial burden of fertility treatments remains one of the biggest barriers for patients. With IVF cycles often costing upwards of ₹1 lakh per attempt, affordability is not just a concern, it's a crisis. But what if IVF was covered just like any other aspect of health? That's the future our next speaker is helping build. Delivering a keynote on introduction to IVF insurance products and how we can reshape reproductive care through financial protection, please join me in welcoming Mr. Vikas Anand once again on stage. Can we have a huge round of applause for him? Thank you, sir. Over to you.
Good afternoon again. And once again, I want to congratulate everyone on the International IVF Day. I don't have words to express the quantum of joy you all bring to millions and millions of couples. Today, as I mentioned, we will be talking about the affordability. At Safety, our focus has always been building innovative solutions that empower clinics and also reduce the financial stress on the aspiring patients. So before I get into the product specs, I just want to do a pulse check from the room. And here is the question. How many of you believe that IVF insurance can significantly increase IVF penetration and adoption in India? So if you believe yes, please raise your hands. Awesome, awesome. Most of us do believe, and personally, I am a big believer that with the introduction of insurance products, I do believe the IVF sector should increase. There's another question I want to ask. Currently, India has between 3 and 3.5 lakh cycles, what we gather from the public domain. There isn't any proven statistics, so this is the best what we could get. So I want to understand from the practitioners and clinicians, how much growth in IVF cycles can we unlock in India in next 3 to 5 years if IVF insurance is introduced? So we have 3 options. A, up to 50%, B, around 100%. So we believe that in next 3 to 5 years, the sector can grow double than existing numbers, and C is more than 100%. So could I have the volunteers with the mic, please? A? C? C. Oh. Personally, I believe I'm more inclined to a C, not because of my business, but generally I'll tell you. Internationally, there hasn't been many insurance products across the world. So we do have a limited data sets available to quantify what could be the possible number. However, we do have 2 geographies which gives us an indication what possible scenario it could be. So I'll talk about that. First talk about US, where there has been states which have mandated IVF insurance for a long period of time. So the states which have mandated, we find the number of IVF cycles and also the number of clinics are 3 times more than the states which haven't mandated. So this is the best possible answer I could get. Also, in recent times, we have seen Japan had, with their falling fertility rates, with public support, had come up with an insurance plan. What we found was the number of IVF cycle increased by nearly 30% in a year of adoption. Within the year of introduction of the insurance product, there was 30% increase. So my answer still remains at Part C. I am extremely hopeful that with the introduction of insurance, we know there is a strong possibility the number of IVF cycles should grow more than 100%. Now coming back to the Indian IVF sector, these are all data taken from public domain. So India has nearly 3 to 5 crore couples which have fertility challenges. The number of IVF cycles, the best estimate I could have ever got is around 350,000. So 350,000, which translates to less than 1% of couple facing a fertility challenge undertake IVF treatment. So there could be multiple reasons why it's less than 1%, but now I want to talk about how can I make the figure on the left hand side move more and more towards the right hand side. How can we ensure that the number of IVF cycles go up? We do provide joys to multiple inspiring couples. There are multiple reasons. Definitely lack of insurance is which is cited at every IVF conference. There is awareness problem. There is a social stigma attached to it, but I do believe it's going down with the acceptability of IVF. But definitely moving this number, left hand side number, to a higher number on the right hand side needs multiple efforts. And this is where what we are doing at SafeTree is building an ecosystem. We are trying to build an ecosystem where we involve couples, where we involve corporates, and where we involve people like you, all coming together and helping Indians approach IVF specialists for a treatment. So this is, we are building a growth ecosystem where couples would be provided with affordable, comprehensive IVF solutions. We are talking to corporates where they are able to diversify employee and their customer offerings, and definitely IVF clinics would be an important part of this ecosystem for this opportunity and faster growth. Before I talk about the products which we are trying to launch, I just want to spend 2 minutes. What is an insurance? Insurance is a product where multiple people buy, that in case they have a challenge, this comes as a financial support. So very, very important. If I were to give an analogy, if I'm wearing a helmet while driving a two-wheeler, it's an insurance that tomorrow if I happen to meet with an accident, my head is safe. Likewise, insurance is a product which is bought by multiple people to support people who may need it. It is not a substitute to a walk-in customer who needs an IVF and we give an insurance. So the precursors of the insurance get lost. So what we are trying to do is, we do understand, and this was discussed in the last panel discussion also, that when someone comes at the clinic, the ability to wait is minimal. And in India, unfortunately, the average age of a couple reaching and discussing the treatment is plus 35. So definitely he has very limited time when he can wait. So we have considered that waiting period consideration has to be minimal, and that's why we have come up with few products for different lifestyle of our customers. So first product what we have launched, I'll be talking very high level kind of a thing. We have our teams who can explain you in a much better detail. So first is for my walk-in customers. At Safetree, we have always endeavored that we want to make the process of parenthood very, very affordable. That's why we have launched a maternity product. So this product would cover the cost of delivery of the baby, and the beauty of this product has a waiting period of 7 months. I can tell you there isn't any product available in the market on the retail segment which has a waiting period less than 1 year. That's the best case, but the average waiting period for any maternity benefit is 3 years. So we have made a genuine efforts to ensure the couple who's planning for a IVF, while we can't offer a fertility product, but we can offer a maternity product at 1/3 of the cost, which is very, very competitive with minimal waiting period. The second is our day-to-day customers. Their age is against, they need a product with a minimal waiting period, and that's the best we could have come up with. So this is a product which offers one IVF cycle with a 1-year waiting period, meant for fast-track coverage for urgent IVF planning. And again, from an affordability perspective, it helps my client save up to 50% of the IVF cost. Also, it does have a health insurance. So what it means is that in case during a waiting period of a year, he incurs some problem, some disease which requires hospitalization, that is also covered within this plan. Then for a medium horizon customers, this is a product which offers 2 IUI and 2 IVF. There is a waiting period of 2 years. It does also help customer save nearly 50% of the IVF treatment cost. And finally is the product which I say the gold standard of our product. Of all the offerings, this is where I want the customer should be buying. So this has a 3-year waiting period, but this is meant for young couples. It offers 2 IUI, 2 IVF, it offers health insurance, it offers maternity, and the beauty of this product is it costs only 500 rupees per month, and this is inclusive of GST. So it translates to an annual expenditure of 6,000 rupees. They have to wait for 3 years, but what is the beauty is that after 3 years, in case they need a fertility problem, there won't be any financial stress. They have a program which comprehensively covers 2 IUI, 2 IVF, maternity, and it also offers hospitalization benefits. So this would be the one which I believe we want to ensure maximum couple buy. And with these kind of products, with the pricing we have done, I'm extremely hopeful that number of couples which have just got married would be inclined. And our endeavor in all the products has been, our motto is to make it affordable, 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 so that financial distress should not impact them. About us, we are a market leader in this space, and I'm sure most of you would know us. So we have insured over 100,000 oocyte donors. We have over 1,000 plus surrogate mothers. We work with most of the leading chains and in over 650 IVF clinics buy our products. We recently got award for the most innovative insurance product at a ET Health Summit. And we do offer all kind of products, while our expertise lies for the fertility sector, but when it comes to doctors, professional indemnity, donors, intending couple, all kind of products is offered by us. And that's what we want to say. Let's all come together. Very, very important moment of truth is we all have to come together. We need to ensure if the sector has to go, we have to clear the affordability question, and I do personally believe this kind of a product will help bring joys to millions of the couples who are looking for parenthood. Happy to take any question. This should be, we were thinking that it should be a part of a shadi.com.
With a box of folic acid. That's what I called it, engagement pill.
Exactly. Okay, thank you very much.
Thank you, sir, for that interesting keynote. Moving on, ladies and gentlemen, it's not just about what we do in the lab, it's about how we protect the world outside of it too. From climate responsibility, we now turn to another powerful topic that impacts millions of young women across India, PCOS and preventive fertility care. As we know, PCOS is one of the leading causes of infertility, but what's often missed is the window of prevention, awareness, and early intervention. It's time to move away from reactive care and toward empowerment, where young women understand their bodies, seek timely guidance, and feel in control of their fertility journeys. We are honored to have with us Dr. Purnima Durga, Chief Fertility Consultant at Mom IVF and Joint Secretary of OGSH. Dr. Purnima is widely respected for her clinical expertise and her deep commitment to adolescent reproductive health. Her approach bridges fertility care with education, outreach, and long-term well-being for women, especially in Tier 2 and semi-urban communities. Please join me in welcoming Dr. Purnima as she speaks on PCOS and preventive fertility care, empowering young women through awareness and early intervention. Can we have a huge round of applause for her, please? Over to you, ma'am.
Good evening, respected seniors and my dear colleagues. It's a true honor to be here today at the 6th IVF Summit Awards among the pioneers in my field, where we idealized all Patki sir, Talwar sir, Narendra Malhotra sir, a lot of seniors which we have idealized and grown up. So standing in front of them and talking about my work, what I've done is a dream come true. Thank you IVF Summit Awards for giving me this opportunity, who have really redefined the landscape of fertility care in our country. So basically we at Mom IVF, we always thought that we have to go beyond the clinic out to do to educate people. This we are doing since long time, from our inception from 2019. So as a doctors, our foremost responsibility is not just to treat the disease, so but to prevent it. So preventive medicine plays a very, very important role. So we took PCO as a condition because that's the most common condition in India. 1 in 5 women in India are suffering with PCO, but when you look at the statistics of PCO, the prevalence is as low as 3.5 to almost like 25%. There is a wide difference in the range of incidence of PCO. That might be due to delay in the diagnosis, delay in the lifestyle interventions, delay in approach to the treatment. So in adolescent age group, it is as high as 16 to 17% of the people in Delhi, one survey from the Hindu, you can see that 17.4% prevalence in college-going women in the age group of 18 to 25 years. So in the morning we have spoke about sustainability and all this. We have spoke about lot of conditions, ovarian regeneration, all these therapies, fertility preservation. But I feel that it is time to talk all of us about the preventive medicine. In fact, before coming to the clinic, if you can educate, make conscious conversations with the young adolescent girls, school girls, college girls, probably we can improve the quality of life of the women in the future. We all know that PCOS is the most common condition of the reproductive age group, which is because of the hormonal imbalance and reproductive dysfunction. So by simple initiating conversations about the condition, how to prevent it, the lifestyle interventions, we can reduce the burden of this condition. And we all know that why we are talking about PCO, there is a lot of society which is working on PCO. Why? Because there is a very high incidence of long-term disorders like diabetes, hypertension, endometrial carcinomas, and infertility in the future. So if we can raise conversations at the early age, probably we can reduce the incidence of this disease and improve the quality of life of the young girls and women of our country. So I'm not going into symptoms and management. We all know about the symptoms of PCO and all, but the thing is, a lot of societies, ASHRAE, ASRM, Indian societies, all said that the first line of management in PCOS is lifestyle intervention. So that's the main thing. So as at Mom IVF, we focus on this mission, and we have went to so many in our last 2 to 3 years. We went to so many schools, colleges. We went to wide spectrum of places, like from the school age to IT sector. We have covered all the sectors. We went to schools, colleges, and IT places and educate them about what is this PCO. A lot of people don't know. A lot of people we took a survey, we took a questionnaire with us, took the survey. A lot of people don't know about this condition. Even though they have irregular periods, they are not bothered about it. The sleep patterns were disturbed in them. They are social, they are addicted to their cell phone. There is no proper sleep quality. They don't know that proper sleep, how important is sleep in their metabolism, hormonal metabolism. When we took the questionnaires, and this we took about 1,000 questionnaires about from different age groups, from this adolescent age group to the reproductive age group. So it was very surprising to see a lot of people don't know when to approach, what to do, and they also don't know how to do lifestyle changes. We as a doctors, even though when the patients come to our clinic, do lifestyle modifications, reduce weight, sleep properly, don't use phone, avoid gadgets, but are we really sitting with them and counseling them and we don't do a long-term follow-up. We just advise them and go off. But we have monitored these patients, screened them. 3 months we have given long-term plans for them, how to manage their weight, how to manage their stress, especially in the IT sector where the wife and husband have different times, their sleep patterns are different, how to manage the work-life balance. We spoke with them, and from social responsibility, we have almost spoke with around 200 to 300 women. Long-term follow-up we have done in these women. So this is about especially you can see the college there. It is a Koti Women's College, the government college. It's so surprised to see how anemic they are. They don't have proper food. In schools also, in government schools, there is a midday meal program. But in summer vacation, there is for the kids, they can't eat food also because they are not going to school and they don't have that midday meal program. There's a lot of things which as a doctors can go out and do. It's our responsibility not only to treat the patient but also to go out and educate and prevent these things which can be managed by simple lifestyle interventions. And we also went to slums where this is our in-house where we have done so many webinars on PCO and all, and these are colleges. And also one more important thing you can see here, it is a slum area in Hyderabad where there is a very early sexual exposure. the girls, once they attain menarche, they're exposed to the, they're sexually very much active, exposed, and there are so many unwanted pregnancies, illegal abortions, which led to lot of young women dead. So we went there, educated. Sexual and menstrual hygiene is something which we are also working along with PCOS. So these are that is the IT sector which we have worked. So apart from this, on our 6th anniversary, we also promote, one motto of our IVF center is, we tell all the children or the school going kids, go out and play outdoor. Outdoor sports are not now gone. So it's very important for the children to play outside games. On our 6th anniversary, we have done cycling, we have given cycles to children and sport kits to the children. We have conducted badminton programs among our staff. So it's very important for us to educate about lifestyle and how to how physical activity, proper diet, exercise plays a very, very important role. And as sir has the Pankaj sir talk has motivated me a lot. He spoke about the journey of the gynecologist, how a female gynecologist is multitasking. To be frank, I'm also one of the member of his green IVF project, where I got so much motivated by his vision and all, where I am also doing my part in my lab to reduce the carbon emissions. But the thing is, today he spoke about it. We took that mission. Lot of young doctors are losing their lives. We in our Telangana society, our colleagues have, lot of people have lost weight, sudden cardiac arrest, stress in the doctors. We don't deal about that. We don't talk about it. I think some conferences should deal with this topic about stress and doctors' life. That's a very important thing. We always think about patients, treatment. We don't think about ourselves. So this year we took that to educate doctors about their health. Actually, they talk about everybody's health. They talk about everybody. They give medication to everybody. What about their mental health, their physical health? So this year our project is health is wealth. So that applies for the doctors as well. So we have to reduce our stress as well and maintain our work-life balance, so that if the doctor is healthy, he can treat millions of patients and make their life happy. So thank you so much. So for us, the long-term wellness plans, so create sustainable habits rather than quick fixes, focus on preventive healthcare measures, seek professional support when needed. Thank you so very much for giving me this opportunity and project our work. Thank you so very much.
Thank you, ma'am, for that informative and very timely keynote. May I please invite Ms. Nikki Gupta, co-founder and CEO of Teamwork Communication Group, to please felicitate our speaker. Thank you so much, ma'am. We now segue into a keynote address by someone whose voice commands both credibility and caution in the rapidly evolving world of assisted reproduction. In an age where AI in embryology, ovarian rejuvenation techniques, and designer gametes dominate headlines, it's easy to get swept up in the hype. But what's real, what's replicable, and what's relevant to the Indian context? In this keynote, we reflect on the promise and pitfalls of chasing innovation for its own sake, and why rigor, regulation, and relevance must guide the future of ART. Please welcome Dr. Amit Patki, President of ISAR, the Indian Society for Assisted Reproduction, and one of the most respected clinician researchers in the field. With a decade-spanning career dedicated to clinical excellence, scientific integrity, and medical education, Dr. Amit Patki has been a bridge between global evidence and Indian practice. Under his leadership, ISAR has taken major strides in strengthening clinical standards, peer learning, and regulatory alignment. Today, he will share his candid, nuanced take on what's trend, what's truth, and what we must truly chase in assisted reproduction. It's my honor to invite Dr. Patki for his keynote, Chasing Unicorns, the Allure and Reality of Newer Trends in Assisted Reproduction. Over to you, sir.
A very good afternoon. Can I have my slides? Yeah. At the onset, I would like to thank IHW Council, Kamill Narayan, and a very hardworking Nayanika, and congratulations for such a fantastic program. I think a round of applause to them. ISAR, with its over 6,000 members, we are delighted to be associated with this program. And I feel very sad that I couldn't be there last year because we were at the Eshure, but ISAR was there in spirit if I was not there. But today I'm delighted to see so many stakeholders come in, and I think it's very, very important that we work together. Today I say happy birthday to Louise. That is what we celebrate, the World IVF Day. And it is not only a birthday for Louise Brown, it is win of science over myth and stigma. And my talk relates to chasing unicorns. Had not Professor Steptoe and Edward chased this unicorn and relentlessly tried 40 times before they got this pregnancy, I don't think we all would be here treating millions of our patients. Can I have the film, please?
We all chase unicorns' big dreams, rare opportunities, that 1 in a million shot. But the hardest part, taking the leap of faith. You may not see the safety net, but sometimes the only way to know is to jump. Chase the unicorn. Take the leap. You just might fly.
So, ladies and gentlemen, today I'll be speaking on a topic which is chasing unicorns, the allure and reality of newer trends in infertility practice. Now, what is unicorn? It is a mythical creature, someone amazing, someone hard to catch or find. And I've used this as a metaphor for balancing what should be a dream and what should be a reality in our ART practice. If you look at this graph, it's very evident that there has been a lot of interest in ART practice over the last 15 years. If you look at the number of publications which have surged more than 100 times, we know that there is cutting-edge technology like artificial intelligence, genetic screening, and sperm selection technologies which are sustaining these publications. But I would like to concentrate on 5-6 major trends that are there in our practice and how we need to balance the dream and the reality in each of them. So let's start with luteal phase, the changing perspective in the last 1 decade. Now, I have been one of the first people to start working with some of my senior colleagues on luteal phase defects and insufficiencies. But let's look at this paper of 2012, the Practice Committee of ASRM, which suggested that luteal phase deficiency is known in healthy, normal menstruating women, and it is important for implantation and early embryonic development. And luteal phase deficiency as an independent entity causing infertility had not been proven. However, they suggested that we should be supplementing luteal phase supplements in cases where we suspect luteal phase deficiency. So from 2012, there have been a large number of pharmaceutical companies who have pushed progesterone down as luteal phase supports and for luteal phase deficiencies. 3 years down the line, the same ASRM comes up with another practice committee paper, which is 180 degrees away, which talks of irrelevance of luteal phase deficiency and says that although it is described in healthy menstruating women and associated with other medical conditions, and although progesterone is important for implantation and early embryonic development, luteal phase deficiency to cause infertility has not been yet proven. But what had happened by then, we were all tutored to give luteal phase support, and I think we all know that we gave it in multiple forms, in multiple doses, and in multiple ways. Until maturity set in, because there's always a yin and a yang. Luteal phase supplementation is necessary. But till date, idiopathic luteal phase has not been proven to cause infertility. The second major thing is this nice paper that came up in 2013, which stated that IUI is not recommended for couples with unexplained infertility, male factor infertility, mild endometriosis, but you could do it for couples where religious, cultural, financial, or social objections to IVF. Now, when you look at these three groups, it almost makes up 50% of all your infertility patients. So what happened? A large group of patients were pushed into IVF. Now, where did they get this nice guidelines? It was based on this pragmatic, randomized, controlled trial by Siladitya, which compared expectant management, clomiphene citrate, and unstimulated IUI in the management of unexplained infertility. Also, a large number of couples who had IVF certainly got pregnant, and they were extremely happy and grateful to the doctors. But not knowing that they didn't need it in the first place, perhaps they would have conceived with a gonadotrophin IUI, which was never considered in these nice guidelines. But by then the damage had already set in, and a large number of unnecessary IVFs had already happened. It was only when Ying Cheong from Southampton came up with this beautiful paper saying, does intrauterine insemination have a place in modern ART practice? And where she vehemently proposed that IUI still has a place in modern ART, and maybe it is the gonadotrophin IUI which can help us in patients of unexplained infertility, mild endometriosis, and male factor. So my question to you, ladies and gentlemen, is, are new trends transformative? Is it always true that when something new protocol, new drug, new device comes up, does it really is earth-shattering? Does it really transform your practice? Or more often than not, these are transient distractions. You start doing it, and after a few years, you realize that it wasn't as good as you thought, and maybe you want to come back into what you did initially. Let's take up PGTA. This is an emerging technology, certainly very good, designed to exclude aneuploid embryos. But does that mean that you do it for every single patient? Does it mean that if you do PGTA on every IVF cycle, you will offer a better result to the patient? Certainly not, because now studies are showing that in young women and in women with good prognosis, PGTA certainly doesn't give you a good cumulative pregnancy rates, may reduce time to pregnancy, but it is better to avoid invasive technology because we really do not know how biopsying, freezing of embryos would cause genetic issues maybe 20, 30, 40 years down the line. So when you look at this graph, you can see that in women with good prognosis for live birth, a conventional IVF resulted in a cumulative live birth rate that was not inferior to PGTA. So in young patients with good number of good quality embryos, PGTA is certainly not going to improve your cumulative pregnancy rates. It does help in patients who are elderly or have had maybe genetic abnormalities or recurrent miscarriages. What about embryo freezing? And what about freeze-all technologies? When we started IVF practice, it was always slow freezing, took hours to freeze one embryo, and we were dissuaded from doing it. But with the advent of vitrification in the last 20 years, it's such an easy process, much, much cheaper. The time is also a fraction of what it took. So we are tempted to freeze. But does freeze-all strategies help everybody? Understand that this strategy was devised to bypass hyperstimulation or the ill effects of overstimulation of the ovary. And hence, it was effective in those patients who were at risk of OHSS, where you would prevent a grossly morbid condition of the patient. But when you do it for all, you actually dilute the importance of this technique and maybe bring it bad repute. So initially it was heralded as beneficial, but understand that it was context dependent and it was only meant for cases where you suspected hyperstimulation or the woman had some medical abnormalities or endometrial issues which prevented you from doing a fresh transfer. So when you look at fresh versus frozen in polycystic patients, you definitely find that the frozen embryo transfer was associated with a higher rate of live birth or lower risk of ovarian hyperstimulation, but also a higher risk of preeclampsia after the first transfer than a fresh embryo transfer. And when you look at fresh and frozen in normal ovulatory women, you find that the live birth rate did not differ significantly amongst ovulatory women with infertility. But of course, the frozen embryo cycle ensured that you didn't have an hyperstimulation even in the low risk category patients. So it was meant for hyperstimulation, but we as fertility specialists expanded its indication and started doing freeze-all for all of them. So when you talk of sustainability and when you talk of green IVF, I think it is wrong to freeze all embryos, subject them to freezing, and then thaw these embryos and use them later, unless if you fear for morbidity in the patient. What about scratching the endometrium? I think it was meant for recurrent implantation failure, but then was used in most cases, and in some countries in Europe, it was mandatory to do the uterine scratch before they did the IVF in the preceding cycle. Until it took a person like Ben Moll to come up with this beautiful review to say it is time to stop scratching the uterus because you would be doing more harm than good in certain cases. What about the role of laser hatching? We had that machine to do embryo biopsies, And then we started doing laser hatching for all, for the elderly, for the PCOS, for the frozen embryo, for endometriosis. For every patient, we found an excuse to go. But now we know that it should not be recommended routinely for all patients. And there is insufficient data till date to suggest, even in those selected patients, that laser hatching actually works or does better for these patients. What about embryo glue? I think most of my embryologist colleague will tell me that it came up as a BIP, but it died down very fast, and nowadays most people would not want to use this embryo glue. I think we are much more educated than to understand that there is nothing like a glue that will help this embryo stick inside the uterus and help us get better pregnancy rates. Innovations are necessary because only then can you improve your success rates, but it is important that you use them in the context that they were supposed to be used and not expand its need and its use in every patient, because then sometimes you actually spoil a good product, a good drug, or a good device because you have indiscriminately used it for every patient. I would like to spend a little time talking on endometriosis because we see a large number of patients. I don't know whether we are seeing a large number of patients or our minds have now awakened to the fact that these patients have endometriosis. Nevertheless, it is a multifactorial challenge, needs tailored approach, and I think this is one place where I think you have to do a patient by patient and you do it for a personalized treatment, because it's not only endometrioma or endometriosis or pain. You have to address the inflammation, the adhesions, and more importantly, if she's interested in having a family, the ovarian reserve that is there in this patient. This chart is a very busy chart. I don't think you should read it. But what is important is that what comes before, the ART or the surgery? And I think this is patient context driven. I think it is important that you sit with the patient and discuss, because in my mind, surgery takes precedence in ART only and only if there is symptoms of pain in this patient. I think in rest of the patients, ART should take precedence. And as we all know, the first surgery is the best surgery and should be done in the best of hands. Reproductive pathologies, uterine abnormalities, the septum resection definitely impacts recurrent miscarriages, and that is what we do for all our patients of recurrent miscarriages if they have a septum. But if we extend this use to infertility, I don't think there is sufficient evidence to conclude whether a septate uterus is associated with infertility, and hence I think it's important to not do it, because sometimes overzealous repair of the septum can actually cause more adhesions, more harm in this patient than that so-called septum which was there. Also, there are various degrees of septum in the uterus, and I think it is important for the doctor to know which septum actually needs to be ignored and which septum actually needs correction, even in cases of recurrent miscarriages. But ladies and gentlemen, I think we missed the bus on fibroids. 10 years ago, this was a beautiful paper which said that the fibroids, even if they are not indenting the uterus, even if they are not more than 5 centimeters, can reduce fertility by reducing the tubal patency, by decreasing the sexual coitus, by the inflammation, by making the endometrium blood flow alterations and reducing implantations. But we did not listen, and we stuck to our guns, saying that only if the fibroids indent the uterus or is more than 5 centimeters, we should be treating them. But now there are excellent papers to suggest about infertility and association with uterine fibroids, and what are the possible mechanisms, and there are multiple mechanisms by how these fibroids affect implantation. And we know that fibroids, even if they do not indent, and even if they are not more than 5 centimeters, reduce IVF success by as much as 25 to 30%. We all know what are the predictors for ovarian response, and we all individualize treatment for ovarian stimulation, taking into consideration age, BMI, other pathologies, and how the patient responds. So I think it is important to use AI in such cases. You get models, you get a predictive analysis, because only that will help you to reach the promised land of individualized ovarian stimulation, where you get the right response, you don't get poor response, and neither over response, and you can then use this to minimize the amount of drugs and also the cost to the patient. So in unexplained infertility, I think it is diagnosis, if it is by exclusion, leads to potential over-treatment. I think we should fall on these prognostic models and also look at expectant management in these patients, because there's a beautiful paper by Hull way back 20 years back, which said that even if you do nothing in these patients of unexplained infertility, almost 20% of them will get pregnant within 3 years spontaneously. So when you use these models, you reduce unnecessary interventions, particularly in patients of unexplained infertility. My second question to you is, we always talk about live births. We talk about cumulative live births. But is that the only metric or the benchmark that we should now be using once IVF is more than 47 years? I think we should push ourselves, push the benchmark, and say how it impacts maternal and neonatal health holistically. And only then we will be able to evaluate our freeze techniques. Only then we'll be able to evaluate unnecessary embryo biopsies and the various drugs that we give mothers in the hope that we get a pregnancy, because we now are looking at only getting a pregnancy and a live birth. I think we will be answerable to a large number of questions over the next 3 to 4 decades if we don't push our benchmark to health, maternal and neonatal holistically. Can I have the film, please? Can I have the film? So ladies and gentlemen, am I telling you that you should not chase your dreams? That you should not chase the unicorn? Of course not. I think if you had not chased the dream, Louis Brown would not be here, and none of us would be here 47 years later. So it is important to chase the unicorn. I don't suggest that there should be a death of the unicorn, because if we kill that dream in all of us, if we kill that creativity in all of us, I think we would be not doing any justice to ourselves and to our patients. So what are we looking at? We are looking at how we can move the benchmark ahead. So when we look at AI, often I get my colleagues telling me that with the advent of AI, it's going to kill us. It's going to kill our embryologists. I don't think so. I think we are, as humans, are very intelligent, and I think we should be making AI our slaves. Use AI to improve our practices, both in clinical and in the lab. And I think it is important that if you use AI, we'll be able to improve outcomes, reduce cost, and positively impact clinical care. The next thing I tell all the research people is to think of infertility where you overcome a complete lack of gametes without donation. So now we offer sperm donation, egg donation, but you still have to do IVF. Let's think of a world where IVF is not needed. How about trying to rejuvenate those ovaries? How about trying to restore fertility in these women, where embryonic stem cell, I think, will be able to help us. Because current techniques do not cure infertility. None of us cure. We bypass the infertility and we offer various options to the patient. So think of something where we'll be able to restore fertility back in this man and in this woman. Think of gonadal transplantation. Think of cryopreservation of gonads, particularly in patients who are undergoing chemo and radiotherapy, and where this can be transplanted back, because that is true treatment and cure for infertility. I think there have been anecdotal cases where live births have been reported, and I think gene therapy is just round the corner, which will be valuable because we should know which genes to trigger so that the fertility is restored and the fertility is rejuvenated, because that is the true meaning of curing the patient and not only treating them. So develop a digital ecosystem where you can give personalized care, use AI, and they use the power to predict what dose, which embryo, and when to transfer, but the multiple images that you have to help us make decision-making, image tool analysis. I would like to end my talk by saying for last year's words belong to last year's language, and the next year's words await another voice. And ladies and gentlemen, to make an end is actually to make a new beginning. Thank you very much for a patient hearing.
Thank you, Mr. Patki, for your insights. May I please request Mr. Kamill Narayan to felicitate Mr. Patki. Dr. Patki, yes. Thank you, Doctor. Thank you, Mr. Kamill. We now move into a clinical, ethical, and social conversation that lies at the heart of modern fertility discourse: fertility preservation. As reproductive timelines shift and cancer survivorship rises, as career planning intersects with family building, fertility preservation has become more than just a medical offering. It's a question of reproductive rights, proactive care, and equitable access. This session, led by Isar, will address the current landscape of preservation in India, advances in oocyte and embryo freezing, oncofertility and adolescent preservation, legal, ethical, and emotional dimensions, and the growing need for awareness across specialties and geographies. Our panelists for this session are Dr. Minu Handa, Clinical Director, Fertility, Cloud9 Hospital, Gurgaon. Dr. Handa brings decades of hands-on expertise in female fertility and patient counseling. Her work focuses on customizing fertility preservation protocols, particularly for high-risk and time-sensitive cases. Our moderator is Dr. Sunita Arora, Head IVF and Senior Consultant, Fortis La Femme, Chairperson, ISAR, Delhi. Dr. Arora is a distinguished leader in fertility medicine with a deep commitment to academic dialogue and patient-first approaches. As chair of ISAR Delhi, she has championed preservation, awareness, and integrated fertility literacy into clinical practice. We also have Dr. Rimi Singla, Director, Radiance IVF and Radiant Super Speciality Hospital, the President of the Mohali Obs and Gynac Society, and the Secretary of the ISAR Chandigarh chapter. We have Dr. Shivani Sachdev Kaur, Director, SCI IVF Hospital. An internationally recognized fertility expert, Dr. Shivani has worked extensively on fertility preservation, particularly in oncology-linked and socially elective scenarios, combining global exposure with deep-rooted Indian clinical insight. We also have Dr. Pooja Mehta, Head of Department, Fortis Bloom IVF Center, Mohali, and Chairperson, ISAR Chandigarh. Dr. Mehta is among the leading IVF clinicians in North India and a strong voice for bringing fertility preservation into routine conversations, whether in cancer care, PCOS, endometriosis, or social contexts. With science, ethics, and empathy on the table, this is a conversation that's both timely and transformative. Please welcome the ISAR Fertility Preservation panel. Can we have a huge round of applause for them?
A very good evening to all. At the very outset, I would like to thank IHW Council for having us here, and thanks to Dr. Amit Patki sir, President ISAR, who gave us this opportunity at Crown Plaza today for celebration of World IVF Day. And I welcome Dr. Pooja, Dr. Meenu, and Dr. Rimi Singla on the panel. And we are going to talk about fertility preservation. So I got a call from Nanika, to be very frank, that it should be understandable to general population. So we have made it very, very simple and no hi-fi things. We are just going to tell you, how we go about fertility preservation, what's the right way. Yeah. So what is fertility preservation, first of all? So fertility preservation refers to techniques used to save or protect a person's ability to have children in future, particularly when facing treatments or conditions that may impair fertility. So if we broadly see these methods, when we say fertility preservation, what all does it involve? So it may involve freezing eggs, it may involve freezing sperms when it comes to male fertility preservation. It may involve freezing embryos, or it may involve freezing ovarian tissue or testicular tissue. So that's very, very understandable thing. So now let's come to common indications of egg freezing, first of all. So I would like to know this from Dr. Pooja. Can you take this up? What are the common indications of egg freezing in our country or worldwide?
To start with, I would say that egg freezing started for oncology patients, basically for cancer patients, where when patient diagnosed with CAs, where they were counseled for egg freezing so that their fertility is preserved, because later on they might be going for chemo or radiotherapy. Then over the time it started getting evolved, and they started that patients, ladies who've not found their Mr. Right, like social egg freezing started, where if they've not found their Mr. Right, then they started freezing their eggs. The best time to freeze eggs is before the age of 35 years, that is the ideal. Especially we do fertility preservation also for patients who have endometriosis. At times, if the girl is not yet getting married, in those patients also definitely we can do fertility preservation. And as fertility preservation is not only for females, it can be done for males also, where we get a lot of patients with oncology patients, or patients who have varicose and all those patients, or some patients who have to undergo vasectomies. They go for fertility preservation beforehand, and then, you know, they can think
And
ahead.
even Dr. Sunita, I mean, in today's scenario, many girls who have the recurrent cyst, and she's a well-educated girl, she's eager to know about the egg freezing, and she herself come to the OPD, no ma'am, I want to freeze my eggs. So scenario is being like, the indications, what would I say, the awareness is increasing, and many girls are aware of what is the importance of egg freezing later on in years.
I think I would just like to add that from the therapeutic point of view, we started with a big C as the cancer, as Dr. Pooja rightly mentioned. In Gurgaon, we have also seen that a lot of patients who have, you know, from the cancers, it went to a lot of other diseases, like especially autoimmune, where we are giving immunosuppressants, where their fertility could be at stake. And many times, genetic disorders is also one of the reasons where a person could be at risk of going for a premature ovarian insufficiency. Even those patients, apart from social causes, therapeutic and social are now a very, very important.
Yeah, very well said. So just to you know, complete the list, which my dear panelists have already enumerated, oncofertility. When we say oncofertility, this means fertility preservation in cancer patients. So why so? Because they may need radiotherapy, they may need chemotherapy, which is going to be toxic for the gonads, is going to be toxic for the ovaries, going to be toxic for the testes. So that's why we want to preserve fertility beforehand, before the girl or the boy goes into the chemotherapy or radiotherapy treatment. Then the genetic problems like, you know, genetic syndromes, Turner's, Fragile X, all these are known to have declined fertility before time. So that's why fertility preservation is an answer in that case. And as Dr. Meenu just said, autoimmune diseases. Then there are conditions where the fertility reserve will go down before time, like in cases of severe endometriosis. So this awareness is very important. If the girl is completing her family on time, perfect. But because of some reason, if she is not able to, you know, kind of become pregnant, it may be any reason, it may be career, it may be not finding the right partner right now. So these are the patients, these are the girls who should know that fertility preservation can be an answer in those cases. And of course, social egg freezing, which we talk about so much, is age-related fertility decline. Then transgender individuals, this is again, you know, something which is very, very talked about these days, and some legal, ethical and social factors. So Dr. Pooja, can you just throw some light on this? What technological advancements do you think was a breakthrough in process of egg or sperm freezing? Because, you know, earlier we used to have slow freezing. So what is it which has really brought in a new light?
Yeah, basically slow freezing was a process in which there was a lot of ice crystal formation. The chances of embryo getting destroyed, I mean, was much higher. So we came up with vitrification technique, which is again a fast freezing, where the crystal formations are very less, there is less damage to the embryos or the oocytes. So vitrification is the best advancement which has come up, and which is really good. And definitely it helps in getting a good revival rate basically.
And this miotic spindle, miotic spindle.
Yes, right. So for my audience, so many of them are already IVF specialists sitting here, so they don't need this to be re-emphasized. But for people who don't know about freezing, social egg freezing and all those things, so there is something called as vitrification, which is now not new anymore. It's been years since when vitrification has come into IVF labs, and this is a technology which leads to, you know, a sharp drop in the temperature. If you look at this graph, the blue one shows vitrification. The temperature drops to minus 190 degrees Celsius over seconds. So that's why there is no ice crystal formation, and there is something called as meiotic spindle inside the eggs, which is very well maintained when we vitrify the eggs. So since when vitrification has come, it's like a boon in the field of IVF, and you know, the labs are doing much, much better as far as egg freezing is concerned. So Dr. Rimi, when we say biological clock of women, so what does it exactly mean?
Basically, if we'll talk about the social egg freezing, the girls, if they really want to freeze their eggs, ideal age is below 35. Around 30, 32, they can, freeze their eggs. And biological clock, everyone is saying like with age and with aging, our ovarian reserve is definitely going to decrease. So as per biological clock, as soon as girl is aware, she should get her freezing done.
So what is biological clock? Biological clock refers to natural decline in fertility with age, particularly the decreasing quantity and quality. So this knowledge is something, you know, which we give to our girls who are coming to our OPDs, that they should either produce kids in time or they should think of freezing their fertility. My slide is not moving somewhere. Yeah, so let's take this case scenario. Dr. Meenu? Yeah, so we have Miss X, who is 34 years, she's an entrepreneur, doesn't want to marry, career-oriented goals, determined that she is not going to marry in next 4 to 6 years, but apprehensive that she may have difficulty conceiving in few years. So she's coming to you. So what is your answer, your take on this case?
So,
or in other words,
yeah.
what are the various fertility preservation options in unmarried girls?
Absolutely.
So and what is the ideal age?
So this is a very important, this is a time when we are doing a social egg freezing, and this is one of the social causes where egg freezing can be taken into account. And as we just said, that biological clock, basically for females, we are born with set number of eggs. Eggs are the cells which are never produced in the body. So after 35, as we just mentioned, that there's going to be a sharp decline in the number as well as the quality of the eggs. So yes, social egg freezing, if she's desirous, she should be freezing, she can take that option, I would say, to freeze the eggs. The sooner the better, less than 35 years, she should be doing the egg freezing. But yes, at least counseling with your fertility specialist, checking your fertility tests, and then taking a very informed decisions. I think right now what we are facing, all of us, is all the Gen Zs, who are so much reading about egg freezing. I think less than 30, 31 years, they are coming in, walking in the clinics and saying we would like to freeze the eggs or the embryos. They don't have, that kind of a stigma. But these are the people that we are trying to tell them, okay, hold on, you need to wait. But 30, 35 are the people where they really need the counselings, and yes, they can take this thing. So ideal age would be less than 35. That would be
right. So at the same time, being fertility specialist and being gynecologist, this is our moral responsibility to explain this to our girls, that it is not a blanket statement for all. Like we should motivate our girls to become, complete their families on time. But if that option is not existing, in spite of your good counseling, the situation is like that, then ideally freezing of gametes should happen at right age. That is very important. And why it is preferred at younger ages? Because as the age advances, all of us know the risk of chromosomal problems, genetic problems, that sharply rises. Risk of Down syndromes, if you look at 45 years of age, it can be as high as 1 in 20. Then similarly, the chances of miscarriages in older eggs is more. So if a girl is freezing her eggs at 32 and she's coming to use them at 40, that egg is as good as an egg of mother at age of 32. Similarly, the risk of stillborns and all is higher when the egg is of higher age. So that's why it's so important to freeze the eggs on time if you are wanting to do so. So Dr. Rimni, can you take up this one? So when a girl is coming to your OPD and she's asking for, ma'am, how many eggs should I be freezing? If she's 30, she's 32, 35. So what is your number you are going to give to that patient?
Yeah, first we have to take her like AFC count by doing one ultrasound, and second is the AMH level. But I would say, as per our guidelines, minimum number of eggs should be around 12 to 15 eggs. I think she should be able to freeze her eggs for her further on pregnancy.
Right. So what we need to understand is, as the age is advancing, the number of eggs, oocytes we will be needing to give one live birth is going to increase. If you look at this paper by ASRM, that says that if you want 70 to 80% chance of a single live birth, then you have to freeze at least 15 to 20 metaphase 2 oocytes in that girl if she's less than 38 years, and the number can be as high as 25 to 30 between age of 38 to 40, if you are you have a goal of giving a live birth up to success rate of 65 to 70%. This is a good success rate, isn't it? So if we want to achieve this success rate later at 40 years of age, or when she's freezing at 32, you should have around 10 to 12 minimum, 15 eggs at 35 and so on. So these, these papers have concluded after so many researches. We just can't say that we have frozen 3-4 eggs and you are good to go. So that number is also to be taken in consideration. So what is the implication? Implication is that particular lady, that particular girl may need more than one cycle of egg pickup to reach at that number, right? So that is also equally important. So
and for that, like many girls, if you are doing a counseling for that girl, if we will not be able to get as much as eggs, and she's definitely, and she's eager, no ma'am, mere ko to freeze karane, and she's ready for the next cycle also for ovarian stimulation.
Yeah, your counseling has to be like
because
that.
Counseling is must when we are taking up for ovarian stimulation ke hame kitne eggs milenge, we don't know. But still we have to do a counseling.
And at the same time, I think the counseling for just not the eggs, but we are looking at M2s. We need to really tell them that we are looking for matured eggs.
M2 kitne milenge usme se, that we need to.
Absolutely. So what we conclude is, if the lady is sure she has to preserve fertility, earlier the better. We can always look at ovarian reserve by looking at AMH, which is blood test, blood marker, and antral follicle count, which is seen on ultrasound. And roughly by that ASRM paper, we can say between 30 to 32 years of age, 10 to 12 eggs, between 35, around 35, around 15 to 20 eggs, but at 40, you will need around 25 to 30 eggs if you are looking at around 70% chances of giving a live birth to that girl. Now the question comes, when the girl is coming to freeze her eggs, she will have this question, am I, good? Will it give me at par success rate as compared to if I'm becoming pregnant at that time? So, Dr. Pooja, can you take up this one? So, we have ample data which says...
See, the thing is, first of all, a thorough counseling of the girl is very, very important. As rightly said, age really matters. See, I had a girl of 46 years of age who came to me the other day saying that she had to freeze her eggs. I tried to counsel her. She's like, at least एक भी मिल जाएगा तो भी आप कर लो pick up. It's so difficult to explain it to them. Like the chances of getting a good embryo is very, very hard in these patients. So it's the counseling part plays a very, very major role. So basically the number of eggs really matter at an elderly age group. What was your question?
So, yeah.
Like thawing rate, we have to counsel her. Like what will be the thawing rate, like percentage? Like around 60 to 70% is thawing rate.
Yes, absolutely. So if provided your lab is good, your vitrification program is good, the lab in which you are going to freeze your legs with a good vitrification program, the thawing success rate are quite good and are comparable to using the fresh eggs.
I think also one of the reasons where younger patients, when you freeze a better quality, better number of eggs, will definitely be at much better position than when you are trying to conceive at a later stage.
Absolutely.
But even now we say that embryo freezing is better than egg freezing. So comparatively. Always we say that to the patient.
Unmarried.
This is an unmarried girl, definitely, but otherwise I'm saying, definitely.
So now, is the procedure different than IVF or is it same? So just in 2 lines, can you just...
Till the time the egg reaches the lab, it's the same. Of course, later on the procedure changes. The procedure is very simple. It's a painless procedure. We have to give injections for 10 to 12 days. There are no cuts involved. Actually, that's how we counsel the patient. The pickup is done through ultrasound TVS guided. So it's quite a simple procedure.
And on the same day, the girl is going to know how many mature metaphase eggs she has got. So now this girl gets married, she comes with her partner, then what is the next step, Dr. Meenu?
So when we have done an egg freezing for a woman for this particular case, then definitely as per the law, she has a husband, so the husband's semen analysis would be done. And then they'll proceed for the ICSI or the IVF procedure depending upon what's the count of what is the semen analysis. And yes, once the embryos are made, then they can be transferred back. So that's an IVF procedure where they'll have to.
I would like to say normally for a oocyte, frozen oocytes, we do only ICSI.
Yeah, because they
we
are
would not,
denuded, so you have to go for ICSI.
ICSI only,
You make
yeah.
a beautiful blastocyst and you put it in our uterus, and we are waiting for the results in 14 days, 10 to 14 days. The beta HCG is awaited. How much more time? Okay. So yeah, as Dr. Meenu said or Dr. Pooja mentioned that freezing embryos is any day better, but when it is about the couple who are coming to preserve their fertility, always be cautious about counseling or taking the girl in confidence and asking about any marital discord disharmony, because if it's an embryo, then she is not able to use it later when she comes, if she is divorced by that time, because on embryo it's equal right of both the partners. So this we have to keep in mind.
But if one of the couple dies, so we have a consent in ART nowadays that the other person can claim if the consent is pre-hand consent is taken.
So I'm talking about the divorce.
Divorce. Yes.
Dr. Sunita, I just want to mention a very interesting couple. They were a Japanese couple who just recently came to me, and they were undergoing a simple ovulation induction or an IUI procedure. But on the history, the girl has already frozen her eggs in Japan. And after a while, after 3 unsuccessful IUIs, so I was telling, why don't you go back and use, because you're 37, you've frozen the eggs at 32. And trust me, the answer really blew my mind. She said, no, they are my eggs. I would like to, see what I want to do with them. So she wasn't ready to inseminate with her husband the sperms, but she was wanting to keep it as her indemnity or an insurance for the future use. So that was like another eye-opener for me.
Yeah, those
That's
eggs
a
would
true
be
banking,
indemnity.
So coming to the legality, for how many years you can preserve it? Dr.
Till
Rimi,
10
we are
years.
short of
10
time,
years.
So,
Yeah.
So by law, you can save the gametes for 10 years, but if you
can
have to
take a
save for
consent.
later use also, then you have to inform appropriate authorities, and you can do that. So do men also have a biological clock?
Yes.
Anybody?
Yeah, definitely.
So are we worried when the men's age is maybe more than
45?
45
yes.
and
So yes, some genetic disorders are linked to increased paternal age as well, like neurodevelopmental disorder, autism, schizophrenia, even genetic disorders like achondroplasia, Apert syndrome, childhood cancers, lymphoblastic leukemia, even neurofibromatosis and Marfan's, they are linked to increased paternal
and the
age.
risk of autism also. We had
yeah,
Dr. Patki's
yeah.
talk, Chandigarh.
yes,
yeah,
absolutely.
the risk of autism.
We need to tell them that
Paternal
even
age.
learning disabilities are very, very common.
And we know that men can also save their fertility. The answer is simple. Semen sample can be saved, preserved. But if they are coming to at 38, then you should tell them that it is only after 45 that these kind of problems may happen, and you can give them that option. And in case the sperms are not there in the semen sample, then TISA and microtesy done for any reason, these tissues can be cryopreserved too. So if we look at ART law 2021, gametes can be frozen for 10 years. If need to be frozen for longer, you have to inform appropriate government authorities. If unmarried women wants to become single mother later on, is it permissible as per law? Yes, but single fathers are not permissible. So if anybody is not aware of this, please be aware. So this we have just taken. So what is this? These are the last 2 slides with me. What is oncofertility in just one sentence?
Fertility preservation for patients who are undergoing cancer treatments. It can be for both male and female. So that is
So oncofertility, why we have started talking about so much about oncofertility is because the treatments for cancers are so advanced now. So the cure rate is increased. So that's why when the girl is in remission phase, she is absolutely cured of cancer. She will be looking ahead for getting pregnant and completing her family. So 5-year survivals for cancers have markedly improved over the last few decades. And what are the various options? If it is post-pubertal male or female, you can preserve their eggs and sperms respectively. If it is pre-pubertal, then cryopreservation of testicular tissue in males and cryopreservation of ovarian tissue in females can be done. So this is, I think, as short as possible we have done for the panel. So once in remission phase, women will have the willingness to conceive. That's why we should talk about oncofertility. Being gynecologists dealing with cancers in gynecology, it is our duty to explain them that they can preserve their fertility. So once again, a very happy World IVF Day to all, and thank you so much for your kind patience.
Thank you to the panel for this interesting conversation. May I please invite Nenika from IHW to felicitate our guests. Can we please keep the applause going for our wonderful panelists?
Yes.
Thank you, everybody. We now move into a crucial knowledge sharing segment that goes beyond data and enters the space of clinical collaboration, real world evidence, and forward looking science. It's time for the official white paper presentation by JB Pharma, a research led initiative on an emerging area of interest in fertility care: probiotics in IVF. As IVF science evolves, the role of the microbiome and gut health linked interventions has moved from theory to serious clinical conversation. Probiotics are now being examined not just as supplements, but as potential modulators of reproductive outcomes, endometrial receptivity, inflammation control, and overall IVF success. This white paper captures expert consensus, evolving evidence, and the path ahead, and is being presented today by a panel of leaders who've contributed to and curated this important. Dr. Anupama Chopra, Medical Director, Chawla Embryo IVF and Chairperson, ISAR Punjab. Dr. Purnima Durga, Chief Fertility Consultant at Mom IVF and Joint Secretary of OGSH. Dr. Ekta Bajaj, Senior Consultant and Head of Department. In the order, ma'am, I'm just going in the right order. Yes. Dr. Ekta Bajaj, Senior Consultant and HOD, Obs and Gynecology, Ujala Cygnus Group of Hospitals, and Dr. Jyoti Malik, Director, Roots IVF and JJ Institute of Medical Sciences, Chairperson, ISAR, Haryana. Please join me in welcoming our distinguished presenters as they share findings, insights, and clinical reflections from the JB Pharma white paper on probiotics in IVF. Let the conversation begin.
So, good evening, everyone. Thank you, IHW, for giving me this opportunity to moderate this panel. We have excellent panelists here. We know probiotics are first introduced in 20th century. Pro is promoting biotized life. So that's about probiotics. Probiotics are everywhere now. So actually, I have a privilege to be there in the meeting where we have developed that consensus in Hyderabad, happened to be my hometown, where we have developed the consensus about probiotics in RPL, or recurrent implantation failure, and in gynec disorders. So I was there with Patki sir in that consensus meeting where we have come up with very good consensus. So, so I think that we have a time constraint. So first, sir, Patki sir, see, RPL has many causes. We know there are so many causes for RPL. What makes the microbiome, especially the lactobacilli, such a compelling factor to target with probiotics? Why? Why we need to add probiotics?
Thank you very much. Just to give you all a little prelude on this, as she very rightly said, we did a master class on probiotics in ISAR, and then we were fortunate to have 3 publications in Curious on this, on 3 different aspects. And I think then this led us to come with a white paper which we'll discuss today. So coming on to recurrent pregnancy loss, we know that there are the major reasons that we have been investigating, mainly anatomical, genetic, inflammatory, or hormonal, or metabolic, and autoimmune. But despite doing all these extensive tests, in most patients, quite often we do not find the cause, and that is where the use of probiotics comes. And how does probiotics works? There is something called as prebiotics and probiotics. So probiotics are the ones which help us to improve the hormonal milieu. Now, when you have patients with recurrent pregnancy loss, it is basically where the pH of the vagina, cervix, and the endometrium should be high. When the pH comes down because of lack of good lactobacilli, you get subclinical endometritis, you get cervicitis, you also get vaginal infections, and you can get recurrent UTI in these patients. And that is what causes inflammation, cervical incompetence, and then you land up with having either a missed abortion in patients of endometritis, or you have an incompetent os-like situation where the patient bleeds and has. So when you want to balance the hormonal milieu, you have to give them supplements of lactobacilli. Now, much to my surprise, there are various different lactobacilli, and you have to give the right combination of lactobacilli, and they found that it is lactobacilli rhamnosus, crisp platinum, and lactobacilli bifidus, which are most important in RPL, because these are lactobacilli which take care of the milieu in the vagina, in the cervix. We also need to understand that when patients get recurrent UTI, we put them on antibiotics. But quite often it is not infection, it is inflammation. And when you combine it with probiotics, you get a better hormone.
Basically what we say is a leaking gut. We say that gut is the second brain. And when the gut is leaking, then it can cause RPL, it can cause RIF, and it can cause any kind of inflammation anywhere in the body. So the urinary genital tract is actually a linked thing. So we have to take care of our gut, and that too with the probiotics to help us in relieving the patients with RIF or with UTIs.
Yes, rightly said, ma'am. For you, as sir said that lactobacillus strains are also very important. We know that vaginal microbiome is 99% is with lactobacilli, but not so with the endometrium. So we know. So is there any, can you clarify about it further, and can you tell us how crucial for this in RPL?
Yeah, for RPL, if we talk about microbiome dysbiosis, vaginal and endometrial, both are important and both are actually interrelated. I hope you can use. Yeah, both are actually interrelated, and the only difference is Vaginal dysbiosis, it is very easy to diagnose and easy to treat. Exactly. But in RPL cases, there is low-grade inflammation, and you can say about 40% of the patients, they have low-grade inflammation and endometritis, but we are not routinely testing for endometrial or for vaginal dysbiosis. But there is very strong evidence if we add probiotics with the treatment, it really helps to prevent RPL and RIF as well.
Okay. Actually, probiotics are anti-inflammatory. They reduce inflammation and they improve the pH. They help in building up removing the biofilm, producing H2O2. So all these things, they are in fact reducing the infections. So they are and helping the implantation. If the vaginal pH is good, the endometrial pH is good, both the microbiota of the endometrium and vagina is good, then definitely the chances of implantation, they improve.
So it is difficult. It is easy to take a vaginal swab if you have a vaginal dysbiosis, but to take a endometrial biopsy is difficult because it can get contaminated, one, and the number of microbiota that are there in the endometrium is almost only 1/10 of what is present in the vagina. So what report you get also may be very misleading. So that's why to diagnose endometritis is not easy.
It becomes invasive as well to diagnose when we are diagnosing the endometrium. Vaginal taking swab is very easy, non-invasive that way.
So yes, ma'am. Yes, very well said. And ma'am, Anupam ma'am, can you enlighten us about the probiotic strains, as sir said? So vagina and endometrial bioma, is there any different based on your consensus review?
When it comes to PCOS, there are many. You have to see the CFU of that particular preparation of the probiotic, because every probiotic, there are different for the, as the sir said, that lactobacillus bifidus and crispatus, they are very helpful in vaginal infections. For PCOS, there has to be more than 100 CFU for a strain to help the patient reducing the inflammation.
When you get probiotics, as she said, it has to be more than 10 CFU per dose. That is important. You also need to make, because these are live bacilli, so you have to ensure that it is heat resistant. Yes. Because otherwise, if a cold chain is necessary, because the probiotics that we got initially needed a cold chain. So if you didn't keep them in the cold chain, they would not work. Also, they should be resistant to the acidic in the stomach. So it is important that what probiotics you use are acid and heat resistant, and the minimum dose is 10 million CFU per dose that you would offer the patient.
Basically, the probiotic has to be safe to the host, and it has to be stable. It should adhere to the gut, should be resistant to the peristalsis, so that it should stay and work, and it should help in making the microorganisms helpful for the patient. So they are good bacteria.
Ma'am, is there any difference between the oral route and the vaginal route?
See, obviously, oral route, it is
what
the
do you
gut.
prefer? Which route do you prefer?
It is always better to, oral route is much better.
Any other panelists want to add which route? This is my patients who are integrating into RPL treatment. Anybody can take the question.
See, it is very low risk adjunct, so there is no harm in giving, and research also suggests there are, if microbiome are less than, they are less lactobacilli dominant, there are high chances of RIF, RPL. So if it is a very safe medication, and we should give, ideally we should start 1 to 3 months before conceiving or before embryo transfer, and it should be continued in early pregnancy as well to prevent early pregnancy miscarriages.
Actually, it has been already proven beyond doubt. It had been used for bacterial vaginosis. Yes. And for recurrent cases of vaginitis, vaginal discharge, where we have given so many antibiotics, we have done everything, and still it does not heal, then probiotic are something which will make that pH okay and take care of that. Non-specific infections.
I also give it in perimenopausal women who come with UTI, and in addition to putting them on estrogen creams, when you add the probiotics, you find that the patients respond much better. So I not only give it to women for fertility, but I also give it in gynec, particularly when there is recurrent UTIs, it's urea plasma uticum, or in BV, bacterial vaginosis, or in menopausal patients when you see that the vaginal atrophy is there. I think you combine it with your hormone treatment and it works wonders.
Yeah, exactly.
Actually, at extremes of age, we don't have enough glycogen, and that glycogen is not being converted into lactic acid. So we need enough lactic acid. We can even advise patient taking lot of curd, because that also promotes lactobacilli. So that is another way apart from this, because that curd is also a probiotic. So one can always suggest to these patients, whoever
the difference between fertile and infertile women who are not conceiving is actually lactobacillus. So many people, they were trying to shift the lactobacillus from a fertile women to infertile, but then there were
there has been a study in Scandinavian countries where they have taken cervical mucus of fertile women and implanted in these women with recurrent implantation failure, and they have found that their implantation rates have gone high. So
transplantation
it is absolutely like the lactobacilli. So when you have such probiotics in the market, I think this is more ethical and more better way of increasing the lactobacilli strength.
So all the panelists, RPL, so we are adding probiotics. So all of you agree with it? Yeah. So it's a drug which we are going RIF. Okay. We are coming to RIF later, but RPL, so we have to give some message to the audience. So RPL, you are adding, we are going to add probiotics to improve the pregnancy rate. So Patki sir, your paper, actually you already spoke about it. So spans multiple conditions, as you already said, bacterial vaginosis, UTI, PCOS, vulvovaginal candidiasis, endometriosis. Yeah. So what unites them under the probiotic approach, like?
Obesity, PCOS, endometriosis, all have an autoimmune angle to them. And this use of probiotics helps them because there is underlying inflammatory conditions in all of them. Be it obesity, you have an inflammatory conditions. Endometriosis, you have an underlying inflammatory. So when you give probiotics, the inflammation comes down. When you add probiotics, you increase short chain fatty acids, which are known as immunomodulators, and they enhance the immune system, and that is why you get better implantation rates, and that is where it helps you in RIF also.
Yes, sir. So probiotics are in every condition. It is when I read about probiotics, I have read a paper where I have seen the probiotics can be given in cancer patients as well. So they have a role, specific strain of probiotics in each condition.
Actually,
exactly,
PCOS,
that specific strain we have to give in definitely. Not a
RPL,
common.
RPL, RIF, GSM, UTIs, all these we knew. But PCOS is something which is a new concept. That
is the new thing which has come up.
Endometriosis, you said, that is one of the new things.
Chronic inflammation. But in PCOS, basically it is the metabolic effects of the probiotic which we are using, because it helps in reducing the insulin resistance in these patients, the same as it works in obese patients. So that is the basis of using probiotics in PCOS.
Okay. So that's the next question. Let's talk about PCOS. How exactly do probiotics help in a condition? We already answered that question. So ma'am, for bacterial vaginosis, how do probiotics compared to antibiotic treatment helps in preventing the recurrence and resistance?
See, antibiotics, they cure acute infections. But bacterial vaginosis, it is recurrent in nature, and when we add prebiotics with antibiotics, so recurrence rate is low. So it's always better to add prebiotics with antibiotics to cure bacterial vaginosis.
Yeah. So vaginosis is by definition lack of
dysbiosis.
lactobacilli.
It's not
giving lactobacilli is the answer.
It's a dysbiosis. Yeah, exactly. Very well said. So, ma'am, how can clinician decide which strain to use? That's a very important question, right? So we don't. There different companies come with different strains. They say. So what are the meaning when you are prescribing a drug? what we have to look behind the strip. We
has
don't
to
look
be
behind the strip, doctor.
Yeah,
So
we should see which particular lactobacilli is there in that particular formulation. So as sir said, I mean for GSM it is different.
For example, can you give
vaginosis,
some
it is
example?
different.
Like
You have rhabdomyos and you try these
So
terms
it
are
is
very, very different.
Lactobacillus rhamnosus, it is Lactobacillus salivarilis, it is Lactobacillus bifidus, and Lactobacillus crisplatinus.
so these
So
four,
these are 4, 5
thing
which
we
are
have to look for.
important. You have to look for them. More important is that the strength that they provide you, it has to be 10 million CFUs per dose. If you get anything less than that, then it is not going to be as effective. Also look to see whether they are heat and acid resistant. Otherwise, you have to maintain them in a cold chain.
So very clear message, the 4 strains and the minimum dosage. 10 million. And you have to, okay. So Patki sir, again the question to you. Why is RAF such a persistent challenge in ART? How do probiotics fit in this narrative?
RIF is a very frustrating thing because there are various causes. You try and investigate them, and often you would investigate the patient for RIF after 1 or 2 failures. So that makes it very frustrating for the patient, even if you find the cause, because then they say, why didn't you look for this in the beginning? Not understanding that RIF happens only in 10% of patients. So if you do these investigations in all, 90% would be waste of the test and the resources. Having said that, in most patients you really do not find the cause, and that's why in RIF you can do right from use only frozen embryos, PGTA, endometrial scratchings to intralipids to PRPs to whatever, because in frustration for you and the patient you try and use everything. But maybe these probiotics is a very low cost, not harmful, not invasive. When you are investigating the patient, maybe you can start them on these probiotics.
Are there any papers which support this, like especially in RAF
My
cases?
paper, our paper which
that's what I wanted.
supports
So,
the use of
all you
probiotics in RAF.
Oh, yes, so that's it.
I think I would like to emphasize that we should give it for at least 2 to 3 months prior to our procedure. As sir suggested, whenever we have started to investigate that patient, let us start all these vitamin D, folic acid and probiotics same very time, so that we have enough time for them to act.
So, ma'am, link between chronic endometritis, dysbiosis and IVF failure.
Link between chronic endometritis.
We'll give to
yeah, please tell me.
elaborate the link between endometriosis, endometritis, dysbiosis and IVF failure. Chronic endometritis.
See, basic denominator is the same here, like microbiome, dysbiosis, and everything is like here. There is immunity related. If you talk about endometriosis, endometritis again, it affects, it's going to affect implantation, and when there are less lactobacilli. So all these things are going to cause RIF.
Okay. Ma'am, last question, when to start probiotics? Before, during, after IVF procedure?
Much before, I said much.
Yeah. So
at
that's,
least
that's
3 months before.
Okay. Thank you so much, my dear panelists. It's a wonderful panel. So probiotics are there. So in our prescriptions from now on, after Patkis's paper, so we all going to add probiotics in our practice now.
Thank you so
yeah,
much.
Thank you so very much. Thank you,
moderating
thank you,
the
thank you.
panel.
Thank you so much for the insightful panel. May I please invite Nenika from IHW to kindly felicitate our guests.
Kamill, we would like you to join.
Thank you so much. Thank you, everybody. We now turn to something more introspective, more subtle, yet increasingly essential to fertility care: the role of stillness, breath, and inner alignment. Our keynote now invites us to step back and look inward. In the quest to advance modern reproductive technologies, have we left behind the role of the body's innate intelligence? Can ancient disciplines like Kumbhak yoga and breath regulation enhance reproductive health outcomes, not as a replacement, but as a complement to clinical protocols? We now have a video by Swami Sri Raj Vibhu, a globally respected Kumbhak yogi, wellness scientist and founder of Medini Fertility Care Private Limited, an institution rooted in the belief that ancient breath sciences can restore hormonal, psychological and energetic balance, particularly for those undergoing fertility challenges. Can we please have the video? Today, Swami Sri Raj Vibhu will share a powerful message on stillness, breath and fertility, integrating ancient wisdom into modern reproductive health. Can we please have a huge round of applause as we welcome him on stage?
Namaskar. My name is Swami Sri Raj Vibhu. And I'm also working in this ecosystem of fertility. अच्छा, कितने लोग यहाँ पे जो हैं उन्होंने ऑपरेशन सिंदूर को फॉलो किया? Has anybody followed ऑपरेशन सिंदूर? अच्छा, उसकी सबसे इम्पॉर्टेंट चीज़ क्या थी मालूम है? We used ब्रह्मोस better than रशिया. रशिया से बेटर हमने ब्रह्मोस को यूज़ किया. We used our defense umbrella better than Israel. और ये बात मैं आपको क्यों बता रहा हूँ? Because I want India practice of IVF to be better than any other place in the world. Can we achieve that? क्या उसको अचीव कर सकते हैं? How? What is the missing element in it? I'll just try to explore that missing element. अगर उसको आप लेके आ गए, then India practice of IVF can be much better than any other place in the world. So how? कैसे वो कर सकते हैं? So assisted reproductive ecosystem में आप जब assistance कहते हैं, when you say assistance, what does it mean? The body is somewhere disabled, isn't it? तभी आप assistant का use करेंगे. The body is becoming disabled. What does it mean? The fertility of the human body is going down day by day. And you know that. आपको मालूम है. So, reducing AMH count, endometriosis episodes, hormonal imbalances, PCOD cases, वो सब आपने देख लिया, है ना? So, my question is, on one hand, we are enhancing or improving the assistance. The missing part is, can we improve the AMH levels, hormonal levels, reduce the episodes of PCOD, thyroid? क्या ऐसा काम हम कर सकते हैं? If you do that, we can increase the efficiency of IVF from 2% to more than 60%. आप में से कितने लोग चाहेंगे ये? Number of IVF cycle can be reduced drastically. कितने लोग चाहेंगे? मेरे ख्याल से सभी चाहेंगे, क्योंकि in any scenario the fertility of this world will not go up soon. तो केसेस तो बढ़ने ही वाला है. But the reputation of conception, giving conception with less number of IVF will make us pioneers in the world. And that is what we have achieved. We can improve and increase the AMH count of, in our program, it gets increased in most of the women. Probably we are the only program which focuses on increasing the AMH count. We have seen even the genetic defect, chromosomal defect, can be corrected, and we have proof for that. Human genome, which has got deviated in the last 100 years, even the modern research says 99% of our genetics can be changed, which we call as nowadays epigenetics. तो क्या क्रोमोसोमल डिफेक्ट को ठीक करने का हमारे पास तरीका है? What do you say when you find a chromosomal defect? हम ठीक कर सकते हैं. We can do that. Can we stop the reason for PCOD, endometriosis? Can we reverse the reason for that? And that is what we have achieved. Can we improve the conception probability of females who are more than 40 years? We have been able to help a lady conceive at 52. Can we improve the chances of conception in cancer patients? There is a patient who came to us who was going through chemotherapy in January. She joined the program in April. Now she has conceived without assistance. With such wonderful result, if we collaborate with the assisted reproductive ecosystem, our practice of IVF can become pioneer and best in the world. But then we'll have to open up the horizon of our thought process. क्योंकि आप सोचते हैं जिस तरीके से, उसको थोड़ा सा अगर हम फैलाव दे दें, we can become pioneers. And ultimately, what is our goal? To help human beings, to make human beings more fertile, to give this happiness of conception or reproduction to the humankind. यही तो है आखिरकार. So why we are not able to come to a certain point of agreement where with a little effort, just this missing part, if we fix this missing part, empowering human body, because human body is supposed to produce those hormones, isn't it? AMH count तो human body बढ़ाता है, उसकी जिम्मेदारी है. अगर इसको हम कर दें सही, we can become pioneers. And the time has come. डॉलर की वैल्यू खत्म हो रही है और इंडिया will rise, but then with its own thought process. कोई बाहर का thought process, उधार में लिया thought process चलेगा नहीं. आपको open up करना पड़ेगा अपने आप को. Now, I'll introduce Kumbhak. What is it? So we'll do some experiment. And these are practical experiments which will help you to understand what is Kumbhak and how it can help the human being increase the fertility quotient. So, I'll explain Kumbhak in few ways. First, let us see how do we make effort. Let us see how do we make effort. So just clasp your fingers. सभी करें ना तो सबको समझ में आ जाएगा. You just clasp your fingers and try to pull hard. बहुत जोर से खींचेंगे, और जोर से, और जोर से, और जोर से. How you pulling? How are you pulling? ये pulling का effort जो लग रहा है वो आप लगा कैसे रहे हैं? Because most of you are from a doctor's fraternity, आप एक तरीके से सोचते हैं. So आप सोच रहे होंगे muscles, nervous system, some people might be thinking mind and what not. But you are missing a point. ये point क्या miss कर रहे हैं? Let's do it again. And wherever I'm indicating, just look there. आप दोबारा से करें and try to pull hard. Now put all your effort. Try to pull hard. Are you holding your breath? The more you try to pull hard, the harder you try to pull, the more you will have to hold your breath, isn't it? And can we see it in another experiment? Just try to push and push hard. You again hold your breath. How do you lift weight? Weight कैसे आप उठाते हैं? You hold your breath and lift weight, isn't it? So walking, jogging, yoga, Zumba, aerobics, whatever you do, whatever action you do, how do you do that action? Singing, dancing, climbing staircases, how do you do that action? Any kind of action has a breath hold factor behind. Without breath hold, you cannot do any action. So, breath hold is the dynamic mechanics of life. इसको दो तीन तरीके से मैं आपको समझाऊंगा, and it is not very difficult to understand. The only thing is, it is not exoteric, it is esoteric. You'll have to look inwards. So without breath hold, you can't do any action. Now it also correlates with your organs. What we have found, and we do a lot of Kumbhak programs, and what we have found, that it improves the organ function. And that is why we have been able to achieve medicine-free life for people who are into heart disease, blood pressure, thyroid condition, diabetes, neuromusculoskeletal problems, and infertility. And our achievements are all on reports. So somebody asked outside, how do you make people believe? I don't. The reports do. The results do. Now, another way of looking at Kumbhak. According to the law of physics, there are two factors which is running the whole universe: pressure and temperature. Without pressure and temperature, nothing works. So pressure, also creates temperature. Let's understand, a cloud has to move from one place to another. It will move in a pressure gradient from high pressure to low pressure. Water has to move upwards in a tree. It will go up in a pressure gradient from high pressure to low pressure. Anything in the body has to move. Even hormones has to be released. It will release in a pressure ecosystem. Every organ functions in a pressure ecosystem. Unexplained in infertility, you know. What is unexplained in that? The pressure ecosystem is not okay, and you don't have any way to measure it. So, everything, any dynamic activity in the world happens in a pressure gradient. Pressure also creates higher temperature. That's why if you go up, pressure is low, temperature is low. Go down, pressure is high, temperature is high. In Ayurveda, this pressure is called as Vata. You must have heard about Vata, Pitta, Kapha. But even the Ayurvedic ecosystem has lost this aspect over the ages. This pressure is called as Vata, which is the king of Ayurveda. So, if the pressure ecosystem is not okay, the thermal ecosystem of the body will not be okay. So, correcting the pressure ecosystem will correct the thermal ecosystem along, which is called as Pitta. The metabolic factor of the humankind, the metabolic diseases are increasing in the world. The Vata, Pitta, pressure, temperature actually helps material management in your body. If this two ecosystem is not okay, pressure ecosystem and temperature ecosystem, thermal ecosystem, it is not okay, material management will not be okay. If material management will not be okay, forget about fertility. And how to improve the material management? You improve the pressure ecosystem and the thermal ecosystem. How do you improve the pressure ecosystem of this body? By breath hold. You can't do it any other way. There is no other way. Can you improve metabolism? Yes. Can you reduce the rate of heart attack in the world? Yes. But then you'll have to introduce this, Kumbhak. You call it by any name. I have chosen to keep an ancient name to it because we already had this. Now there are experiments going on around the world. People are trying to live underwater in a pressure, and they found, and what do they found? And they find that within 100 days they can reduce their age by 10 years. That's what I have been saying. Kumbhak can actually reduce your biological age. 2 years of Kumbhak. I said 2 years, but experiments say in 100 days you can reduce 10 years. We have done the world's first experiment. We have done the world's first scientific experiment correlating Kumbhak with mitochondrial health. You know, every kind of function in your body has some correlation with mitochondria. Because mitochondria is the powerhouse of our body. It gives us the energy. Without energy, can anything happen in this body? Nothing. And you know, mitochondrial health has decreased over few decades. Now, I'm not trying to put down anybody. Give me one person who has come out of diabetes by reducing sugar level or taking medicine in the last 100 years. Give me one example. Diabetes is increasing in the world. Give me one example of a person who has come out of blood pressure, heart disease by taking medicine. So, I'm not saying those are not important, but those are reactive methodologies of treatment. when we can improve the ejection fraction, the heart rate, the rate of miscarriages, and that's what we have achieved. By doing Kumbhak, we can reduce the rate of miscarriages. The holding factor, heartbeat doesn't happen, and people come and do Kumbhak, and next time heartbeat happens. So even if we go for IVF, if we improve the efficiency of IVF or assisted reproduction, only then we are really helping the humanity. We are also becoming the pioneers in the world. We'll have to collaborate with that. We run program for preventing fertility also, Mirambika, just starting that program where we can enhance the fertility factor of people who go for marriage or conception at later stages of life. We run a program for conception where we have found these results, what I have just explained, by the name of Garbhadhana. We are doing program which can actually help prevent genetic disease from parents to the offsprings. We can prevent the genetic transfer. Do we need this at this point of time? Yes, very much we need that. So we run a program for that by the name of Ashtanga Garbha Sanskara. Now I've kept the ancient names because we already had those things, but I've created those methodologies and formulas. There is a lot to do. There is a lot of research that we are trying to do, but then a single person can't do everything. So if the whole ecosystem of fertility, they come together, all the stakeholders, if they come together, they collaborate and do research in a different way, in a different area, with a different thought process, we'll be able to help humanity for sure. And that is why I said we'll have to open up the horizon of thought process. So I'm just trying to take a little leverage of being a little harsh without introduction of Kumbhak and other ways of empowering this human body. There is no possible of improvement in the world. Fertility is going down. It will go down. Assistance will help to a certain level. Even if you try to preserve the embryo, the egg, AMH count you can't increase. What will be the use of those eggs? So we'll also have to look from that perspective. And let's expand our horizon of thought process and collaborate and work so that we can improve the fundamental fertility of humankind. Thank you.
Thank you so much. May I please invite Mr. Kamill Narayan to felicitate our speaker. Just allow us a moment, ladies and gentlemen. Ladies and gentlemen, you've been a super patient audience since today morning, very dedicatedly listening to all our conversations. And in the interest of time and also to respect all the time that you've given us, we're taking a segue and we're breaking into the awards as of now, post which we'll have our final session of the day, and I hope you will continue to be with us towards the end. It gives me great honor to welcome you to the most anticipated segment of the 6th India IVF Summit, the IVF Awards 2025. Tonight, we gather not just to present trophies, but to honor excellence, leadership, and impact in the world of fertility and reproductive care. These awards are a tribute to those who have transformed hope into reality for countless families through science, compassion, innovation, and relentless dedication. Over the past months, we invited nominations from across the country, from metropolitan centers to tier 2 cities and beyond, and the response was overwhelming. Each nomination was a story of commitment, of patients empowered, of clinical breakthroughs, and of human lives are touched. The evaluation process It seems that we might have to take a little minute of a break. Ladies and gentlemen, please continue to be patient with us. Okay, ladies and gentlemen, we're back and we're back for good. Before I begin, I know you guys have been a super patient audience. Can I please hear a cheer for the awards to come to just get the energy up in the room? This is the moment we've all worked very hard for, and I hope all the winners and all the participants are here today to celebrate with us. As I was saying, that the evaluation process for these awards was rigorous and detailed, guided by an independent jury panel of some of India's most respected public health experts, clinicians and researchers. They looked closely at measurable impact, innovation, scalability and quality of care. We extend our heartfelt gratitude to our jury for their time, discernment, and integrity in this process. And now, to do the honors, this evening we are joined by two visionary leaders whose contributions to health systems and policy in India are truly remarkable. Critical areas. With that, let us begin tonight's celebration of those who make miracle possible every day. Should we begin now? Are we good to start? Okay. Fantastic, ladies and gentlemen. We now begin with the first category for tonight, Regional Leadership in Fertility Awareness and Outreach. And the award goes to Dr. Anupama Chopra. Please join me in welcoming her on stage. Moving to the next category, Excellence in Embryology East. The winner is Dr. Antara Mukherjee. Please give it up for her, ladies and gentlemen. Is Dr. Antara here with us today? I think we can just cheer for her in spirit and give her a huge round of applause. Moving on to the award for Excellence in Reproductive Endocrinology, the winner is Dr. Rinki Balani. May I please have her on stage, ladies and gentlemen, and keep the applause going. Winning the award for Excellence in Clinical Gynecology Practice, the winner is Dr. Asima Patra. May we please give a huge round of applause for her. Winning the award for Regional Champion in Fertility Care Delhi, we have Dr. Bhavna Singla. Can we have a huge round of applause for her? Can we keep the applause going, ladies and gentlemen? Winning the award for Excellence in Fertility Counseling and Support, we have Dr. Deepika Jagga. May I please call her up on stage? Winning the award for National Excellence in Reproductive Endocrinology, the winner is Dr. Sunita Arora. Can we have a huge round of applause for her? Winning the award for excellence in andrology and male fertility management, we have Dr. Hitendra Somani. Next up, we have Excellence in Reproductive Ultrasound, and the award goes to Dr. Indrani Lod. Ladies and gentlemen, let's keep the applause going. Let's keep cheering on for our winners. Moving on to our next category, Leadership in Transformative Fertility Care. The winner is Dr. K.D. Nair. May we please have him on stage. Winning the award for Regional Excellence in Fertility Care North, the winner is Dr. Pooja Mehta. Winning the award for National Embryologist of the Year, the winner is Dr. Pranay Ghosh. Dr. Pranay, we might keep you with us for a little bit longer because the next award for excellence in fertility laparoscopy goes to Dr. Puneet Kochar, who couldn't be here with us today, but Dr. Ghosh will kindly receive his award. Can we please cheer for her in spirit? Winning the award for Regional Leadership in Fertility Advancement, the winner is Dr. Sagar Mane. Winning the award for Clinical Excellence in Reproductive Endocrinology, we have Dr. Sanjay Makwana. Next up, for excellence in obstetrics and IVF, the winner is Dr. Seema Bajaj. Ladies and gentlemen, let's let our applause reflect the full house of the room. Can we please be louder and cheer for all the winners? Next up, the award for the IVF champion of the region Bihar goes to Dr. Simi Kumari. Can we cheer for her, please? Next up, the award for excellence in fertility and reproductive medicine education. The winner is Dr. Rajat Ray. Next up, the award for outstanding provider in affordable ART services. The award goes to Dr. Vikram Singh Bhatti. Now, ladies and gentlemen, the Lifetime Achievement Award in Reproductive Science goes to Dr. Nalini Mahajan, and let the applause be as loud as her achievements. Next up, the award for Emerging Leader in Fertility and Reproductive Health goes to Dr. Soumya Prasad. Next up, the award for excellence in clinical IVF practice goes to Dr. Suyesha Khanijao. Can we please have a huge round of applause for her? Moving forward, the award for excellence in reproductive health outreach and patient education goes to Dr. Seema Pandey, ladies and gentlemen. believe we have a representative receiving Dr. Seema Pandey's award instead. Next up, the award for excellence in embryology goes to Dr. Sapna Tyagi. Next up, the award for excellence in reproductive endocrinology goes to Dr. Richa Singh. Let's keep the applause going, ladies and gentlemen. Next up, the award for Embryologist of the Year. The winner is Dr. Rakesh Samal. The award for excellence in patient-centric care in fertility goes to Dr. Shruti Mane. Can we have a huge round of applause as she joins us? Moving forward, we have the award for Regional Excellence in Fertility Counseling Bihar, and the award goes to Dr. Nidhi Singh. Can we please give it up for her? Moving forward, the award for leadership in reproductive medicine and ART innovation goes to Dr. Rishikesh Pai. Next up, the award for excellence in integrative fertility and women's wellness goes to Dr. Ekta Bajaj. Moving forward, we have the award for excellence in reproductive endocrinology and advanced IVF protocol, and the award goes to Dr. Haritha Menon. Moving forward, the award for excellence in male fertility treatment goes to Dr. Varun Shah. Can we please hear it for him, ladies and gentlemen? Moving forward, the award for excellence in embryology goes to Dr. Ram Prakash Chaudhary. Moving forward, ladies and gentlemen, the award for excellence in IVF practice goes to Dr. Anushka Madan. Winning the award for excellence in embryology, the winner is Mukesh Kumar. May we please give it up for him, ladies and gentlemen. Next up, the category for MedTech Excellence in Fertility, and the award goes to Maya Organics Private Limited. Can we please hear it up for the team? Next up, the award for innovation in insurance plans for fertility treatments. The winner is Safetree Insurance. Can we please give it up for the team? Ladies and gentlemen, moving forward, the award for Outstanding IVF Chain National Impact goes to Bloom IVF. May I please invite Dr. Ujaswini, CEO, and Dr. Rishikesh Pai, founder Bloom IVF, to receive the award. I would also like to invite Dr. Sunita Arora and Dr. Pooja Mehta to join us on the dais. Dr. Suesha, please kindly join us as well. Ladies and gentlemen, the next award is Pharmaceutical Excellence in Sustainable Healthcare, and the award goes to Gufic Biosciences Limited. Can we please give it up for them? Moving forward, the award for Best IVF Chain in North India goes to Gunjan IVF World. Can we please give it up for the team? Next up, the award for Outstanding Patient-Centric Care in Fertility. The award goes to Rainbow IVF. Can we please give it up for them? Since we've chaired for Rainbow IVF in spirit and they're not here with us right now, we move forward to the next category, which is IVF Business Catalyst of the Year National Excellence Award, and the award goes to Osphere IVF Services Private Limited. Can we please give it up for them, ladies and gentlemen? The next award goes to for the category of Outstanding IVF Clinic Standalone, and the award goes to Roots IVF. Can we please hear it for them? Next up, the award for Outstanding Affordable ART Provider goes to Yellow Fertility and IVF Center. Let's keep the applause going, ladies and gentlemen. Moving forward, the award for Outstanding Contribution to PCOS Awareness and Preventative Fertility goes to Mom IVF Fertility and Research Center. The award for Excellence in Natural Fertility and Holistic Reproductive Care goes to Medini Fertility Care Private Limited. Next up, the award for Emerging Leader in Regional Fertility Services Punjab goes to Radiance IVF. Can we please have a huge round of applause for the team? Next up, the award for Outstanding IVF Chain goes to Seeds of Innocence. Can we give it up for the team, please? Let's have a huge round of applause, people. You all have been an outstanding audience, supremely patient, and I promise we have a last few set of awards remaining. I would appreciate if we can keep the applause going and continue to energize all our winners and participants. The next award is in the category of Outstanding Patient Advocacy in Fertility, and the award goes to Lex Curium. To give away our final set of awards, may I please request Dr. Amit, President ISAR, to please join us on stage to give away the awards. The next category is Outstanding IVF Clinic Standalone, and the award goes to Dr. Lads Navjeevan Hospital Private Limited. Next up, the award for Outstanding IVF Brand Non-Metros, And the award goes to Myri Fertility and IVF Center. Let's keep the applause going, ladies and gentlemen. Next up, the award for excellence in affordable IVF with high success rates goes to Imprimis IVF and Fertility Center Private Limited. Can we have a huge round of applause for them? Next up, the award for entrepreneurial excellence in fertility care. The winner is Dr. Sarthak Bakshi. Can we please hear it for them, ladies and gentlemen? I think we have a representative from Dr. Sarthak Bakshi collecting the award today. Let's give it up for him in spirit. Next up, ladies and gentlemen, the award for leadership excellence in IVF and fertility services goes to Dr. Rita Bakshi. Can we please have her on stage? Next up, ladies and gentlemen, the award for Women's Health Champion in Reproductive Medicine goes to Dr. Meenu Handa. Next up, the award for excellence in IVF and fertility service goes to Dr. Vandana Hegde. Can we please clap for her as she joins us on stage? Gentlemen, two of our previous awardees weren't there with us at that time, but since they're here now, let's celebrate them. The award for excellence in embryology East goes to Dr. Antara Mukherjee. Can I please have her on stage? Last but most definitely not the least, we have the winner for excellence in reproductive ultrasound, and the winner is Dr. Indrani Lode. Can I please have her on stage? Can I please request all the winners from today's ceremony to join us on the stage for a group photograph? Everybody inside and all your friends who may be outside, could you please come up on stage for a group photograph, ladies and gentlemen? All the winners from outside and inside the auditorium, can I please have you all on stage for a group photograph of all the winners? We have enough space for all our lovely winners. Can we have all of you up on stage, please? For a happy picture and for all our winners, can we have 3 cheers? Hip hip! Thank you everyone for joining us for the 6th India IVF Summit and Awards. We now break for dinner. You've been a lovely audience. Thank you so much. This is your host Vaishnavi Kalia signing off. Have a great evening ahead.
May I also request the IHW team to come forward to the stage? IHW team members, please come to the stage. We can have a photograph for all the people who have done the good job. बुला लो.
Can we now have the hard workers behind today's event, the IHW team on stage please for a photograph. Everybody from IHW, can I please request you to join me on stage?